So, good afternoon, everyone. Hopefully, all of you are back. Let's begin with the next topic, and that is the important one as well, and that is nothing else but vascular surgery beta. Okay? Please let me know if the audio visuals are clear so I can just proceed. Chalo now. Let's start. Here we have a question beta which says we have a 57-year-old patient beta, 57-year-old patient who complains of intermittent claudication, and now there is pain at rest also beta in the lower limbs over the last 6 months. What is the most common cause? Now important is beta, सबसे पहले you have to remember here basically the cause is likely to be a case of gradual arterial obstruction. Now what do I mean by arterial obstruction? We know that means there is some kind of blockage inside the artery beta. That is what we are talking about. Okay. Now gradual means what? That this obstruction in the artery which is there beta, it is developed very slowly over a span of months or years together beta. This obstruction basically has developed inside the arteries. That is what is called as a gradual arterial obstruction. Now important is whenever arterial obstruction is going to develop, what will be the symptoms of the patient? We know beta, if an artery is blocked, obviously the part which is distal to the obstruction beta, okay, the part which is distal to the obstruction will not receive enough blood supply beta, and as it is not going to receive enough blood supply, that's the reason the patient will start experiencing the ischemic symptoms. What are these ischemic symptoms? Let's see them one by one. First of all beta, my patient, as he is not receiving enough blood supply, okay, for example, consider that his lower limb vessel is blocked beta. For example, if my patient's, I say, if my patient's femoral artery is blocked beta, obviously the part which is distal to the femoral artery, the leg of the patient, will not receive enough blood supply. That's the reason what will happen now. When my patient will start walking beta, see, when my patient is at rest basically, therefore at that time my patient has no pain, right? When my patient is basically resting, at that time there is no pain. But as soon as my patient starts walking beta, after walking a certain distance, my patient starts having pain in the legs. Why? Reason beta, as my patient starts walking, definitely what is going to happen? His leg muscles are going to contract, and as his leg muscles are contracting beta, due to that the demand of the muscles is more, and if the demand of the muscle is more beta, obviously this blocked artery will not be able to supply that demand, and that's the reason my patient will start experiencing pain. So please remember, initially beta, when the blockage has just started, the patient does not have any pain at rest. But as soon as the patient starts walking, after walking a certain distance beta, my patient experiences a cramping pain in the legs. This is classically called as intermittent claudication. Why we are calling it as intermittent? Reason beta, now when my patient is going to rest, the pain is going to disappear. Okay? So the pain only appears on exertion or only appears while the patient walks beta. Otherwise the pain is going to disappear. That is what is intermittent claudication. Later on what will happen beta, the blockage will increase further. As the blockage is going to increase further beta, definitely what is going to happen, now the nerves will also not receive enough blood supply, and as the nerves are also not receiving enough blood supply beta, the nerves will get irritated, and due to that my patient will start experiencing pain. So as these nerves will start getting damaged beta, my patient will have a constant pain in the leg. Okay, even at rest beta, my patient will have pain. The first was intermittent claudication. After that, now my patient is having rest pain beta. And as I've told you, rest pain is basically due to the damage to the nerves. And that's the reason it is also known as beta, the cry of dying nerves. Later on, definitely, my nerves, okay, will get completely damaged. And due to that, initially the patient will have decreased the sensations, that is called as paresthesia. Later on, when the nerves are completely gone, there will be no sensations beta felt. That is what is called as numbness. Apart from that, the skin is also not receiving enough blood supply. Therefore, when you touch the skin beta distal to the obstruction, you'll feel definitely coldness will be there, right? Next beta, obviously here that the area distal to the obstruction is not receiving blood supply, so it will undergo cyanosis. Okay, therefore you will be able to see color changes in the skin beta. Along with that, the patient may also have ulceration of the skin over there. So when my patient is going to have color changes in the skin along with ulceration beta, that is what is called as the stage of pre-gangrene beta. Okay, and later on when there is complete necrosis beta of that site, that is what is called as gangrene beta. These are the various stages when a patient has a gradual arterial obstruction. Okay, they're not going to develop all of a sudden but in one day. It is going to develop over a period of months or years together. Okay, so that is what is gradual arterial obstruction. Now when I say gradual arterial obstruction beta, do remember that if they ask you what is the most common cause, so yaad rakhna hai, the most common cause of a gradual arterial obstruction is going to be something called as atherosclerosis beta. Yes, we know that in atherosclerosis beta, the patient usually develops a blockage inside the vessels. Okay, so atherosclerosis followed by the second most common cause beta is known as Berger's disease. Yes, I intentionally call it as Berger's because beta Berger's, which is there, it is also a name of IgA nephropathy. So better to call it as Berger's disease so that we do not get confused. Okay, so yaad rakhna hai, the most common cause or the leading cause of gradual arterial obstruction has to be atherosclerosis followed by Berger's disease. Now please remember beta, if I talk about these conditions, they are definitely associated with important risk factors like, for example, beta obesity or hyperlipidemia or alcohol, smoking. Okay, all of these are going to be the risk factors beta, which are very commonly associated with both of these conditions. Now, how to differentiate basically atherosclerosis or Berger's disease, because both are actually going to cause blockage in the arteries beta, and that too slowly. That means a gradual arterial obstruction. So if I want to differentiate beta whether it is a case of athero or a Berger's disease, there are few important points to be remembered. And the first and the foremost important point has to be nothing else but age of the patient. Yes, atherosclerosis is going to be more common in patients who are more than 50 years of age beta. Who are more than 50 years of age, whereas Berger's disease, which is there beta, it is usually common in patients who are usually less than 50 years of age, that is younger patients beta. Right, yaad rakhna hai that atherosclerosis is more common in elderly patients more than 50. Berger's is more common in patients less than 50 beta. This was only the difference beta which has been given in a previous year question. Yes, they gave almost similar findings beta. Okay, and the only thing that they mentioned was the patient is definitely 55 years of age. The only difference that you had basically was the age, and in that question definitely you have to answer it as atherosclerosis therefore. Okay, next important, if they ask you the vessels beta, so please remember the vessels which are usually involved in patients of atherosclerosis bache are going to be the larger vessels of your body, large vessels. That means something like the abdominal aorta, the femoral artery, these kind of large vessels are generally involved beta in atherosclerosis. If I talk about the Berger's disease, so Berger's disease mein beta, please remember the more common type of vessels which are involved, you might have discussed this in pathology as well beta, it is a medium vessel vasculitis. It is definitely the medium or the small vessels which are commonly involved. Okay, so the medium or the small vessels which are commonly involved beta in a Berger's disease. Next is involvement beta. Involvement matlab understand, in atherosclerosis beta, the obstruction is going to start proximally and it will proceed distally beta. Okay, the obstruction in atherosclerosis is proximal to distal, from larger to the smaller vessels. But in Berger's disease beta, it is completely opposite. The obstruction starts from the smaller vessels of the body beta and then goes towards the larger vessels. That means it is distal to proximal beta. Okay, so in atherosclerosis beta, the obstruction or the involvement which is there, it is going to be proximal to distal. Whereas if I talk about the Berger's disease beta, in Berger's disease, the involvement or the obstruction which is there beta, it is going to be distal to proximal. Right, that has to be remembered. If they ask you what is the most common site, so please remember beta, the most common site for both the conditions, is it the upper limbs or the lower limbs? So yaad rakhna beta, the most common site for both the conditions is going to be same beta, whether it is the atherosclerosis or it is a case of Berger's disease. Dono ke liye the most common site has to be the lower limbs of the patient beta. Lower limbs are going to be considered as the most common site in both the conditions. Okay, very good, that has to be remembered. Now, if I talk about the first cause of gradual arterial obstruction, bache, and that first cause is nothing else but atherosclerosis. Now, when I talk about atherosclerosis beta, I hope all of you are quite aware, you have discussed it in pathology, that whenever there is any kind of endothelial injury or there is irritation to the endothelium, there is platelets beta which come, then there are foam cells, then there is a calcification, that is fatty streaks will develop, and that will lead to development of a complete atherosclerotic plaque. And this atherosclerotic plaque is basically causing obstruction inside the arteries of the patient beta. Okay, so initially when the blockage is going to begin beta, we know definitely the patient is going to have a cramping pain on walking only beta. When the patient is at rest, there is no pain, but there is a cramping pain on walking a certain distance beta. But as soon as the patient takes rest beta, the pain is going to disappear. Okay, so cramping pain on walking, but the pain disappears at rest is classically a case of, we know it is known as intermittent claudication beta. So the earliest feature in a gradual arterial obstruction has to be something called as intermittent claudication. You have to remember one point beta, that what is the grading system used for intermittent claudication called as. याद रखना है, the grading system that is used for intermittent claudication has been asked in the name beta. The name of the intermittent claudication grading is classically called as the Boyd's classification beta. ठीक है, the Boyd's classification is actually going to be it is actually the grading for the intermittent claudication. Now let's see the grades of intermittent claudication one by one. First condition beta, I'll say the first condition is, here the patient starts walking. After walking a certain distance beta, the patient has pain, but the pain is very mild, therefore the patient continues to walk and the pain eventually disappears बेटा. ठीक है, पेशेंट चलना शुरू करता है, थोड़ा चलने के बाद दर्द होता है, बट वो दर्द थोड़ा सा होता है बेटा, इसलिए पेशेंट चलता रहता है और वो अपने आप पेन गायब हो जाता है. दैट इज व्हाट इज ग्रेड 1. ग्रेड 2 बेटा, नाउ हियर डेफिनेटली द पेशेंट स्टार्ट्स वॉकिंग. After walking certain distance, the patient has cramping pain. Okay, here the pain is again mild, therefore the patient continues to walk with pain. Yes, here the pain does not disappear, but the patient continues to walk with pain. It is manageable. So grade 2 क्या है, पेशेंट चलने लगता है, चलने के बाद थोड़ा सा दर्द होता है, वो दर्द थोड़ा सा ही होता है, इसीलिए पेशेंट चलता रहता है, दर्द के साथ चलता रहता है. ठीक है, दर्द गायब नहीं हो रहा. दैट इज ग्रेड 2. Grade 3 is what beta, the patient starts walking. After walking a certain distance, the patient has a severe pain in the leg beta, and therefore the patient has to stop, the patient has to take rest beta, the patient is compelled to take rest. तो grade 3 क्या हुआ, पेशेंट चलने लगता है, पेशेंट चलता है थोड़ा डिस्टेंस, उसके बाद बहुत ज्यादा सीवियर दर्द होता है, जिसकी वजह से पेशेंट को रुकना ही पड़ता है बेटा. ठीक है, एंड ग्रेड 4 विच इज देयर बेटा, द पेशेंट विल हैव पेन एट रेस्ट. ठीक है, इवन इफ द पेशेंट इज रेस्टिंग, द पेशेंट इज हैविंग पेन. क्लियर? So that is important. As I've told you, class 1 which is there, there is pain on walking which does, okay, there is pain on walking beta, and that pain disappears when patient continues to walk beta. Next is class 2 bache. Class 2, there is pain on walking beta and the patient continues to walk with pain bache. Class 3 is what? Class 3 is the pain forces the patient to stop. ये correct कर लेना बेटा, the pain forces the patient to stop. Clear? So that is important. हाँ मैंने clear कर दिया, that's important. Next important beta is class 4. Class 4 में the patient is going to have pain at rest also beta. Okay, class 4 में the patient is going to have pain at rest. No issues with this anybody? No issues with this? चलो, great. Next important beta is the second stage beta. Second stage में क्या होता है? There is a constant pain beta. Okay, and that is what? That is due to damage of the nerves beta. And this constant pain due to the cry of dying nerves. I have told you what is considered as cry of dying nerves. It is nothing else but beta, the rest pain. So the next step is going to be rest pain beta. That is actually the cry of dying nerves. Okay, तो याद रखना है, cry of dying nerves is nothing else but rest pain. Next important, next stage में क्या होगा? The patient will have injury to the nerves. Due to that, the patient will have paresthesias. There will be numbness and there will be coldness beta. ठीक है, the patient will have Rutherford beta. There is another classification, you don't have to worry about that. The common in clinical practice we use this one. ठीक है, so please remember beta, paresthesias, numbness and coldness is there beta, that has to be remembered. Next if I talk about beta is going to be rest pain. Next stage में क्या होगा? The patient will have rest pain. Along with that, as I've told you, the skin is not receiving enough blood supply, therefore there will be cyanosis and therefore you will be able to see color changes beta. ठीक है, with or without ulceration of skin. Okay, and ulceration happens because of necrosis. So here the necrosis may have started. ठीक है, so rest pain, color changes with or without ulceration of skin अगर बोलते हैं बेटा, that is the stage of pre-gangrene बच्चे. ठीक है, that would be considered as a stage of pre-gangrene. And ultimately beta, when there is complete necrosis distal to the obstruction, that will be the stage of gangrene. When there is complete necrosis distal to the obstruction, that is the stage of gangrene. ठीक है, तो intermittent claudication, rest pain, coldness, numbness, paresthesias, along with pre-gangrene and gangrene beta. These are the various stages of a gradual arterial obstruction. Now let's talk about beta this one over here. What is this? You can see here, here there are just color changes which are seen beta. So this one which is there beta is the stage of pre-gangrene. But here you are able to see beta, there is complete necrosis. So this is what is going to be a complete gangrene beta, right? That is important. Now, just by looking at the picture, do not say it is burgers, because you are able to see the small vessels in the toes. No, beta. This is the similar kind of picture which was given in a previous year question that I told you, beta. But where they have said definitely the patient's age is 55 years of age. That's the reason, beta, the answer to that question was atherosclerosis. Clear about? So that is important. Now, important is when a patient comes to us with a gradual arterial obstruction, what is going to be done? Okay, what is going to be done basically, beta, for the clinical examination of the patient? So, yaad rakhna, for the clinical examination of an artery, we always go for palpation of a pulse, right? Clinical examination kaise karoge? We have to palpate a pulse, beta. Now, palpation of pulse, we know, beta, it should always be done against a bony surface, so that when you press the artery against a bone, beta, you will be able to feel or palpate the pulse properly. So the most common pulses are the radial, brachial, femoral, then the popliteal behind the knee, the posterior tibial, sarkari question of your exam, posterior tibial between the tendo Achilles and the medial malleolus, and the dorsalis pedis, beta, that is against the navicular bone or between the first and the second metatarsal of foot. Clear? These are the pulses that we commonly feel, and the last one is this, when nothing is felt. Okay? Now, important is, beta, when you are going to palpate a pulse in a patient of a gradual arterial obstruction, what could be the feature? Now, understand, beta, for example, this is an artery which has got blocked. Okay? This is the artery and this is the blockage, beta. So, this is the area proximal to the obstruction. Okay? Coming to that. Okay? Next, this is the area proximal to the obstruction. This is definitely distal to the obstruction, beta. Okay? What is going to happen, beta? Understand, the area proximal to the obstruction, beta, will have definitely more blood flow. The area proximal to the obstruction, beta, will have more blood flow, and therefore proximal to the obstruction, beta, the pressure is going to be high. Okay? Proximal to the obstruction, beta, the pressure of the patient is going to be high, beta. That has to be remembered. And if the pressure proximal to the obstruction is high, beta, will it have a linear blood flow or a turbulent blood flow? Obviously, it will have a turbulent blood flow, beta. And whenever there is a turbulent blood flow, bache, it is actually going to create a noise also, and that noise is what is called as a bruit also, that you will be able to hear on auscultation. Okay? Whereas, beta, distal to the obstruction, basically the blood flow which is there, okay, distal to the obstruction, the blood flow is lesser. That's the reason the pressure distal to the obstruction is going to be less. So now when I palpate the pulse, beta, when I palpate the pulse, what I'll be able to feel? Proximal to the obstruction, beta, the pulse will be pretty strong. It will be a high volume pulse. But distal to the obstruction, beta, the pulse will be weak or feeble, beta, that is a low volume pulse, right? For example, if I say my patient is having a popliteal artery blockage, so obviously, beta, the femoral pulse of my patient will be extremely strong. But on the other hand, the posterior tibial pulse of my patient will be weaker, beta. That is what I'm saying. Okay? Chalo. So if I talk about, beta, the pulse basically, as I've told you, you have to remember one thing. Proximal to the obstruction, beta, the pulse is going to be high volume pulse, beta, or it is going to be an extremely strong pulse. But if I talk about, bache, distal to the obstruction, beta, it is going to be a low volume pulse. Okay? Or it is going to be a feeble or a weak pulse, beta. Clear? That is important. Now, as I told you on auscultation, beta, you can also auscultate for the vessel basically. And when you auscultate proximal to the obstruction, what is going to be heard, beta? As I've told you, proximal to the obstruction, when we are going to auscultate, due to that turbulent flow, beta, we are able to hear a noise, and that is what is called as a bruit, beta. Okay, bruit will be present basically proximal to the obstruction. That has to be remembered. No issues with this. Now, next thing that we have to do, beta, in clinical examination is basically ABPI. What is ABPI? Ankle brachial pressure index. By the name itself, it is evident, beta. Okay? ABPI ki agar main baat karu, it is nothing else but ankle brachial pressure index. That means it is basically index or a ratio, beta, of the blood pressure at the level of the ankle and the blood pressure at the level of the arm, right? So ABPI jo hota hai, ankle brachial pressure index, beta, the formula is easy. That is nothing else but, beta, the systolic blood pressure at the level of the ankle upon the systolic blood pressure at the level of the arm, beta. Okay? That is what is called as the ABPI. Clear? Now, please tell me that slightly there will be higher pressure normally, beta. In a normal person, slightly higher pressure is in the arm or the ankle. Slightly higher pressure is in the arm or the ankle, beta. So, yaad rakhna, beta. Please remember, slightly there is a higher pressure in the ankle normally. Why? Because of gravity, beta. Because of gravity, there is a slightly increased blood flow towards the lower limbs of the patient, and that's the reason the systolic BP at the level of the ankle will be slightly higher beta as compared to the systolic BP at the level of arm. इसीलिए beta in a normal person usually the ABPI which is there, it is usually going to be more than 1. Okay, so the rather the range which is there beta, I'll say it is between 0.9 to 1.3 beta, right? It is usually more than 1 beta in a normal person, the ABPI. Okay, so that has to be remembered. Ankle brachial pressure index का formula I've told you, it is systolic BP at the ankle upon systolic BP at the arm. ठीक है, normal value of the ankle brachial pressure index beta has to be 0.9 to 1.3. Single best answer you can mark it as 1.1. Okay, so 0.9 to 1.3 is basically the range beta, so that has to be remembered. Now we know that whenever there is going to be atherosclerosis beta or a Burger's disease in the patient, obviously there is going to be blockage inside the lower limbs of the obviously there is going to be blockage in the lower limb arteries beta, and as there is going to be blockage in the lower limb arteries bache, that is the reason definitely the patient will have a decreased blood flow towards the ankle, and if there is decreased blood flow towards the ankle, even the systolic BP towards the ankle is going to decrease, and as the systolic BP in the ankle decreases beta, the ankle brachial pressure index of the patient is also going to डिक्रीज बेटा. ठीक है, अगर लोअर लिम्ब को ब्लड सप्लाई कम मिल रहा है तो सिस्टोलिक बीपी एट एंकल कम है, इसीलिए बेटा डेफिनेटली द एबीपी ऑफ द पेशेंट डिक्रीजेस इन ग्रेजुअल आर्टेरियल ऑब्स्ट्रक्शन. तो इन ग्रेजुअल आर्टेरियल ऑब्स्ट्रक्शन बेटा डू रिमेंबर इंटरमिटेंट क्लॉडिकेशन में द एबीपी ऑफ द पेशेंट, इंटरमिटेंट क्लॉडिकेशन में एबीपी ऑफ द पेशेंट इज लेस देन 0.9 बेटा. ठीक है, रेस्ट पेन में द एबीपी ऑफ द पेशेंट विच इज देयर बेटा इट इज लेस देन 0.5. रेस्ट पेन में द एबीपी ऑफ द पेशेंट इज यूजुअली लेस देन 0.5. Critical limb ischemia beta, if they ask you about the critical limb ischemia which is there, definitely here the ABP of the patient which is there, beta, it is less than equal to 0.3. The ABP of the patient is less than equal to 0.3 beta, that has to be remembered. And gangrene mein beta the ABPI will be almost nil, it is going to be 0.1 almost, right? Gangrene mein almost there is no blood supply towards the angle na, so therefore it is going to be almost towards the 0.1 beta. ठीक है, so that has to be remembered. These are the important things. याद रखना, they have asked you about the intermittent claudication, they have definitely asked you about the critical limb ischemia as well. ठीक है, तो in intermittent claudication beta do remember that the ABP of the patient will be less than 0.9, and critical limb ischemia has been asked also. In critical limb ischemia beta the ABP of the patient is less than equal to 0.3, that has to be remembered. Okay, so here in the picture what they are doing, they are basically beta they have tied a cuff at the level of the ankle. One reason is definitely to check the ankle systolic blood pressure at the ankle and to calculate the ABPI. Second, what is in her hand beta, basically this is nothing else but a Doppler beta that is in her hand. Okay, usually she is using a Doppler over here. Okay, that is important. Now if they ask you what is the investigation of choice, now here I am going to clear two things for you beta which will actually help you not only in this but in multiple other systems also and the subjects also. For that is the confusion between the investigation of choice and gold standard test beta. To understand what is the difference, investigation of choice which is there beta, it should be cheaper, it should be easily available, okay, it should be non-invasive or at least minimally invasive. Okay, it should be affordable definitely as I told you, and it may not give you diagnosis in 100% cases. It may definitely beta, it may definitely give you the diagnosis in patients sorry, it may definitely give you diagnosis beta in 90% of patients, and that's fine. Okay, no issues with that. This is what is called as the investigation of choice. Now when I talk about beta the gold standard investigation on the other hand, yaad rakhna, gold standard investigation on the other hand, it may be expensive, does not matter, it may not be easily available, that's fine. It may be invasive beta, does not matter, it can be invasive, no issues with that. Apart from that, definitely beta you have to remember that it will give you diagnosis in 100% cases beta. Yes, it will give you diagnosis in 100% cases. And lastly, it can not only be used for treatment, it can not only be used for diagnosis beta, it may also help you in treatment. Such an investigation will be called as the gold standard investigation. Okay, with an example of bile duct I'll explain you. The first one is definitely bile duct. If they ask you investigation of choice, answer is MRCP, the magnetic resonance cholangiopancreatography beta, where we do a T2 weighted MRI beta, where we do a T2 weighted MRI basically, please remember that. Okay, so I do a T2 weighted MRI definitely बेटा. T2 weighted MRI में क्या होता है? Water appears while the bile appears white बेटा. ठीक है? Therefore, I do not have to inject any contrast inside the bile duct. Clear है बात? That's the reason बेटा MRCP will be a non-invasive investigation. Therefore, MRCP will be considered as investigation of choice for bile duct problems. On the other hand, beta, if I talk about basically, okay, on the other hand, if I talk about beta, is the ERCP, which is a gold standard investigation for bile duct. Reason, ERCP, that is endoscopic retrograde cholangiopancreatography beta. Over there, we have to insert an endoscope beta. So obviously, it is an invasive investigation. Second, it may be expensive. It may not be easily available, right? But ERCP will always give us a diagnosis first thing. Second beta, for example, if there is a stone in the bile duct, ERCP will not only help us in diagnosis of that, ERCP may also help us in removal of the stone also, right? That means it is diagnostic as well as therapeutic. That's the reason beta ERCP will be the gold standard investigation. Clear है बात? Similar manner में. Now if I come back to the vessels beta, ठीक है? Vessels के लिए एक logic दे रहा हूँ. Again, you don't have to rectify anything. याद रखना, whenever there are peripheral vessels beta, peripheral vessels से I mean the upper limb and the lower limb vessels बच्चे. Upper limb and lower limb vessels में you have to remember one thing beta, that these vessels are superficial. Okay, so therefore for these upper limb and lower limb vessels beta, the investigation of choice is going to be a duplex scan. Now what is a duplex scan beta? It is nothing else but beta a color Doppler along with a ultrasound B scan beta. Okay, color Doppler plus an ultrasound B together is what is called as a duplex scan. Color Doppler will tell you about the flow of the blood. Ultrasound B scan you can remember it as a photograph. ठीक है, तो color Doppler video है, ultrasound B scan एक photograph है. Together it is what is called as the duplex scan. If duplex is not an option, then the second best choice will be color Doppler. ठीक है. If they ask you about the gold standard investigation for the peripheral vessels, the gold standard investigation क्या है? We have to inject a catheter beta, and then from that we have to definitely inject a dye. Okay, we have to insert a catheter and then we have to inject a dye beta. Now this dye will travel from these peripheral vessels, and when the dye is traveling via the peripheral vessels, you have to take a X-ray beta. Now here definitely due to that dye, the vessels will appear highlighted. So if there is any kind of problem in the vessels, we will be able to detect that. This is what is called as the angiography. When I only say angiography beta, that means definitely it is the catheter or the invasive angiography where we have pushed in a dye. Okay. Next important, let's talk about the central vessels of your body beta. Central vessels I mean the head, neck, chest, abdomen and pelvis. These vessels if I talk about beta, these are larger vessels. Second important beta, here there are a lot of structures around it beta, and these are deeper also. That's the reason beta duplex is not going to be working for the central vessels. So central vessels के लिए the investigation of choice is either a CT angiography or a MR angiography. But here when I mean a CT angio or MR angio, here I am not injecting any dye. Yes, these are non-invasive or minimally invasive methods beta. Okay, these are special types of MRI or CT beta which can help us to take a picture of the vessels like a T2 weighted MRI. No need of dye anybody. Okay, that is important. So CT angiography or MR angiography beta will be the investigation of choice for the central vessels of the body. Then what is the gold standard? The gold standard here also for the central vessels is also angiography beta. And when I only say angiography, मतलब मैंने बोला you have to insert a catheter and inject a dye, and then that dye is going to travel via these vessels, and then we will take a X-ray. That is what is called as a angiography. Clear about? Hopefully there is no issues on this one now. Sorry. Investigation of choice beta. Investigation of choice अगर वो बोलेंगे तो you have to remember बेटा the answer is nothing else but a duplex scan. ठीक है, all the vascular problems बेटा that we are going to study, majority of them में. ठीक है, atherosclerosis में yes बेटा अगर बड़ी vessels involved है, for example if the abdominal aorta वगैरह involved है, then you have to go for a CT angiography. But here we are talking about the lower limb vessels mainly, so a duplex scan is going to be used. ठीक है, अगर aorta है तो again I am saying CT angio will be used. ठीक है, duplex scan will be done बेटा. Duplex scan नहीं option में, then the second option which is there beta as I told you is a color Doppler. So duplex is what? It is nothing else but color Doppler plus ultrasound B scan. That has to be remembered. If they ask you what is a gold standard investigation, gold standard investigation I've already told you beta, it is nothing else but an angiography beta. Okay, so that is important. Now if they ask you which is the most common vessel bache, if they ask you that which is the most common vessel involved in atherosclerosis, so yaad rakhna the most common vessel involved in atherosclerosis, I hope all of you are quite aware about it, It is nothing else but the abdominal aorta beta. The most common vessel affected with atherosclerosis overall in the body has to be the abdominal aorta, which it has to be the abdominal aorta, that has to be remembered. Followed by that beta, the second most common vessel which are involved are the coronary arteries beta. That is the vessel supplying the heart. Therefore, the patient has MI due to blockage of these coronary arteries, right? So the most common vessel involved with atherosclerosis beta is going to be your abdominal aorta itself, and the second most common is going to be coronary arteries. Next important, if they ask you which are the most common peripheral vessels involved, तो याद रखना है बेटा the most common peripheral vessel, because abdominal aorta or coronary arteries beta both are central vessels of your body. The most common peripheral vessel involved, this was a previous year question, answer has to be the popliteal artery beta. Popliteal artery basically is the most common peripheral vessel that is involved. Okay, and the last one which is there beta, it is going to be which is the least common vessel involved. So yaad rakhna beta, if they ask you which is the least common vessel involved in patients of atherosclerosis, there are two types of vessels beta. The first one, if I talk about, okay, it is going to be the circle of Willis. Yes, circle of Willis, that means those blood vessels beta which supply the brain, they have less chances of atherosclerosis. And the second one which is there beta, it is the internal mammary artery. Okay, internal mammary artery which is there beta, it can be two of them. That is the right internal mammary artery known as rima, or the left internal mammary artery known as lima beta. Okay, that is important. One is circle of Willis beta, and the second is definitely the lima or rima. That is the right or the left internal mammary arteries. Now important is beta, why this is important to know which is the least common vessel affected. Reason beta, for example, if a patient has blockage in the artery, we know we can do a bypass grafting. So which is the best autologous bypass graft beta from your body? So obviously it is going to be the vessels beta with the least chances of atherosclerosis. Obviously you cannot take a circle of Willis now for grafting. So it is going to be the lima or rima beta, which could be the best grafts to be used. Okay, which can be the best grafts beta, the right or the left internal mammary artery. Okay, these could be the best autologous grafts. I'll talk about that in a while. Understood? This is important beta to be remembered. Now, if I talk about the treatment beta or the management in a patient of atherosclerosis. Now, when we talk about the management in a patient of athero beta, so obviously you have to treat what? Basically, you have to relieve all the symptoms of the patient beta. Whatever problems that the patient is having, you have to give relief of those symptoms, first thing. And second beta, you have to improve the blood supply distal to the obstruction, right? You have to just increase the distal blood supply. These are the aims of our treatment beta. The first and the foremost, yaad rakhna aapse, that in whichever condition beta the risk factors are modifiable, the first line treatment in that particular condition has to be lifestyle modification beta. ठीक है, तो इस कंडीशन में भी बोला था मैंने, ओबेसिटी, स्मोकिंग, अल्कोहल, ऑल ऑफ दीज आर मॉडिफाइबल रिस्क फैक्टर्स, राइट? सो देयरफॉर बेटा, हियर द फर्स्ट लाइन मैनेजमेंट, if they ask you what is the first line management, answer has to be beta lifestyle modification. ठीक है, तो when they say what is the first line treatment in atherosclerosis, answer has to be lifestyle modifications beta. Clear? Now in lifestyle modifications, what has to be done beta? So we know definitely lifestyle modifications mein the first and the foremost, we know smoking and alcohol are very important risk factors beta. So the first thing that has to be done, the patient has to quit smoking and alcohol beta. The patient definitely has to quit smoking and alcohol bache. Next, I've told you definitely obesity is important risk factor. The patient has to go for a weight loss beta. Patient has to go for a weight loss. And second, for the purpose of that itself beta, you have to go for regular exercise. Okay. Along with that, the patient could avoid the fried fatty food beta, because hyperlipidemia is another risk factor. Okay. So these are the important lifestyle modifications to be recommended. One is quit smoking and alcohol. Second is weight loss and regular exercise beta. Okay. These are the main lifestyle modifications to be recommended. Now, if lifestyle modifications are recommended beta, obviously in a lot of patients what happened beta, the lifestyle modifications are going to fail, especially when we ask them to stop the smoking, right? So lifestyle modifications were tried for a span of almost 6 months beta. Lifestyle modifications were tried for almost a span of 6 months, but if they fail beta, definitely, in that condition, the next step has to be what? In that condition, the next step has to be medical treatment beta. Now, when I talk about the medical treatment, which drugs are to be used in this condition? The first and the foremost beta has to be vasodilators. Now, when I talk about the vasodilators beta, what the vasodilators will do? Vasodilators are actually going to dilate the blood vessels over there, beta, and actually they will increase the distal blood supply, right? That is important. Now, which vasodilators are used, beta? Not the conventional ones. Here, the vasodilators that we use, beta, it is going to be something like silastazole, or we can give pentoxyphylline, beta. These are usually the phosphodiesterase inhibitors, beta, which could be given to the patient. So, yaad rakhna hai, silastazole, oxypentaphylline, pentoxyphylline. These are going to be the drugs, beta, which can be used in this patient as vasodilators. Second important, बच्चे, antiplatelet drugs if they ask you. तो याद रखना antiplatelet drugs which are given, those are going to be something like, anybody, long term पे बेटा we can definitely give aspirin to our patient, or we can also give beta another drug which is antiplatelet drug known as clopidogrel. So clopidogrel, ticagrelol, ठीक है, aspirin, all of these drugs could be given. Next important beta, the last option which is there, it is nothing else but statins, beta. So statins, we know beta, they are considered as the drug of choice for hyperlipidemia or hypercholesterolemia, beta. Okay, atorvastatin, rosuvastatin, those can be given as well. So vasodilators plus antiplatelets plus statins, beta. This is the combination medical therapy which is used for the management in a case of a atherosclerosis, beta. Clear hai baat? That has to be remembered. Now let's talk about the next condition, beta. Now, if lifestyle modifications tried but failed, medical management tried but failed, then the next option has to be surgical procedures, beta. And now the next step is a surgical procedure known as PTA, beta. Now, what is this PTA basically? It is nothing else but percutaneous transluminal angioplasty. We know, beta, what is plasty? Repair. So, angioplasty means repair of a vessel. Basically, you have to either remove that blockage, beta, or you have to repair the vessel so that the blood supply distally is improved, beta. Transluminal, that means you have to go inside the vessel and you have to perform this procedure, beta. Okay. So for this procedure, as we have to go inside the vessel, beta, we are actually going to use this catheter over here, and this has been asked in your examination as image based question. This long catheter, beta, with a balloon at the end, basically used for vascular surgery, is called as, so yaad rakhna hai, beta, this is classically called as the Fogarty's vascular catheter. This is basically called as a Fogarty's vascular catheter. गलती से भी इसको फोरीज वोरीज नहीं बोलना है, ठीक है? So please remember, बेटा, it is the Fogarty's vascular catheter, बच्चे, which will be used for the purpose of angioplasty. No issues with this. Now there is two types of angioplasty that we can do, beta. One, definitely at the site of the blockage we can go, beta, and we definitely can inflate the balloon over here. As we are going to inflate the balloon, beta, we will actually break down the plug, beta. Okay, as we will keep on inflating the balloon, okay, we will deflate, inflate, deflate, inflate. So due to that constant inflation and deflation of the balloon, beta, it will help us in breaking the plaque, basically breaking the blockage, beta. And once that blockage, or once that atherosclerotic plaque has been broken down, now with the same catheter, beta, we remove all those fragments. Reason, if you leave those fragments over there itself, beta, they may cause blockage of the smaller vessels at least. Okay, that is the reason. So this will be called as a balloon angioplasty, right? When you are going to break down that plaque, that is what is known as a balloon angioplasty, beta. Here you are able to see the balloon, beta, not the stent. This one inside which is there, beta, this is the balloon. Okay, that is important. Now the second option which is there, beta, it is nothing else but a stent angioplasty. Now what do I mean by a stent angioplasty, beta? So here, beta, at the site of the blockage, you actually are going to insert a stent, beta. At the site of the blockage, beta, as you are able to see here, there was a blockage, right? So definitely at the site of the blockage, you can see we have inserted the stent, basically, right? And as you have inserted the stent, you can see the plaque which is there, beta, it has been compressed, okay? And now the blood which is there, beta, it is going to flow via the stent. And as the blood will flow via the stent, beta, now there will be no chances of any problem or any obstruction in the blood flow. Now, previously, beta, we used to use metallic stent. But what was the problem, bache, with the metallic stents? Basically, the metallic stents were again the site for the platelets to attach. And that is the reason, beta, on the stents, actually, we have seen plaques forming. So nowadays, beta, rather than using a metallic stent, we have started using drug-eluted stent. That means a stent which is coated with an antiplatelet drug, beta, so that the platelets will not stick to the stents, basically. Clear? Okay? So that is important. So stent angioplasty which is there, beta, it is usually of two types. Either it could be a metallic angioplasty, metallic stent angioplasty, or it can be a drug-eluted stent angioplasty. Nowadays, we know, beta, we commonly use a drug-eluted stent for the purpose of angioplasty. If they ask you that which is the drug that is used definitely to coat these drug-eluted stents, beta, The antiplatelet drug that is generally used beta to coat these is nothing else but a drug known as sirolimus beta. Okay, this has been a neat PG question earlier. So do remember that beta, that the drug which is used to coat these stents basically beta has to be the sirolimus drug, which is an antiplatelet drug beta. Okay, so that is important. Now if I talk about beta the next one, that is bypass grafting. Okay, if I talk about the next one, that is nothing else but bypass grafting beta. So if angioplasty has been tried, but if the angioplasty fails beta, then the next option has to be bypass grafting. Now bypass grafting का idea कहाँ से आया बेटा? हमें bypass grafting का idea हमें blood vessels body से ही आया बेटा. How? Understand. Normally beta we know that whenever there is a gradual arterial obstruction which develops basically beta in the artery, what the body does? The body tries to find new routes beta. Yes. And how does the body finds a new route beta? Body actually forms new collaterals beta. Okay. And when this body is going to form the new collaterals beta, now what is going to happen? Obviously the blood will start flowing via these collaterals bache, right? The blood which is there beta, it usually flows via the collaterals. So body has given us the idea, if the main rasta is blocked, you can definitely change the route and go. Okay, so that is what is done beta. So we do the same thing in bypass grafting. What we do, we take a vessel from somewhere in your body beta, or we take a synthetic graft bache, okay, and then that graft we are going to place beta proximal to the obstruction and distal to the obstruction. We are going to connect that graft beta proximal and distal to the obstruction. Why? So now the blood which is there beta, it is going to flow via the graft itself. And here what we have done, we have actually bypassed the obstruction beta, and that's the reason it is called as a bypass grafting. Clear about that? Has to be remembered बच्चे. Now if I talk about beta bypass grafting की अगर मैं बात करूँ, okay, if I talk about the bypass grafting, there are two types of bypass graftings which are available beta. Either I can do the bypass grafting with the help of an autologous graft, that means a graft which is taken from your own body, or with the help of a synthetic graft beta, a graft which is prepared. Okay. Now if they ask you which is the best autologous graft of the body, I have already told you beta that the vessel which will have least chances of atherosclerosis, that can serve as the best graft, and that is going to be nothing else but beta your lima or rima beta, that is your left or the right internal mammary artery. So your lima or rima beta are going to be considered as the best grafts basically. If that is not an option beta, then the second option which can be there is definitely the GSV beta. And what is GSV? GSV is nothing else but the great saphenous vein beta. Now a lot of people are like, so nahi, GSV is the better graft. No, the better graft is always a lima or a rima beta. Yes, more commonly we definitely do a GSV grafting. Reason behind that is great saphenous vein grafting beta, it is much easier. It is easy to take a GSV graft beta, okay, but it is not the best one. Reason, arterial grafts are considered always superior to a venous graft. First thing. Second, the patency of the lima or rima graft, an arterial graft, is around 15 to 20 years beta. The patency of a great saphenous vein graft beta will be only around 10 to 12 years. Clear hai? So that's the basic thing beta that you have to remember. Now if they ask you beta which is the best synthetic graft, so yaad rakhna, if they ask you the best synthetic graft beta, it basically depends on which vessels basically we have to do a grafting for. Okay, if they say beta we have to do the grafting for a large vessel, okay, we have to do a grafting for a large vessel like the abdominal aorta beta, right? So above the iliac vessels, if you have to do the grafting bache, then the best synthetic graft has to be Dacron beta. Then the best synthetic graft that is used is Dacron. But for medium to small vessels, if you have to do a grafting, for a medium to small vessels we have to do a grafting beta, then the best synthetic graft is known as PTFE bache. Then the best synthetic graft is known as PTFE. Now what is PTFE? It is nothing else but beta polytetrafluoroethylene. Okay, the best graft that is used for small vessels beta is polytetrafluoroethylene or PTFE graft. The best graft that is used for larger vessels of the body beta like the aorta is going to be the Dacron graft. Hopefully that's clear to you, all of you. Yeah, we have to do a regular follow-up. Not only after 10 years, we have to do a regular follow-up in the patient. Yeah. Chalo. Now next important beta if I talk about basically is there is one more option beta to treat this gradual arterial obstruction, and that is lumbar sympathectomy beta. Now what is a lumbar sympathectomy? Basically in this condition beta, we have to remove the lumbar sympathetic ganglia. Okay, in this condition we have to remove the lumbar sympathetic ganglia. So in lumbar sympathectomy there is removal of the L1, L2, L3, L4 sympathetic ganglia beta from the lumbar region. Okay, why? Understand now. See, we know beta that your lumbar ganglia which are there, they are definitely sympathetic in nature. Okay, sympathetic system means when you are going to see a tiger and run beta, at that time your sympathetic system is active. So beta, what should happen basically in the muscles and in the skin and the nerves beta? Okay, when the sympathetic system is active. Now मुझे बताओ, definitely when you have to run, okay, obviously you need more blood supply towards the muscles. That's the reason that whenever the sympathetic system will whenever the sympathetic system is active beta, okay, as we need more blood supply towards the muscles beta, there is vasodilatation of the muscles and there is vasoconstriction of the skin, because we steal the blood supply from the skin beta and we give it to the muscles first because we have to run now. Okay, that is what is going to happen beta whenever the sympathetic system is active normally. अब क्या करते हैं अपन? We are removing the lumbar sympathetic ganglia. As you remove the lumbar ganglia itself beta, the sympathetic outflow has been lost. If there is no sympathetic outflow itself beta, अब क्या होगा? In the muscles beta, rather than vasodilatation, there will be vasoconstriction बच्चे, and in the skin beta, rather than vasoconstriction, there will be vasodilatation beta. ठीक है? That is important to be remembered. So now what is happening here beta? The blood supply from the muscle is taken and it is given to the nerves and the skin beta. Why? Because in this condition beta, the muscles have already been damaged. Okay, so definitely now we are taking that blood supply and we are at least trying to save the nerves and the skin, because now the next number is of the nerve and skin beta. The nerves and the skin of the patient have started getting damaged beta due to low blood supply. Therefore we are taking the blood supply from there and giving it to the skin and the nerves. Muscle has that ability that it will have formation of collaterals later on, but skin and nerves will not get blood supply. Okay, that's the reason beta we have to do a lumbar sympathectomy. Now please tell me in the chat box that in which condition a lumbar sympathectomy should be absolutely contraindicated. In which stage of distal ischemia lumbar sympathectomy should be absolutely contraindicated? What was that condition where you should not steal the blood supply from the muscle? Reason, the muscles have not been damaged yet. And that's the reason if you steal the blood supply, the muscles will actually get damaged. Okay? So please remember, lumbar sympathectomy is removal of L1, L2, L3, L4 lumbar sympathetic ganglia, which is going to cause vasodilatation of the skin, that is sympathetic vasodilatation of the cutaneous vessels beta, and it is going to ensure that there is enough blood supply to the skin as well as the nerves bache. Okay, so it will prevent the death of the nerves. As it is going to prevent the death of the nerves beta, we know it is going to be used in which condition? The lumbar sympathectomy beta is indicated in rest pain. Why in rest pain beta? We know in rest pain definitely beta, rest pain is called as cry of dying nerves. That means here the nerves have started dying, and that's the reason beta we want to restore the blood supply to the nerves bache, and that's the reason lumbar sympathectomy should be done in a patient of rest pain. But it should absolutely be contraindicated. It should absolutely be contraindicated beta in a patient who is having intermittent claudication. Reason is, if you do not give blood, if you definitely beta steal the blood supply from the muscle in a patient of intermittent claudication. In intermittent claudication beta, the muscles have not died yet. Okay, but if you steal the blood supply, the muscles will surely die. Okay, so that is important beta. In a patient of intermittent claudication, never go for a lumbar sympathectomy. Lumbar sympathectomy is absolutely contraindicated in that condition. And where is it indicated? It is rather indicated to be done beta in a patient who is already suffering from rest pain, the next stage. Okay, that has to be remembered. Now if I talk about beta the gangrene basically, तो याद रखना है बेटा, gangrene की अगर मैं बात करूँ, obviously if a patient comes to you with a gangrene, the only treatment option is nothing else but beta, we have to cut out. That means we have to do an amputation beta. Whenever a patient comes to you with a gangrene, we have to go for an amputation itself. Clear है बात? These are the treatment options beta that we are going to use for a obstruction basically, right? Whether it is a gradual arterial obstruction. Okay, that is important. Now important beta, if I talk about a condition known as Leydig syndrome. What is Leydig syndrome? Yaad rakhna. Leydig syndrome means beta, for example, this is the aorta and this is the common iliac vessels beta, right? We know that when the abdominal aorta is going to bifurcate, there is formation of the common iliac arteries beta. So this is what is called as the aorto-iliac bifurcation beta. This is what is called as the aorto-iliac bifurcation. Here beta, in a patient of Leydig syndrome, there is actually a blockage in the aorto-iliac bifurcation itself. Yes, the patient has a bifurcation beta in the aorta. The patient has a blockage beta in the aorto-iliac bifurcation. Now please tell me, if there is a blockage in the aorto-iliac bifurcation itself, will the common iliac arteries receive blood supply? No. And if the common iliac arteries itself will not receive blood supply beta, will the internal and external iliac arteries receive blood? No, we know that your internal iliac artery, which is there, beta, it is going to supply the pelvic organs and the perineum along with genitalia, right? The internal iliac artery goes inside the pelvis and it supplies the perineum and the genitalia. So if the internal iliac artery does not receive blood supply, beta, the patient will never be able to get a penile erection. That means the patient will have impotence. Next important, external iliac artery, we know, beta, it usually goes into the leg of the patient. We know that the external iliac artery converts into the femoral artery, popliteal artery, tibial artery, right? So if that external artery, external iliac artery is not going to receive blood, beta, your lower limb and your buttocks are not going to receive blood. So the patient will have a cramping pain in the buttocks, beta. That is called as gluteal claudication. As well as the patient will have a shooting pain in the whole lower limb as well, beta. These are the symptoms in a patient of a lyric syndrome. So yaad rakhna, what is lyric syndrome? It is nothing else but beta blockage at. It is what? Blockage at which level? Aortoiliac bifurcation. Okay, it is obstruction or the blockage basically beta at the aortoiliac bifurcation. Hopefully that's clear to all of you now. Next, as I've told you, what are the symptoms? Symptoms are nothing else but gluteal claudication, shooting pain in the lower limbs, as well as impotence beta. Okay, the patient is going to develop. Yeah, in all classes it is contraindicated, obviously. Okay. Last one which is there, beta, it is treatment. Now what is the treatment? So we know, beta, here the problem is in the aortoiliac vessels, so therefore we have to use a synthetic graft, beta, and that synthetic graft which is there, it should be made up of Dacron because larger vessels are affected over here. So this is the Dacron graft, beta. As you can see, it looks like the aortoiliac bifurcation itself. Okay, so please remember, here we have to go for a Dacron graft repair which is okay. What should be the treatment for lyric syndrome? It is nothing else but a Dacron graft repair has to be done. Okay, so do remember that. Next important beta, if I talk about, is another condition that is the second most common cause of gradual arterial obstruction. And we know the second most common cause of gradual arterial obstruction is nothing else but beta. It is Buerger's disease. Now, if I talk about the Buerger's disease, beta, we know this condition is also known as what? It is also known as thromboangiitis obliterans, beta. Now, as I say, thromboangiitis obliterans, which is what is the problem over here? Here, the patient is actually having inflammation of the veins, beta, and due to inflammation of the veins, what is going to happen, beta? There is going to be blockage in the veins which will develop. Okay, so that is what is called as a thromboangiitis obliterans, beta. Okay, that is what is Buerger's disease. Now we know, beta, for the diagnosis of Buerger's disease, the criteria that is used is known as the Ollen's criteria. Yaad rakhna, the name of the criteria that is used for diagnosis of Buerger's disease is known as Ollen's criteria. According to Ollen's criteria, beta, there are three important parameters which should be there. The first one, if Buerger's disease is more commonly seen, as I've told you, in younger patients who are usually less than 40 to 45 years of age. And if I say males or females more commonly, so please remember, it is more commonly is seen, beta, in younger males, beta. Yes, younger males are going to be more commonly affected than females, beta, in a patient, in a case of Buerger's disease. First thing. Second important, the patient should have a history of tobacco use, beta. Okay, history of tobacco use is a most important risk factor in Buerger's disease, bache. And the most common form of tobacco use would be smoking, obviously. So the patient would have a history of smoking. Third important, beta, the patient should have signs and symptoms, beta. The patient should have signs and symptoms of distal ischemia. What are the signs and symptoms of distal ischemia, beta? I've already told you basically, beta. The patient is going to have intermittent claudication initially. Later on, there will be rest pain. Later on, there will be paresthesias, numbness, and coldness. Then the patient will progress into the stage of pre-gangrene, where there is color changes and ulceration of skin. And later on, there will be complete necrosis, beta. That is the stage of gangrene. Okay? All of these are signs and symptoms of distal ischemia itself. Okay? So, less than 40 to 45-year-old male, history of smoking, along with signs and symptoms of distal ischemia, are the three most important parameters of Ollen's criteria. If they ask you, beta, among the upper and lower limbs, which is going to be the more common site? I've already told you, beta, that a case of Buerger's disease which is there, it is much more common in the lower limbs, beta. Whether it is atherosclerosis or it is Buerger's disease, I've told you the most common site has to be lower limbs of the patient. Lower limb vessels will be blocked. Upper limb vessels, can they get blocked? Yes, beta. Upper limb vessels, they can get blocked, beta, but they are not more common. And if the upper limb vessels of the patient are blocked beta, obviously the upper limb is not going to receive enough blood supply. So just like we have intermittent claudication in leg beta, okay, what we are going to have in the arm, understand, whenever the whenever I will start writing beta, okay, obviously all my upper limb muscles are going to work, and as my upper limb muscles are working over here beta, their demand is more. And if there is a blocked artery beta in my upper limb, obviously it will not be able to supply the increased demand, and that's the reason I will start experiencing pain beta. So if I'm having a cramping pain in my upper limb as soon as I start writing, this is actually a intermittent claudication, which is usually seen in my upper limb beta, and this is classically referred to as the writer's spasm beta. Okay, so upper limb में the cramping pain on writing or the intermittent claudication which is there beta is classically called as the writer's spasm. No issues with this. As I told you, the features which are there beta, there will be intermittent claudication initially. Later on, the patient will have rest pain. Then there will be paresthesias, numbness, coldness. Along with that beta, there will be pre-gangrene and ultimately gangrene. So all those features are going to be seen over here also. If they ask you beta, what is the investigation of choice? I have told you beta, even whenever the peripheral vessels are going to be involved, investigation of choice has to be a duplex scan beta. So here also the investigation of choice is a duplex scan. If they ask you what will be the gold standard investigation बच्चे, तो याद रखना gold standard investigation is nothing else but an angiography beta. And we have discussed beta that when a patient will undergo angiography over here in a patient of Buerger's disease, a very classical feature is seen. Yes, when a patient of Buerger's undergoes an angiography, a very classical feature will be seen, and that has been an image based question of your FMG examination earlier. So yaad rakhna, what is that? See, we know that Buerger's is a cause of a gradual arterial obstruction. So obviously beta, your body will try to form collaterals. So here you can see the body has tried to form collaterals over here beta, and these collaterals which are there, they are giving us a very classical appearance. What is this appearance of collaterals seen on angiography called as? This is classically called as the corkscrew appearance of collaterals beta, right? This is known as the corkscrew appearance of collaterals. Basically that has to be remembered. Okay, this is what is classically known as beta the corkscrew appearance of collaterals. Okay, so that is important. No issues with this. Now if they ask you definitely beta, what is the treatment in the patient? Once a diagnosis has been made beta, you can definitely see beta, this has been a previous year image based question beta in a in your examination, when they gave definitely there was gangrene beta in the periphery of the patient beta, when the small vessels like the fingers or the toes could be involved. By looking at this picture, people thought that upper limbs are more commonly involved. No, it can be seen in upper limbs, but it is less common. Okay, no issues with this, anybody? Now if I talk about beta, what is the treatment? Obviously beta, here also the risk factors are modifiable. So the mainstay of management has to be what? Lifestyle modification. So mainstay or the first line management will always be lifestyle modifications beta. And in the lifestyle modifications, the same advice that you will give beta in as you have given in atherosclerosis, that is weight loss, regular exercise, quit alcohol and smoking beta. But the most important advice that is required over here is obviously beta, quit smoking. Okay, you just have to tell the patient either choose your fingers or choose smoking, but still the patient will choose smoking beta, obviously. But so lifestyle modification which is there beta, it is usually nothing else but quit smoking and alcohol. That is going to be the most important advice to be given. Yes, along with that, the other advices as I've told you in atherosclerosis will be there. Okay, that is important. ABPI you can use over here also. Yes, same diagnosis के लिए बाकी everything remains same. यहाँ पे clinical examination will also be exactly the same. Then you will go for investigation of choice. Take any gradual arterial obstruction में. Now important is beta, if I talk definitely about the lifestyle modifications were tried beta, but lifestyle modification failed. So in that condition beta, obviously what we have to go for? Next step, we have to go for a medical therapy beta or a medical treatment. Okay, medical treatment, the same 3 drugs that we gave in atherosclerosis beta. That is what? First were vasodilators, something like silastazole and pentoxifylline-like drugs. Second was the antiplatelet drugs like aspirin or clopidogrel. And third was definitely the statins beta. Those same 3 drugs can be used over here. Next important beta, we can directly go for lumbar sympathectomy now. Yes, over there in atherosclerosis, what we did, we usually tried beta doing a percutaneous transluminal angioplasty or a bypass grafting. but that both will not be possible in a patient of Buerger's disease. Why that will not be possible? Understand, beta. For example, beta, if I talk about a percutaneous transfemoral angioplasty, we have to insert a catheter, beta, and then we have to place a stent. Okay, but it is possible, beta, for the large vessels of your body. In Buerger's, it is the very small vessels which are involved. Will it be possible for a small vessel to do angioplasty? No, that's the reason. Second, why bypass grafting not possible? Reason, beta, I hope all of you are quite aware that when I told you about the bypass grafting, I told you that you will take a graft and you'll connect it proximal to the obstruction and distal to the obstruction. Okay, but the problem in Buerger's is what, beta? The problem in Buerger's disease is definitely, beta, here we are having the obstruction which is developing distal to proximal. Matlab, it has actually started from the distal parts of the vessel, beta. So now if the distal part itself is blocked, where I am going to connect the distal end of the graft? I cannot connect the distal end of the graft itself, na? Graft का दूसरा end connect क्या करोगे? That's the reason, beta, definitely even a bypass grafting is not possible. Okay, so the only option that will be left with you will be a lumbar sympathectomy in a case of Buerger's disease. Now, as I've told you, that statement that angioplasty and a bypass grafting which is there, beta, it is not possible to be performed in a patient of Buerger's disease. Now, in patients definitely. For example, beta, there is a person who has to undergo a bilateral lumbar sympathectomy, beta. Okay, he's having blockage in both of his lower limbs, beta, and therefore he has to undergo a bilateral lumbar sympathectomy. We know during a lumbar sympathectomy, we have to remove the L1 to L4 ganglia, beta. And if it is a bilateral lumbar sympathectomy, beta, we had to remove L1 to L4 ganglia on both the sides. And if we do this, beta, then the patient will never be able to get a penile erection ever in life. The patient will have an impotence throughout his life. Reason, beta, the same lumbar sympathetic ganglia, beta, they are actually going to supply the penile vessels. That's the reason, beta, those penile vessels can dilate and then there is increased blood flow towards the penis causing a penile erection. Okay? So if you are going to cut all the lumbar ganglia, beta, the patient will never get a penile erection. So क्या करना है? In bilateral lumbar sympathectomy, beta, we actually save at least L1 ganglia, beta, and at least on one side. अब कम से कम एक तरफ का L1 ganglia छोड़ दो, ठीक है? On one side, beta, at least leave one L1 one ganglia, beta, and that is L1, ठीक है? So whenever you have to go for a bilateral lumbar sympathectomy, whenever you have to go for a bilateral lumbar sympathectomy, please remember at least spare, okay, at least spare L1 ganglia, beta, unilaterally, as I've told you. To avoid what problem? To avoid impotence, beta. Okay, so that is important to remember. That is all about your Buerger's disease. Now let's talk about the next condition. And that is nothing else but Raynaud's phenomena. Easy one. Now if I talk about the Raynaud's phenomena, shall I? If I talk about the Raynaud's phenomena, what is Raynaud's phenomena? Understand. Raynaud's phenomena is basically spasm and dilatation, beta. It is spasm and dilatation of the small vessels, either in the tip of the fingers or in the tip of the toes of a person, beta. That is what is the Raynaud's phenomena. Okay? So it is spasm and dilatation of the arterioles and venules, beta. And due to the spasm and dilatation, beta, there is a sequence of color change which is usually seen in the fingers and the toes, beta. What is that? Let's see. So here, bache, you can see, just a minute. We have an arteriole, beta, and then we have a venule over here. Can you see the arteriole and venule? Both of them definitely, beta, they are in spasm. As both of them are in spasm, beta, the tip of the fingers, they are not able to receive any blood supply. And as it is not able to receive any blood supply, beta, that's the reason definitely you are able to see pallor, or you can say it is a white color, beta, right? You are able to see pallor or there is white color. Next important, beta, what happens is here now the venules are still in spasm, beta, but the arterioles are going to dilate now. As the venules are still in spasm but the arterioles are dilated, what will happen? There is definitely, beta, the oxygenated blood will start coming, but all this oxygen will get used up and a lot of deoxygenated blood will collect over here, beta. Right, there will be mixing of the oxygenated and deoxygenated blood. When deoxygenated blood is going to pool up over there, obviously, beta, the color of the fingers is now going to change and it is going to become blue in color, beta. Right, the color of the fingers will change and it will become blue or cyanotic in color. Last important one is, beta, arterioles are already dilated, The venues are also going to dilate beta, and now there will be a normal blood flow which will start at this side, and that's the reason now the color of the fingers beta, it has come back to normal. That means it has come back to red beta. Clear है बात? So white, blue and red बच्चे, white, blue and red is the sequence of color change which is seen in patients of Raynaud's phenomena. This has been a previous year question of FMJ examination. What is the sequence of color change beta? क्या बेटा डिस्टल मतलब सबसे कोने से ऑब्स्ट्रक्शन स्टार्ट होता है. इफ द ऑब्स्ट्रक्शन इज गोइंग टू स्टार्ट फ्रॉम दिस एंड, वेयर आर यू गोइंग टू कनेक्ट द डिस्टल एंड ऑफ द graft basically? It's not possible only to do a grafting, right? So white, blue and red basically, if I talk about beta, these are the sequence of color changes which are seen in a patient of Raynaud's phenomena beta. Clear about that is important. Now if I talk about Raynaud's phenomena beta, it is nothing else but the spasm of arterioles bache. Okay, it is nothing else but the spasm of arterioles and the spasm of venues which will happen beta in the tip of the fingers or in the tip of the toes, which leads to the sequence of color changes, that is white, blue and red beta. Okay, that you are able to see. Now important is beta yaad rakhna that these color changes which are there beta, they are usually associated with some risk factors. So Raynaud's phenomena is associated with two most important risk factors beta. One definitely is a cold exposure beta. So if a person is exposed to cold environment or cold water beta on a recurrent basis, like housewives for example, right, they will be at the risk of developing Raynaud's phenomena. Or definitely beta, the second risk factor is prolonged vibration. Okay, so for example, you might have seen beta those people who drill the roads basically, they definitely are exposed to prolonged vibration with those machines basically, right? Those people are also at a very high risk of developing Raynaud's beta. So cold exposure or prolonged vibration which is there beta, cold exposure or a prolonged vibration which is there, these are the two conditions basically which I considered as the most important risk factors beta for a Raynaud's phenomena. Initially they used to only mention about cold water exposure, but now they have started mentioning about prolonged vibration in the recent questions. So please remember that it is also an important risk factor. If they ask you beta, more commonly it is seen in males or females, so yaad rakhna hai beta that Raynaud's phenomena is going to be more commonly seen in females, and that too young or middle aged females beta. Now why it is going to be more common in females beta, let's talk about that. Okay, so you have to remember that there are two types of Raynaud's phenomena bache. One is called as the primary Raynaud's phenomena, and this primary Raynaud's phenomena itself is known as Raynaud's disease beta. So agar wo Raynaud's disease de de, it is one and the same thing. Okay, so primary Raynaud's phenomena is also known as Raynaud's disease beta, whereas secondary Raynaud's phenomena we have. Now primary Raynaud's phenomena which is there beta, or the Raynaud's disease which is there, here the cause is unknown beta. That means it is idiopathic. Here the cause is not associated with any other condition. Okay. Next important, if I talk about the secondary Raynaud's phenomena beta, secondary mein it is usually associated with some other disorders beta. Yes, secondary mein beta, secondary Raynaud's phenomena is usually seen in those patients who are definitely suffering from connective tissue disorders. What are connective tissue disorders? SLE, rheumatoid arthritis, scleroderma, Sjogren's syndrome, all of them beta. Okay, so usually if Raynaud's phenomena is seen in females who are already suffering from connective tissue disorders beta, that then it will be called as a secondary Raynaud's phenomena, because then it is secondary to that particular disorder बच्चे. ठीक है, तो याद रखना है primary Raynaud's phenomena or Raynaud's disease is idiopathic in nature. Secondary Raynaud's phenomena is associated with connective tissue disorders beta, and we know that connective tissue disorders are more commonly seen in females. That's the reason definitely beta you have to remember that even Raynaud's phenomena is going to be more commonly seen in females beta. Clear about? Now, if they ask you what is the treatment in a case of Raynaud's phenomena, तो याद रखना है lifestyle modifications will be the first line management again. ठीक है, तो lifestyle modifications will be the first line management. And what should be done in lifestyle modifications? You have to ask the patient to avoid the risk factors beta. Okay, obviously ask the female definitely if she wants to immerse her hands in water, she at least should use cold water beta for all the household works that she has. Like sorry, she should use definitely warm water instead of cold water beta. Okay, for all the household works that she has. Apart from that, you can ask the person beta to change basically the job. For example, he is exposed to the prolonged vibration. Okay, that is important. Apart from that, you can ask the patient to wear warm clothing basically, so that the patient is not exposed to the cold environments. Okay, so that is important. Gloves you can ask the patient to wear. Now, even after giving lifestyle modifications, or even after prescribing lifestyle modifications in the patient beta, if you are not able to see any improvement in the patient, in that conditions beta, we have to give medical management. एंड अगर मेडिकल मैनेजमेंट की बात करें बेटा तो प्लीज रिमेंबर द ड्रग ऑफ चॉइस फॉर रेनॉल्ड्स फिनोमेना are going to be CCBs. What are CCBs beta? It is nothing else but calcium channel blockers. Okay, so do remember CCBs or calcium channel blockers like nifedipine, okay, or verapamil. These could be definitely beta the drug of choice to be used in a patient of Raynaud's phenomena. Followed by that beta, the second best drugs will be nitrates. Reason nitrates have a lot of side effects like hypotension vagara. That is the reason nitrates are not the first choice. The safest drug which is they've given beta in this patients is going to be CCBs or calcium channel blockers. This has been a previous year question of FMG exam. Okay, so that was all about your Raynaud's phenomena beta that you need to remember. Now let's talk about the next one beta, and that is, till now beta we have spoken about the gradual arterial obstruction. That means the arterial obstruction which develops very slowly. Now let's talk about the sudden arterial obstruction beta. Okay, and that sudden arterial obstruction which is there beta is going to be called as embolism. Right, that sudden arterial obstruction which is there beta is going to be called as embolism basically. Now what is embolism? Understand, for example, the patient basically beta had a atrial fibrillation. I hope all of you are quite aware beta that atrial fibrillation means what happens, that the atria of the patient are just twitching, and as the atria are just twitching beta, the blood is not pumped out properly from the atria. So there is a lot of pooling of blood or stasis of blood inside the atria, and that's the reason beta there is a very high risk of thrombus formation inside the atria. Clots or thrombus are going to form inside the atria beta. Now what happens, one fine day beta, one fine day, these clots or this thrombus usually get separated from here, and now they go to a peripheral blood vessel beta, and they cause complete blockage of that vessel. They go to some peripheral blood vessel beta, and over there they cause almost, okay, 80% 90% blockage of that vessel beta. Now here the arterial obstruction or the arterial blockage has developed all of a sudden. So this is the sudden arterial obstruction beta. Now till the time a clot was over here itself beta, okay, this will be called as a thrombus. But when a thrombus gets separated from its original site, travels to a new place, and then causes a blockage beta, then it is going to be called as an embolus, and this phenomena is known as embolism. Okay, so let's talk about embolism now. So embolism is nothing else but beta a sudden occlusion. Okay, embolism is nothing else but a sudden occlusion of a vessel beta by a foreign substance, and that is not usual. That is nothing else but a thrombus basically, which has come from somewhere else. Okay. Now important is here what is going to happen. Suddenly beta, all of a sudden, the limb or the upper extremity or the lower extremity beta will not receive enough blood supply. That means it will undergo ischemia beta. So here what happens, all of a sudden there is an acute limb ischemia which develops, and due to acute limb ischemia beta, please tell me, will the body have enough time to develop collaterals? No. तुम बोलोगे सर कोलैटरल्स डेवलप हो जाएंगे. प्लीज रिमेंबर बेटा, कोलैटरल्स यूजुअली डेवलप इन अ ग्रेजुअल आर्टेरियल ऑब्स्ट्रक्शन. इट यूजुअली टेक्स टाइम फॉर द कोलैटरल्स टू डेवलप. बट यहाँ पे तो बेटा देयर वाज अ सडन almost complete obstruction of the vessel na, so therefore the body does not have enough time beta to form the collaterals. So in sudden arterial obstruction there is no collateral formation which can happen, and as there is no collaterals itself beta, the distal part of the obstruction will not receive the blood supply at all, and when it will not receive the blood supply at all beta, obviously it will immediately start undergoing necrosis. It will be immediately start undergoing gangrene beta, and that's the reason beta embolism will be considered as a vascular emergency. Embolism will be considered as a vascular emergency beta. Clear about that has to be remembered. Now if they ask you beta that what is going to be the most common source of embolus, so please remember, if they ask you the most common source of embolus beta, okay, the most common source of embolus is nothing else but the heart beta, as I've told you. The most common source of embolus is the heart, and they will intentionally give you beta the history of atrial fibrillation in the question. Okay, so you have to remember, okay, atrial fibrillation means they are telling me stasis of blood, and that means I have to think about a thrombus formation in the heart. Clear about? So most common source of embolus is going to be the heart itself. From there it is going to come, and it can block any vessel beta. Now please remember bache, in a patient of embolus or a sudden arterial obstruction, there are classical 6 P's which are going to be there. Okay, the classical 6 P's. What are those? Let's see them one by one. The first one beta, as the vessel is completely blocked bit almost, the part distal to it will not receive blood supply, and that's the reason beta there will be a pallor on the skin which will be visible. First P. Second beta, as the nerves will not receive blood supply, the nerves will get irritated initially beta, and they will cause extreme pain beta. The patient will have a lot of pain. Next beta, now the nerves which is there, now the nerves which are there beta, they will start getting damaged, and as the nerves will start getting damaged beta, obviously the patient will have decreased sensation. And I hope all of you are quite aware, decreased sensation is known as paresthesia. Next important beta, here the skin is also not receiving blood supply beta, and as the skin is not receiving enough blood supply beta, there will be coldness on the skin, and to just make a P out of it, we have definitely called coldness as poikilothermia beta, right? So please remember, coldness is nothing else but poikilothermia, right? Next important beta, even the muscles are not receiving enough blood supply. That's the reason beta, the muscles will undergo, okay, the muscles are not receiving enough blood supply. That's the reason beta, the muscles will undergo weakness, that is paralysis. And the last sign which is going to be seen beta, yaad rakhna, the last sign which is going to be seen is nothing else but beta, pulselessness. Okay, completely the pulse is going to be absent beta, distal to the obstruction. Okay, this has been a question that which is the last sign, sorry, which is going to be the last sign beta in a patient of embolism. So yaad rakhna ye baat, the late sign or the last sign in patients of embolism beta has to be pulselessness beta. The last sign has to be pulselessness. Please remember that. Okay, the pallor, pain, paresthesias, poikilothermia, that is coldness, paralysis, that is muscle weakness, and pulselessness beta are going to be the 6 P's in a patient of embolism. Clear about? If they ask you beta, what is the investigation of choice in the patient now? Obviously, again, peripheral vessels are blocked beta, so investigation of choice has to be a duplex scan. As the peripheral vessels are blocked, investigation of choice has to be a duplex scan beta. Apart from that beta, now if I talk about the treatment, okay, what should be done for the treatment of the patient? So do remember, treatment ke liye beta, the first line management which is there, okay, treatment ke liye beta, the first line management has to be giving a low molecular weight heparin injection. Reason is beta, why I have to give an injection of low molecular weight heparin? Because for example beta, due to the embolus, if the blood vessel is almost 85% blocked, do you want the embolus to increase in size further and the vessel to get completely blocked 100%? Obviously not. That's the reason beta, you have to prevent the further extension of the thrombus. You have to prevent the thrombus from growing further, and that's the reason, to prevent the further extension of the thrombus beta, we have to give the first drug which is the anticoagulant of choice in emergency beta, and that is nothing else but a low molecular weight heparin has to be the first drug to be given in the patient. Clear about? That is important. Once definitely that is given beta, now we will start definitely beta the management. If I talk about the management beta, if the patient has presented to me early, if my patient has presented to me early beta, what would be done now? If the patient has presented to me early, that means what? Within 6 to 8 hours of obstruction, within 6 to 8 hours of blockage beta, if the patient presents to you, that means here the gangrene would not have started beta. Yes, until now the gangrene would not have started. We can save the fingers basically beta. What could be done in this case? We can insert a Fogarty's catheter beta, and with the help of Fogarty's catheter, can I remove the embolus? Yes. So we will insert a Fogarty's catheter, and with the help of Fogarty's catheter beta, we are going to remove the embolus. Removal of embolus, I hope all of you are quite aware, is known as an embolectomy beta. So you can call it as embolectomy. Thrombectomy bol sakte ho, embolectomy. Okay. So if the patient presents to me early, we can go for an embolectomy. But beta, if it is a very, very small blood vessel, is it possible to insert a Fogarty's catheter and remove the embolus? No. In that condition, it may not be possible. So in those conditions, at least, can I break down the thrombus into pieces beta? Yes. And I hope all of you are quite aware, when you are going to break down the thrombus into pieces, that is what is called as thrombolysis beta. That is what is known as thrombolysis. Okay. And the thrombolysis which is there, I hope all of you are quite aware, it is done with RTPA beta, that is recombinant tissue plasminogen activators beta. And these recombinant TPA drugs which are there beta, they are nothing else but drugs like alteplase, reteplase, tenecteplase, right? These are the common thrombolytic agents beta which can be used. Okay. So the better treatment is always embolectomy beta. But if embolectomy is not possible in the patient due to the smaller caliber, then you can go for a thrombolysis also. No issues with that. But if the patient has presented to me late beta, what is late basically? That means already the gangrene has begun over there. When my patient presents to me late beta with already gangrene at that particular site, obviously I cannot save that limb. I have to go for what? I have to go for an amputation beta. We have to go for an amputation over there. Clear hai? Chalo. So that was all about your sudden arterial obstruction beta, known as the embolism. Now, a recent question. Okay, this topic basically I thought ki okay, this is less common. Chalo, usually I was about to scrape it out basically from the examination, because in the recent NEET PG it has not been coming, but in the recent 6 July examination beta, this topic appeared in your exam. ठीक है, ऑलमोस्ट एवरीबडी मार्क्ड इट एज द वेरिकोज वेन्स, वेरी फ्यू पीपल मार्क्ड इट एज एवी फिस्टुला। ठीक है, याद रखना बेटा, देयर हैज बीन अ रीसेंट क्वेश्चन 6 जुलाई इटसेल्फ इन द exam from this AV fistula. Now what is AV fistula beta? AV is nothing else but an arteriovenous fistula beta. Okay, AV is nothing else but an arteriovenous fistula. If I talk about an arteriovenous fistula, what is a fistula? We know beta, it is an abnormal connection. Now it is an abnormal connection beta with two organs basically. So here one side we have the artery beta, one side we have the vein. Okay, and the connection between them is what is called as a arteriovenous fistula. So if there is an abnormal connection beta between an artery and a vein, that is what is called as a AV fistula. What can be the causes of an AV fistula, bache? It can definitely be a penetrating trauma, a very common cause which is there beta, penetrating trauma. So in the recent question in your examination also beta, which they gave, they said that the patient has a history of trauma 10 years back. Okay, so that is important. So penetrating trauma definitely could be a most important cause beta for a AV fistula to develop. Next important can be infections, because infections can cause erosions of the vessels, and that's the reason they can lead to formation of a fistula. Malignancy, because we know malignancies can cause invasion of the blood vessels, and it can be congenital also. In pediatrics you might have discussed about the congenital AV fistulas. Okay, now it can also be iatrogenic beta. What is iatrogenic? We are going to create a fistula. Now why we have to create a fistula beta? So in any patient who has to undergo a hemodialysis or a renal dialysis beta, in those patients definitely we need a fistula. Okay, and where is that fistula commonly created? That fistula is commonly created beta in the patient's cubital fossa, between the two vessels. Which are the two vessels? One is the radial artery, second is definitely the cephalic vein. Yes, so we have to create a fistula beta usually between the radial artery and the cephalic vein, bache. And this arteriovenous fistula which is there, which is created for the purpose of renal dialysis, or which is iatrogenic in nature, is classically called as, remember the name, it is known as the Brescia semino fistula beta. This fistula which is there, which is known as the Brescia semino fistula. Clear to all of you? That has to be remembered. So Brescia semino fistula which is there beta, it is the iatrogenic fistula created for the purpose of renal or hemodialysis. Now what will be the picture in the patient? Let's talk about that. When a patient has arteriovenous fistula, what are all the problems? Now let's see. Shall I? Chalo. Okay. Now important is, if I talk about beta, this is the artery. We know arteries are larger in size, they are located deep beta, and second definitely they are going to have more pressure bache. On the other hand, if I talk about a vein bache, vein are smaller in size, they have less pressure, they are usually more superficially located beta. Okay, and this is an abnormal connection between both of them beta, that is a arteriovenous fistula that is developed. Can you see this one? This is a AV fistula. Now what is going to happen? Normally I told you beta that there is more pressure inside the arteries basically, and there is less pressure inside the veins. Obviously, from where is the blood going to go where? We know beta, the blood will always travel basically from the arteries to the veins beta. As arteries have higher pressure, so the blood will always go from an artery to the vein beta. Now, as there is a lot of blood coming into the vein beta, we know that veins are usually smaller. So as there is a lot of blood coming into the vein beta, to accommodate that blood basically, this vein which is there beta, it will start undergoing dilatation. This vein of the patient which is there beta, it dilates. And when it dilates too much beta, it also becomes tortuous basically, twisted. Okay? So please remember beta, as there is a lot of blood coming into the vein, this vein is going to dilate and it is going to become tortuous. We know that veins are superficial, therefore superficially itself beta, you will be able to see this swelling beta, which is due to the dilated and the tortuous vein. One thing. Second important beta, now from the artery, how the blood is going to come? Now from the artery beta, the blood in the vein usually comes with each pulse, right? There is more blood pushed beta into the vein with every pulse, right? So definitely the swelling which is seen over here beta, it will actually show us pulsations, right? That is going to be a pulsatile swelling. And this was the hint which is mentioned in the question beta, that pulsatile swelling was seen. And if pulsatile swelling, if they have mentioned beta, that has to be a case of arteriovenous fistula, it cannot be varicose veins. Varicose veins mein swelling is seen, dilated vein is seen, but no pulsations are seen. Okay, so that is important to be remembered. That has been asked in the recent exam. Okay, so please remember, as I've told you beta, here there will be an abnormal dilatation and engorgement. Engorgement means fullness. There is a lot of blood in the vein now, so there is abnormal dilatation and engorgement of the vein beta. And due to this dilatation and engorgement of the vein beta, we are able to see which kind of swelling, as I've told you, we are able to see pulsatile swelling. Some important pulsatile, I hope all of you quite remember. Pulsatile swelling, if they say beta, it is suggestive of AV fistula. Pulsatile proptosis, if they say, that is suggestive of cavernous sinus thrombosis. Pulsatile tinnitus, if they say beta, that is suggestive of a tumor known as glomus jugulare bitche. Okay? These are the pulsatile ones. And pulsatile bony metastasis, we will discuss beta, that is suggestive of renal cell carcinoma. Okay? Sure. So now important is beta, if I talk about the auscultation basically. So auscultation pe kya hoga? Understand. We know beta that the veins which are there, they have less pressure. Okay, and therefore they have a linear blood flow. But as there is a lot of blood coming into the veins now beta, the pressure inside the veins is very very high. And as the pressure in the vein is very high beta, it is basically going to have which kind of flow beta? It is going to have a turbulent flow. That is the reason beta, when you auscultate over this pulsatile swelling or when you auscultate over the vein beta, you will be able to hear that turbulent flow noise, and that is called as a bruit beta, right? Auscultation beta, definitely you will be able to hear a bruit. That has to be remembered. Now next important beta is when we are going to compress the artery beta, what is going to happen? See, understand, proximal to the fistula beta, we have to compress the artery. Okay, proximal to the swelling, proximal to the fistula, I am going to compress the artery. Here is the fistula, I am going to compress the artery over here. Now what is going to happen beta? As I have compressed the feeding artery itself, the fistula is not receiving the blood supply, the vein is not receiving the blood. That's the reason beta, the swelling is going to decrease in size beta. The size of the swelling decreases. Second, the pulsations in the swelling are going to decrease basically. The pressure in the swelling is going to decrease. The bruit in the swelling is going to decrease, right? That is important to be remembered beta. So yaad rakhna, here if I press the feeding vessel or the feeding artery itself beta, obviously the size, the pulse rate, the systolic BP and the bruit, everything reduces beta in the swelling, and this is classically called as which sign? Remember the name of the sign. This is classically called as a Nicoladini-Branham sign beta. What is this sign called as? So do remember, this is classically known as the Nicoladini-Branham sign. No issues with this. Next important beta, if I talk about basically what is the investigation of choice in a patient. Yaad rakhna, the investigation of choice in the patient which is there. Again, we are talking about AV fistula beta, but the problem is here the fistula which is there, it is going to be very very small beta, and that is the reason you may not be able to see it with the help of a duplex scan. It could be deeper also at times. That's the reason beta, the investigation of choice has to be a MR angiography. Okay, so only exception beta jahan pe you will see MR angiography as the investigation of choice is the AV fistula. Baki everywhere is it either it is a duplex scan or a CT angio. Okay, so here the investigation of choice you have to remember beta has to be an MR angiography. Clear about? Next important, if they say what is the management in a patient of AV fistula. So if they say the patient is asymptomatic, I always say one thing, if the patient is asymptomatic, will the patient come to us? No. So obviously beta, even if the patient comes to us, the treatment is nothing else but beta observation. Okay, so that is important beta, the treatment is nothing else but observation. So please remember beta, the treatment of the patient which is there is going to be observation if the patient is asymptomatic. But if the patient is symptomatic beta, then what should be the first line management? The first line management should be to close the fistula. How I am going to close the fistula? Understand. We are actually going to inject beta embolizing substance which is going to block the fistula. If you inject embolizing substance which will block the fistula beta, this procedure is known as angioembolization. So please remember the first line management which is there beta in blocking the fistula has to be an angioembolization. Okay, but if you have tried an angioembolization beta, but even after that it fails, you have tried an angioembolization but even after that it has failed beta, so in that condition what should be done? In that condition definitely you have to go for beta a surgical ligation now, right? You have to open it up and we have to go for surgical ligation of the fistula. Hopefully that's clear to all of you now. Clear? Chalo. So that is important. Now let's talk about the next topic beta, and that is aneurysms. Now if I talk about aneurysms beta in the patient, done with this. Hopefully. If I talk about aneurysms beta, please remember aneurysms which is there. What is aneurysm? It is nothing else but abnormal dilatation of a vessel. Yes, if there is too much dilatation of a vessel beta, for example this one. Okay, here you can see both the walls of the vessel have dilated beta. This is a aneurysm basically. Or If you can see this, this one which is there beta, it is what is also called as an aneurysm. Now this sac like which is there beta, this sac like aneurysm which is there beta is called as a saccular aneurysm, and this one which is seen in the body itself beta is called as a fusiform aneurysm. So these are the common types of aneurysm beta. One is the saccular aneurysm, second is the fusiform aneurysm. That has to be remembered. So this is what is called as aneurysm beta. Now we know that if the patient is going to have aneurysm of a vessel, obviously the vessel wall is going to thin out beta. And if there is thinning of the vessel wall beta, the patient will have a very high risk of rupture also beta. If the aneurysm is very big in size, the patient will have a high risk of rupture. If they ask you that aneurysms which are there beta, they are going to be more common. Okay, aneurysms which are there beta, they are going to be more common in which age? We remember that we know the vessel wall of which patients are going to be weak, or the blood pressure in which patients is going to be high. Obviously it is the elderly patient beta. So due to high blood pressure and the weak vessel wall, elderly patients are at a higher risk of developing aneurysms beta. What are the risk factors? As I've told you beta, whenever the pressure inside the vessel is going to increase, obviously the tendency to form an aneurysm is going to increase over here beta. Okay? Kaise? So for example, if a patient is having atherosclerosis, I've just now told you, if a patient has a atherosclerosis beta, proximal to the obstruction, definitely the blood flow is very high, the blood pressure is very high. That is the reason beta, there will be a lot of pressure on the vessel wall, and that's the reason there will be dilatation of the vessel wall leading to formation of an aneurysm. So please remember, a very important risk factor is atherosclerosis beta. Other conditions where definitely beta, the vessel wall of the patient is weaker, and those conditions are, first is Marfan syndrome beta due to fibrillin gene defect, or the Ehlers-Danlos syndrome बच्चे due to collagen 5 defect mainly. ठीक है? So these are the conditions beta where definitely the vessel walls of the patient are going to be weaker, and that's the reason the risk of aneurysm is going to be higher. If they ask you what are the sites beta where aneurysms could be seen, let's talk about that. If they ask you the most common vessel for forming an aneurysm, the most common vessel beta for aneurysm formation is the circle of Willis beta. Yes, we know that circle of Willis, that is the blood vessel supplying the brain. They are the most common site beta for aneurysm formation. I hope all of you are quite aware. We have discussed about spontaneous rupture of berry aneurysms, which was seen in the circle of Willis or the anterior communicating artery beta. Okay, that led to which kind of hemorrhage? Subarachnoid hemorrhage beta. Clear about? So the most common vessel beta which is affected with aneurysm is the circle of Willis. If they ask you which is the most common extracranial vessel beta outside the brain, if they ask you, definitely which is the most common vessel. So we know that atherosclerosis is the most common risk factor. That's the reason beta, we have to remember that atherosclerosis is more commonly seen in which vessel? Abdominal aorta. So therefore the most common extracranial vessel beta for aneurysm to develop has to be an abdominal aorta beta. It has to be an abdominal aorta bache. No issues with this, anybody? Next important, if they ask you beta, which is the most common peripheral vessel? So yaad rakhna hai beta, the most common peripheral vessel which is involved is going to be, which was the most common peripheral vessel for atherosclerosis? We know beta, it was the popliteal artery. So you have to remember here also the same thing is going to follow beta, that the most common peripheral vessel involved with aneurysm has to be the popliteal artery itself, and this was another previous year question. Okay, so please remember the most common peripheral vessel which is involved for aneurysms beta has to be the popliteal artery. Next important, if they ask you which is the most common visceral artery beta or the visceral vessel, so yaad rakhna visceral vessels mein, visceral matlab the one which supplies the inner organs beta or the internal organs. So most common visceral vessel which is there beta is going to be the splenic artery. Okay, so splenic artery is the most common visceral vessel. Next, if they ask you which is the most common vessel beta for pseudoaneurysms basically. So the most common vessel for pseudoaneurysm, if they ask you beta, answer has to be the femoral artery beta. The most common vessel for pseudoaneurysm which is there beta, the answer has to be a femoral artery. No issues with this, anybody? These are the important points beta. These are the important one-liners to be remembered for aneurysms beta. Now if I talk about beta, what will be the clinical features in the patient? Okay, if I talk about what are going to be basically the clinical beta, arteries have more pressure. Abhi to bataya maine. Arteries have more pressure. That's the reason arteries will be the more common site. Pressure is the reason now why the vessels are going to dilate. Next important beta, it is not only the arteries, it is more commonly the arteries. Veins can get definitely. Now, if they ask you, beta, if what is the clinical feature basically, so please remember, beta, the clinical feature which is there, it is nothing else but most of the aneurysms which are there, if they are smaller in size, beta, okay, please remember the most common presentation is nothing else but asymptomatic. Yes, majority of the patients, beta, if the aneurysm is very, very small, they will have no symptoms, beta, they will be usually asymptomatic. Now, if the symptoms are there, beta, what will be those symptoms? The patient will have expansile pulsation, beta, right? That aneurysm, if it is in the periphery, for example, that may be seen as a swelling also at times, and then you will be able to see, beta, this kind of a expansile pulsations basically, right? So expansile pulsations can be seen first thing, or beta, if for example there is a aneurysm arising from the abdominal vessels, beta, like the abdominal aorta, on deep palpation, beta, you may also be able to feel a lump in the abdomen as well. Yes, you can feel a lump in the abdomen also, beta, on palpation. And please remember, due to that lump in the abdomen, when there is aneurysm from the aorta, patient may also have discomfort, beta, and at times even pain will be there. The patient may have some kind of discomfort, and the patient may have pain also. Please remember, beta, as I've told you already, that aneurysms की वजह से there is thinning of the blood vessel wall, and that can increase the risk of rupture, beta. So for abdominal aorta, beta, what is the critical diameter after which the aneurysms are going to rupture? Okay, that critical diameter we need to know now. Otherwise, we are not going to treat the patient, and the patient will directly come to us with a ruptured aneurysm. Okay, so याद रखना बेटा, the rupture which is there, it is usually seen after the critical diameter, beta, and that critical diameter for an abdominal aortic aneurysm is going to be more than equal to 5.5 centimeters, beta. It is going to be more than equal to 5.5 centimeters, beta. Okay, so that is important to be remembered. So if the abdominal aortic aneurysm is more than equal to 5.5 centimeters, the chances of rupture are very, very high. It will definitely be different for all the other arteries, beta. Like femoral arterial, it is more than equal to 3 centimeters. Popliteal arterial, it is more than equal to 2 centimeters. Okay? Likewise, if they ask you, beta, what is the investigation of choice? So do remember that investigation of choice, if I talk about bache, is going to be a CT angiography. Why? Because I've told you the most common vessel is circle of Willis. Second most common vessel is abdominal aorta. Both of these are central vessels, beta. That is the reason if they ask you what is the investigation of choice, you have to remember, beta, the investigation of choice has to be a CT angiography. And when we go for a CT angiography in the patient, beta, do remember a very classical picture will be seen. Okay, so CT angiography की है. Here you are able to see, beta, this one which is there. This basically is the dilated part, beta. This is the main aorta na. So here you are able to see, beta, this is what is the dilated part, and the dilated part which is there, or that aneurysm which is there, beta, it is basically seen as a half moon shape, and anything which appears like a half moon, beta, should be called as what? Should be called as a crescent, beta. Okay, or meniscus. So this is classically called as crescent sign or the meniscus sign, beta. This is classically known as the crescent sign or the meniscus sign, beta. So crescent or meniscus sign on the CT angiography, beta, is what is suggestive of aneurysm in a patient. Okay. Now if I talk about, beta, what should be the treatment of the patient? So let's talk about the treatment. If they say when the treatment should be given, beta, SDH नहीं बेटा, SAH होता है, subarachnoid hemorrhage happens due to this. No issues with this, anybody? Yes, varicose has dilated veins, beta. That is what is called as the varicosities basically. So that is nothing else but a type of aneurysm itself, rather a pseudo aneurysm itself in the veins, right? So that is what aneurysm ka literal meaning is, only dilatation. We don't call it as aneurysm, but it is nothing else but varicosities are nothing else but a type of pseudo aneurysm itself. Okay. So please remember, beta, if I talk about the treatment basically, if the patient is symptomatic, okay, if the patient is symptomatic, we have to treat the patient. Or if the patient is having a critical diameter, that means if the diameter of the aorta is more than equal to 5.5 centimeters already, so after this there will be a risk of rupture. So you have to treat only the symptomatic patients, or you have to treat all the patients, beta, who have a critical diameter. Okay, so definitely otherwise the patient will have a risk of rupture. So what is the treatment, beta? Obviously, bache, here, for example, this is the aneurysm. What we can do, can I just this is the aneurysm, beta. Can we just place a graft inside it, beta? Yes. Why? Because when I place a graft inside the vessel, the blood is going to travel via the graft, beta. So that what is going to happen now, it is not going to come in contact with the wall, and as it is not going to come in contact with the wall, beta, the pressure on the wall will be less, and therefore the wall may come back into the normal position in majority conditions, beta. Okay, so that is important to be remembered. So this is important, but this is what is done basically. And this is either called as a open, either we can go for open surgery beta, either open or a endovascular, either an open or an endovascular, okay, Dacron graft repair. Why Dacron? We know beta that it is a large vessel, that is a aorta. So we have to go for beta a open or an endovascular Dacron graft repair has to be done. Clear about? And this endovascular repair itself beta can be called as EVAR. Now what is EVAR basically? So in case if they use this term EVAR bagara, do not get confused, it is the same thing. EVAR is nothing else but endovascular aneurysmal repair. Okay, it is the same thing beta, that has to be remembered. So open or endovascular Dacron graft repair beta, that has to be remembered. Either open Dacron graft repair or endovascular Dacron graft repair. And yet endovascular repair itself is called as EVAR beta. Now next question which is there beta, we have to remember. So that was all about your aneurysm bache. This was all about your aneurysms. Now let's talk about the next topic, that is from the aorta, and that is going to be beta, nothing else but aortic dissection. Very common topic in the recent exams beta. Okay, it is also in the NEET PG and FMG exams. Most of the times one question at least is seen from this topic. Okay, so let's talk about aortic dissection. Now here you can see beta the patient, how the presentation is going to be. A patient presents beta with a diffuse chest pain. The patient presents to you beta with a diffuse chest pain, and that chest pain is radiating to the interscapular area. Now what do I mean by interscapular area? Exactly in the center of the back beta. Okay, the patient has a pain referring or radiating beta exactly to the center of the back. This is the classical appearance beta. The blood pressure of my patient is going to be around 90 by 50 millimeters of mercury. That means my patient is hemodynamically unstable. What is the investigation of choice? Now here beta the classical presentation which is there is diffuse chest pain radiating to the interscapular area of the back. Please remember, yes, the chest pain also radiates beta to the back in patients of myocardial infarction, but that usually radiates to the left side of the back, and along with that it also radiates to the left shoulder, left arm and the jaw of the patient. Okay, but here beta in aortic dissection the pain only and only radiates to the center of the back beta or the interscapular area. Very classical hint. Okay, now what will be the investigation of choice? We'll discuss about that once we have talked about the topic. Now if I talk about beta the aortic dissection, basically what is aortic dissection beta, let's try to understand. See, we know beta that in the vessel wall how many layers are there? I hope all of you are quite aware. There are 3 layers in the vessel wall beta. One is the tunica intima, second is the tunica media, and third is the tunica external beta. Okay, what happens now basically here inside the artery beta, there is a very high pressure, right? Inside the aorta beta in this patient there's a very high pressure, and as there is very high pressure inside the aorta beta, what is going to happen? Understand, as there is a very high pressure in the aorta, the tunica intima which is there, the innermost layer of the aorta which is there beta, the tunica intima, it undergoes a tear. As there is a lot of high pressure now, there is a lot of pressure inside the aorta beta. Due to that there is a lot of strain on the tunica intima beta, and therefore it undergoes a tear. Now as it undergoes a tear beta, what is going to happen? Understand, here beta the blood which is there beta, it is passing by the main lumen. A lot of blood will also start entering this tear beta. Okay, a lot of blood will also start entering inside this tear. Okay, and due to that beta, as more and more blood is coming inside the tear beta, the tear of the patient will keep on increasing. The tear inside the aortic wall of the, where is the tear? The tear is inside the aortic wall beta. The tear in the aortic wall beta, it will keep on increasing further, and there will be such a point beta where actually there will be more blood inside the tear than in the main lumen of aorta. Right, there will be more blood beta in the tear rather definitely in the aortic lumen beta. That has to be remembered. Now please tell me, if there is less blood inside the aortic lumen, obviously the organs are also going to receive less blood beta, and when the organs are also going to receive less blood, what is going to happen? For example, if the kidneys receive less blood, the patient will land up into acute renal failure. If the heart receives less blood, the patient will have myocardial infarction. If the brain receives less blood, the patient will go into stroke. Right, these can be a complications beta which could be associated with the case of aortic dissection, because in aortic dissection there is a tear in the wall, and therefore all the blood is going inside the tear beta, and there is less blood left inside the main aortic lumen. Clear about? Chalo. So aortic dissection, as I've told you, it is nothing else but a tear in the intimal layer beta, and the blood which is there, it enters between the tunica intima and the tunica media. Okay, अब risk factor क्या था? I've told you beta, when there is extremely high pressure inside the aorta beta, it actually causes a tear in the wall. So that extremely high pressure in the aorta is what is called as uncontrolled hypertension. So they will give you a case beta of an elderly patient who is a known hypertensive and the patient is non-compliant. Non-compliant means not taking medications. That is the reason beta the patient has uncontrolled hypertension, and due to that the patient develops a aortic dissection. ठीक है? If they ask you what is the most common site, याद रखना है बेटा, the most common site is the lateral wall of the aorta beta, and which aorta? More common it is the ascending aorta which. So it is the lateral wall of the ascending aorta beta that you have to remember. ठीक है? So lateral wall of ascending aorta beta is going to be the more common site for the aortic dissection to develop. Done with this. Next important beta, what will be the complaints in the patient beta? Let's talk about the complaints of the patient. Okay, shall I? See, the earliest complaint in the patient, the earliest complaint in the patient is going to be what beta now? The patient will start experiencing chest pain. Reason? If there is tear in the aortic wall beta and most of the blood is going inside that tear itself, your heart will not receive enough blood supply beta. Okay, and that's the reason definitely, as the myocardium is not receiving this is not receiving enough blood, the patient will start experiencing angina, right? That's the reason beta the patient will have chest pain. So patient, please remember beta, the patient is also going to have chest pain radiating to which area exactly? Radiating to the interscapular area. Very, very classical. I've told you beta, with this itself a lot of hints you can get in the exam. So patient is having beta a chest pain radiating to interscapular area beta. Okay, so that is the classical presentation of aortic dissection. If there is involvement of the aortic root beta, as I've told you, if there will be involvement of the aortic root, the coronary arteries will not receive enough blood supply, and therefore beta the patient will suffer from myocardial infarction. The patient may suffer from myocardial infarction. If the brain vessels are not receiving enough blood supply, patient may have stroke. If the renal vessels are not receiving blood supply beta, the patient may have renal failure also. That has to be remembered. Okay. Now if they ask you beta, when a patient comes to us with a severe chest pain radiating to the interscapular area, obviously we are going to get confused in the emergency beta, and the first thing that we try to always rule out beta in any patient of chest pain has to be MI, and that's the reason beta we will send a ECG. But when we do a ECG beta, no MI changes are seen on the ECG as such. Okay. Then another investigation we always do beta in a patient of chest pain after ECG is going to be a chest X-ray. Now here when I get a chest X-ray of the patient done beta, you are able to see what is seen on the chest X-ray. Here, can you see the aortic shadow? The aortic shadow which is there beta, it has increased because the aortic wall is having a tear now. So actually the diameter of the aortic wall increases. That's the reason beta. So this is classically called as widening of mediastinum. And this was actually mentioned in the recent NEET PG examination beta. So they mentioned that the chest X-ray shows widening of mediastinum. So that should give you a very strong hint. Okay, they are talking about a aortic dissection. Okay, so widening of mediastinum on a chest X-ray will be an important finding beta. Now important is definitely chest X-ray can be a first line investigation, but it cannot be a investigation of choice. Now for aorta beta, which is a central vessel, investigation of choice is what? I've told you bache, the central vessels ke investigation of choice has to be a CT angiography beta. So obviously we have to go for a CT angiography. So investigation of choice beta in a stable patient, we have to go for a CT angiography. Why only in stable? Because I've told you already that beta CTs are never done in unstable patients beta. Okay, that's the reason definitely in a hemodynamically stable patient you can go for a CT angiography beta. That has to be remembered. So stable patients mein CT angio will be done, and when we do a CT angio beta, a very classical finding is seen on the CT angio. Let's see that. A very classical finding is seen definitely on the CT angio. What? Here how it goes into the wall. वॉल में क्यों नहीं जाएगा बेटा? दिस इज द ट्यूनिका इंटीमा, दिस इज द ट्यूनिका मीडिया. अगर टीयर हो जाता है तो ब्लड विल स्टार्ट एंटरिंग ओवर हियर, एंड एज देयर इज अ लॉट ऑफ रेजिस्टेंस ओवर हियर, मोर एंड ब्लड विल स्टार्ट एंटरिंग ओवर हियर. ठीक है. सो ऑब्वियसली इफ यू क्रिएट अ टीयर, obviously a lot of blood will start flowing inside the tear na, and the tear will keep on increasing with more and more blood flow, more and more blood going inside it. Okay, that is important. तो याद रखना बेटा, if I do a CT angiography, a very classical appearance is seen, that you are able to see this is the aorta beta, and on this aorta beta you are able to see this is the main vessel. Can you see the main vessel is definitely beta smaller now, okay, and this is the tear, okay. So the main lumen which is there beta, you can see definitely there is less blood inside the main lumen and there is a lot of blood in the tear basically. This is a classical picture beta, and that gives us a which classical appearance known as the टेनिस बॉल साइन बेटा. तो याद रखना, टेनिस बॉल साइन विल बी क्लासिकली सीन बेटा. टेनिस बॉल साइन इज गोइंग टू बी क्लासिकली सीन in a patient of aortic dissection on a CT angiography. ठीक है, so that has to be remembered. No issues with this. If they ask you beta, what is the investigation of choice in an unstable patient, because I've told you that in unstable patient we cannot go for a CT angio. So if they ask you what is the investigation of choice in a unstable patient beta, then you have to remember beta, it is nothing else but an sorry, a transesophageal echocardiography beta. ठीक है, that means we are actually going to send beta just like an endoscopy. Basically we are going to send definitely the ultrasound probe beta from here or the echo probe from here, and now it will go into the patient's esophagus. We know esophagus is close to the aorta, therefore with that ultrasound over there or that echo over there beta, we'll be able to assess the aortic wall properly. ठीक है, so that is important. So transesophageal echo can be done definitely in the emergency beta. That's the reason transesophageal echocardiography has to be the investigation of choice for a hemodynamically unstable patient in the emergency beta for aortic dissection का case. ठीक है, so transesophageal echo beta has to be the investigation of choice for unstable patient in the emergency. Clear है बात? That is important. I hope all of you are quite aware now. You have got your answer. Okay, the patient is hemodynamically unstable in your question, so answer has to be the investigation of choice will be a transesophageal echocardiography. ठीक है, चलो. So that has been a previous question. Now let's talk about beta the management. But you have to remember that the management in a case of a aortic dissection beta, it is based on the classification. So for that you need to know the classification beta of aortic dissection. If I talk about the classification of aortic dissection, it is known as the DBK's classification beta. Okay, it is classically known as the DBK's classification. When I talk about the DBK classification, here aortic dissection is usually divided into three types. याद रखना, the dark lumen which is there beta, this is the tear. ठीक है, the dark lumen which is there, it is the tear beta. So type 1 DBK जो दिख रहा है, in type 1 DBK beta, we are able to see a tear in the ascending aorta as well as the descending aorta, right? You are able to see a tear beta in the ascending as well as the descending aorta. So that is type 1. Type 2 DBK, if you are able to see beta, there is a tear only in the ascending aorta. In type 2 DBK, there is only a tear in the ascending aorta. Type 3 beta, now whether it is type 3A or type 3 beta, okay, whether it is type 3A or a type 3B tear, in both the conditions definitely beta, you are able to see a tear in the descending aorta. So याद रखना है, type 3 में the tear is only seen in the descending aorta. Okay, the only difference is type 3A में it is suprarenal above the renal vessels, type 3B में it is infrarenal below the renal vessels also. ठीक है, that is important. That is the first classification. Now we have to talk about the more important classification beta for aortic dissection, and that more important type of classification for aortic dissection has to be the Stanford classification. Yes, because the management of aortic dissection is usually done according to the Stanford classification beta. Now let's talk about the Stanford classification. So if I talk about Stanford beta, aortic dissection is classified into Stanford A and Stanford B beta. So Stanford A जो होता है definitely, here you can see beta, okay, it is either involvement of ascending plus descending aorta, or it is involvement of only the ascending aorta. This together will be called as Stanford A and B. Stanford B मतलब क्या? Stanford B means involvement of the descending aorta beta. ठीक है, Stanford B means involvement of the descending aorta. Easy to remember. Stanford A is what? Either ascending plus descending or only descending. Sorry, only ascending. And Stanford B is what? Only and only descending beta. ठीक है, so that is what is important. Now if the patient comes to us beta, what is the first line agent? As I've told you beta, the uncontrolled hypertension or excessive rise in BP is the problem. So the first line agent has to be a beta blocker, and the shortest acting beta blocker is given over here to control beta the hypertension over here, and that is known as IV esmolol. So we have to give IV esmolol beta as the first agent. Does not matter whether it is Stanford A or Stanford B beta, the first line agent has to be IV esmolol itself. Clear है बात? That is important. Now once you have definitely given IV esmolol to the patient beta, do remember that now we will go for a क्लासिफिकेशन वाइज मैनेजमेंट. इफ दे से इट इज स्टैनफोर्ड ए, स्टैनफोर्ड ए क्या था अभी बताया मैंने. स्टैनफोर्ड ए मींस आइदर इन्वॉल्वमेंट ऑफ ओनली द असेंडिंग एओर्टा बेटा, और इन्वॉल्वमेंट ऑफ द असेंडिंग प्लस डिसेंडिंग एओर्टा बच्चे. ठीक है, दैट इज व्हाट इज द स्टैनफोर्ड ए. स्टैनफोर्ड ए में बेटा प्लीज रिमेंबर द मैनेजमेंट विल ऑलवेज एंड ऑलवेज बी अ सर्जिकल रिपेयर. स्टैनफोर्ड ए में बेटा द मैनेजमेंट शुड ऑलवेज बी अ सर्जिकल रिपेयर बेटा. इट कैन नॉट बी मैनेज कंजर्वेटिवली, याद रखना ये बात. स्टैनफोर्ड ए, द मैनेजमेंट इज ऑलवेज अ कंजर्वेटिव, ऑलवेज अ सर्जिकल रिपेयर बेटा, कैन नॉट बी मैनेज कंजर्वेटिवली. Next important, if I talk about बच्चे, is Stanford B. Stanford B में you have to remember beta, it is involvement of only the descending aorta. If there is involvement of only the descending aorta, that is called as Stanford B beta. Stanford B में once you have given IV esmolol to the patient, now the patient has to be monitored beta. Yes, a proper monitoring has to be done. If you do a proper monitoring beta, a lot of patients of Stanford B improve on their own beta. Yes, a lot of patients of Stanford B are going to improve on their own, therefore they may not need a surgery. Okay, so just Stanford B में IV esmolol plus monitoring has to be done. If the patient's condition deteriorates, if the patient's condition worsens, then we can go for a surgical repair beta. If the patient's condition is worsening, then we go for a surgical repair, only in few cases beta. Okay, in the recent NEET PG examination and the previous FMG exam beta, they asked you that the patient is having aortic dissection, what should be the management beta. Okay, it was a Stanford B which was given, so that is the reason beta the management had to be IV esmolol and monitoring to be done in the patient. Okay, and if they give a Stanford A beta, then the management has to be IV esmolol followed by a surgical repair always. Okay, that is important. क्या करना है, want a break or shall I continue? कोई ना, ले लो break because we are done with arteries now. So arteries have been done. So now after this definitely 30 मिनट का तो break करता ही नहीं होगा. So arteries have been done now. Now we will start with veins basically. There are only two topics in veins. One is DVT and varicose. थोड़ा बहुत complex varicose है but इतना नहीं है. You'll understand it. And after that definitely we'll talk about lymphedema. Then we are done with the vascular and we'll immediately start with GIT beta. ठीक है? Let's start now, beta. Next topic that we have to talk about, beta, is veins now. ठीक है, तो अभी याद रखना, till now we were talking about the arteries, beta, so definitely the flow was from proximal to the distal part. Now we are talking about the veins, so therefore the flow which is there, beta, it will be from distal to the proximal part. ठीक है, तो चलो, if I talk about, beta, the next one, that is DVT. ठीक है, DVT is nothing else but deep venous thrombosis, beta. What is deep venous thrombosis? I hope all of you are quite aware that in your lower limbs, beta, there are two types of veins. Okay, one are the superficial veins, second are the deep veins. So when there is blockage inside these deep veins, which will develop, beta, that condition is what is known as DVT. Okay, so please remember, the blockage in the deep veins of the lower limbs, okay, is what is known as DVT, beta. Now, why a thrombus basically develops, or why a blockage usually develops, beta? In pathology, you might have studied about the virtuous triad, beta. The three factors responsible for a thrombus formation are going to be, the first important factor from the virtuous triad, okay, is going to be endothelial injury, beta. Q, when there is an endothelial injury, which does not matter whether it is a physical injury or not, okay, immediately what are going to come over here? Platelets are going to come over here, beta, and they will definitely form the primary clot. Then definitely the clotting factors will come, then they will form a secondary clot, beta, right? So definitely that is going to happen. So first of all, beta, the most important factor, if they ask you, okay, among virtuous triad, which is responsible for the thrombus formation, answer has to be an endothelial injury. Next important is stasis, beta, right? If there is stasis of blood flow, that means blood ek jagah thum jata hai, ruk jata hai. So if there is stasis of blood flow, beta, obviously the risk of thrombus formation is going to increase, beta. And last is a hypercoagulable state, beta. Okay, hypercoagulable state hai, that means definitely the blood is more viscous, the blood is more thicker, gaढ़ा hota hai. That's the reason the risk of thrombus formation is higher. Now, if they ask you what is the most common site, beta, for deep venous thrombosis to develop, the most common site for the DVT to develop, beta, has to be the calf region, which is, okay, it has to be the calf region, beta, which is going to be the most common site for DVT to develop. And in the calf, beta, it is which veins mainly? So you have to remember, it is the soleal veins, beta, which are the most common veins where the DVT is going to develop. Yaad rakhna ye naam. These are the soleal veins of the calf, beta, which are the most common site for the thrombosis to develop. Okay. If they ask you what is the most common cause, so yaad rakhna, the most common cause for a DVT to develop is going to be a prolonged immobilization. What do I mean by prolonged immobilization? The patient stays in the same state, beta, or in the same position for a longer duration of time, right? So the patient does not walk over here, right? That is called as prolonged immobilization. Now, prolonged immobilization is seen in which patients? All the patients, beta, who are bedridden, for example, right? Those patients who are usually bedridden, they are not able to walk, and that's the reason, beta, they will have an increased risk of DVT. So prolonged immobilization can be due to multiple reasons, okay, and these can be given as hints in your question, beta. The first is, for example, a patient has taken a long haul flight, beta, from New York to New Delhi, and the patient has not walked on the flight. Definitely that is one reason. Second, the patient has undergone a major surgery, beta, something like a TKR or a THR, that is total knee replacement or a total hip replacement surgery. After that, the patient would have bed rest. Next important, beta, the patient the patient is having fractures, like either lower limb fractures are there, or there is a spine fracture, due to which the patient has been advised bed rest, beta, or the patient is admitted in the ICU, okay, or comatose patient. All these patients basically, beta, they are going to have a prolonged immobilization. So yaad rakhna hai, prolonged immobilization which is there, okay, is actually considered as the most important risk factor, beta, in a patient of DVT. So the important ones are going to be, first is a long haul flight. They will use this commonly, beta, in the history, or they will say major surgery like a TKR or a THR, or the co-examiner will give you a history of lower limb or a spine fractures, beta. Okay. Now important is that all patients who are having prolonged immobilization, will they develop DVT, beta? No. Okay, there should also be some risk factors, beta, for the DVT to develop. Okay, and what are these risk factors? Let's talk about that. So if they ask you, the risk factors for the DVT to develop are going to be, the first one which is there, beta, is, okay, previous history of DVT. Obviously, if a patient had a previous history of DVT, beta, obviously there is a very high risk of recurrence in the patient then. Next important is pregnancy. We know, beta, that pregnancy is a hypercoagulable state. You might have studied in OBS that definitely all the clotting factors increase in pregnancy except 11 and 13, right? So that's the reason pregnancy is a hypercoagulable state. Malignancy also beta. Malignancy is also a hypercoagulable or a prothrombotic state where the risk of thrombus formation increases. Next is protein C and protein S deficiency. I hope all of you are quite aware that in your body beta, you have certain natural anticoagulants which break the clot basically after some time. And those anticoagulants are antithrombin 3, protein C, protein S. But if the patient is having deficiency of protein C and protein S like anticoagulants beta, obviously the clot will not get broken down and the clot will persist beta, and that will lead to thrombus formation. Okay? Or if there is a factor 5 lead-in mutation. Usually mutations leads to loss of function beta, but here there is a gain of function in the factor 5, and as there is gain of function, the clotting factor 5 beta will actually increase the risk of thrombus formation over here. Okay? That is important. So all these risk factors, okay, so either of the risk factors beta, if it is associated with prolonged immobilization, then the patient will develop a deep venous thrombosis. Now, why prolonged immobilization causes it? Reason beta, if the patient is not walking beta, his leg muscles are not contracting. As his leg muscles are not contracting beta, the flow in the deep veins of the lower limbs is not maintained properly. Rather, there is stasis of blood flow beta. वो जो खून है वो रुक जाता है बेटा, थम जाता है अपनी deep veins में lower limbs की. ठीक है? So that is important to be remembered. If they ask you what is going to be the most common or the earliest feature, do remember that here, as I say beta, this is the deep vein now. Okay, and here if there is a blockage inside the deep vein, obviously beta, the blood which is there, it is going from distal parts to the proximal part. What will happen? The blood which is there beta, it is not able to go, so there is pooling of blood in these deep veins beta, and as there is pooling of blood in the deep veins, the pressure in the deep veins is going to increase, and as the pressure in the deep veins increases beta, we know definitely it is going to kick out the extra fluid. When this extra fluid goes out beta, that leads to edema or swelling in the calf region. First thing. Second, here the fluid which is, here the blood which is collected beta is the deoxygenated blood in the veins. That is the reason beta, the nerves at this site may not be able to receive enough oxygenated blood supply beta, and that's the reason they will cause they will get irritated and they will cause a lot of pain beta. Clear about? So that is important. If they ask you what is the most common or the earliest feature in a patient of DVT, answer is the pain and swelling in the calf region is going to be the most common and the earliest feature in a patient of DVT beta. Clear? Next important beta, if I talk about, the patient may also have chest pain beta and dyspnea. Now if they say beta, the patient is having chest pain or dyspnea, what does that suggest you of? So please remember, you might have discussed in medicine. So the patient was a pregnant female beta. She was taking a long flight from New York to New Delhi, and obviously in the long flight definitely she had a prolonged immobilization, and already she is having a risk factor, that is pregnancy. So now what has happened? As she has not walked throughout the flight beta, there was stasis of blood in the deep veins, and that led to thrombus formation. Now as soon as she got down from the flight beta, she started walking. As the female started walking beta, her leg muscles started contracting, and as the leg muscles will start contracting beta, this thrombus from here, it will get separated beta. Okay, this thrombus from here, it will get separated, it will go all the way up to the lungs beta, it will go all the way up to the lungs bache, and it is actually going to cause blockage inside the pulmonary blood vessels. And if there is blockage in the pulmonary blood vessels beta, I hope all of you are quite aware, it is known as pulmonary embolism beta. Okay, and that is going to cause severe respiratory distress and chest pain in the patient, right? That is a complication of DVT. Yaad rakhna ye baat. So if they say beta, the patient has suddenly started developing chest pain and dyspnea beta, okay, it is basically due to pulmonary embolism, which could be a complication of, okay, of a patient of DVT beta. Okay, so yaad rakhna, pulmonary embolism which is there, it has developed in the patient. No issues with this, anybody? Rare? Yeah, pulmonary embolism could be rare, but yeah, it can occur. It is not so rare. It has happened basically with one of my juniors itself beta. Okay, he was definitely sitting for longer durations of time and studying for NEET PG, and that's the reason beta, he had stasis of blood, and due to that definitely he started experiencing leg pain. So he went to an orthopedician. Orthopedician gave as usual calcium and vitamin D. No improvement was there. That's the reason definitely he again went to the orthopedician, and he recommended, even without proper examining, he recommended that young 26-year-old chap, okay, to a physiotherapist. Now the physiotherapist, he don't even know, like, he obviously started compressing the muscles of the leg, and as he started squeezing the muscles of the leg beta, immediately the thrombus has dislodged from that side, went up to the lungs and led to a massive pulmonary embolism in him. Okay, and he had 17 infarcts in the lung and he was admitted in the ICU for 3 months. Okay, so that is important. So you have to remember that why I say definitely it's very important for your profession to, like, you have to be more serious in your profession. This is the reason. Even a small mistake of yours could have costed a life to any person. Okay, so that is important. Here you are able to see beta. This condition, when there is complete cyanosis of the legs beta, which has happened. The patient is having DVT, and now definitely beta, there is pooling of a lot of cyanotic blood also over here. This condition is what is called as a, okay, there is a lot of deoxygenated blood which is pooling over here, and there is cyanosis of the leg beta which is seen. This condition is called as phlegmasia ceruleus dolens beta. This condition which is there is classically called as phlegmasia ceruleus dolens. Okay, this has been asked in your examination beta in the NEET PG. So do remember that phlegmasia ceruleus dolens is the important manifestation, can be seen in a patient of DVT beta. Why you have to immobilize? Basically, you can keep on walking in between. Okay, keep on pressing your calves in between. No issues with that. I have options for everything. Don't worry. You can wear stockings also. If you want any other advice, I can give. Don't worry about that. Next important beta, if I talk about is this leg over here beta. Here you are able to see definitely beta that the patient's leg which is there beta, it is appearing white completely. Here there is complete pallor in the one of the legs beta. This condition is known as phlegmasia. Okay, this condition which is there beta is what is known as phlegmasia ceruleus alba beta. This condition is classically called as, alba means white, right? So please remember this condition is known as phlegmasia ceruleus alba. Done with this? Okay, so these are the two manifestations beta that you have to remember for a case of DVT beta. Now, if I talk about the examination findings, what will be seen on examination? So obviously beta, first thing which will be seen on examination is tenderness in calf beta. Yes, when you touch even the calf of the patient beta, the patient may have a lot of pain. So the patient may have tenderness in the calf region. That is the first finding. Second important beta is going to be two signs beta. There will be two clinical signs. Okay, what are those? First of all, understand this is the foot of my patient, this is the leg of my patient beta. So what we are doing beta, we are definitely dorsiflexing the foot. As I dorsiflex the foot beta, there will be a lot of resistance, stiffness and pain beta in my patient's calf, right? So as I dorsiflex the foot, there is a lot of pain, stiffness and resistance in the calf region. This is classically called as the Homan sign beta. This is known as the Homan sign. Second definitely is when I squeeze the calf beta, the patient will have a lot of pain, and that is called as the Moses sign beta. When you squeeze the calf, the patient has pain, that is known as Moses sign. Will you ever do all these clinical signs? Never. They are just theoretical signs beta. They are not to be elicited clinically. Reason, if you elicit these kind of clinical signs, there can be a risk of embolism beta that will happen. Okay, so that is important to be remembered. These are just theoretical signs beta, but they have been asked in your exams. So do remember dorsiflexion of foot which is there beta. Okay, dorsiflexion of foot which is there, definitely it is going to cause a lot of resistance beta or a lot of stiffness in the patient. And when there is resistance or stiffness along with pain in the calf region beta, it is classically called as which sign? It is known as the Homan sign beta. Okay, it is known as the Homan sign. Next important, if I talk about bache, is squeezing of the calf. Okay, squeezing of the calf is going to cause the pain, and when I talk about squeezing of the calf leads to pain beta, that is known as the Moses sign. Okay, Moses, so never it should be elicited, never. Okay, hopefully that's clear to all of you now. Chalo. Next important beta, if they ask you investigation of choice, peripheral vessels are having a blockage. We know always peripheral vessels is having a blockage beta. It has to be called as what? Peripheral vessel is having a blockage beta. It is nothing else but, anybody? Duplex scan. So investigation of choice in a patient of DVT has to be a duplex scan beta. Okay, again, as I've told you, investigation of choice will be a duplex scan. Now, important is for prediction of DVT beta. See, we have to consider all the risk factors. Each risk factor will be given a score, and then depending on that, definitely we are going to predict the chances of DVT in the patient beta. Okay, so prediction of DVT could be done with the help of a criteria. You just have to remember the name of the criteria beta, and that criteria with which we can predict the chances of DVT in a patient is known as modified Wells criteria beta. So modified Wells criteria is the one with which you can actually predict the chances of DVT in a patient. One of the important criteria in this is beta that the patient should have a prolonged immobilization for how many hours? More than 72 hours beta. Yeah, right now one of the criteria which is there, it is prolonged immobilization for more than 72 hours. That is the one of the parameters of the modified Wells criteria. Okay. Clear hai baat? So that is important. So modified Wells criteria, which is there definitely beta. Okay, it is going to be the criteria used for the DVT. Chalo. Next important if I talk about is the treatment beta or the management. So yaad rakhna, management if I talk about is going to be anticoagulation because definitely clots or thrombus have been formed beta. So anticoagulation should be done. Please remember for first 5 days in the emergency, bache, for the first 5 days in the emergency, what could be given? Which is the anticoagulant of choice in emergency? We know beta, it is nothing as but injection of low molecular weight heparin. So we have to start injection of low molecular weight heparin to the patient. Along with that beta, we have to start a oral tablet of warfarin also. So when the patient of DVT is admitted in acute episode, you have to start an injection of low molecular weight heparin, which is actually going to be considered as the drug of choice beta in the emergency. And along with that, definitely you can start beta oral warfarin tablet as well. Okay? Now if they ask you after the 5 days what should be done, so after the initial 5 days are done beta, then you have to discharge the patient. Obviously you are going to discharge, and we have to discharge the patient only on an oral tablet. And then after 5 days beta, we will only continue oral warfarin in the patient. Okay, after 5 days we will just continue oral warfarin in the patient. Now if warfarin had to be continued after the discharge itself beta, why it would have been started on day one? So reason, please remember, we always have to start warfarin on day one beta. Reason is warfarin takes 5 days to start its action beta. That is the reason. If you want the action of warfarin from 5th day onwards, you have to start it on day one itself. Now important is what should be the duration of warfarin therapy, for till what time beta you should give warfarin to the patient. So yaad rakhna ye baat. The duration of treatment, if it is a very first episode, the patient has come to us beta for the very first time with the DVT, then you have to continue this warfarin therapy for a span of 3 months beta. Okay, first time mein only 3 months tak you have to continue this warfarin therapy. But if it is a recurrent DVT beta, that means the patient has come again with a case of DVT, then here the warfarin therapy should be continued lifelong in the patient, right? The anticoagulants will be required lifelong in the patient. Reason is beta, if there is a recurrent case of DVT, the patient will have a very high probability to develop DVT again and again, and therefore we have to keep the patient on lifelong anticoagulation. Otherwise, the patient may develop DVT and that can lead to pulmonary embolism and death of the patient suddenly. That's the reason. Now, what is another way beta to prevent a pulmonary embolism in a patient of recurrent DVT? So for example, if a patient is having a recurrent DVT beta, what I can do, for example, this is the inferior vena cava of the patient. We know now that when the thrombus gets separated from the deep veins, it travels all the way up to the inferior vena cava, from there to the heart, and from heart ultimately to the patient's pulmonary blood vessels where it causes the blockage beta. So what I can do, can I place basically beta a filter inside the inferior vena cava? Why? Because if you place this filter in the inferior vena cava beta, and if the thrombus tries to go upwards beta, obviously what is this filter going to do? This IVC filter is actually going to break down that clot beta or the thrombus into multiple fragments. Okay, so that is what is done. So therefore beta, if a patient is having a recurrent DVT, one of the methods to prevent embolism can be placing a IVC filter beta. Okay, we can place an inferior vena cava filter to prevent the pulmonary embolism in the patient. Clear about? Next important if I talk about is prevention. Now in your examination beta, more than definitely the treatment of the patient beta, they are actually inclined towards asking you the prevention, how to prevent or how to do a prophylaxis of DVT. So this is a very important point beta, yaad rakhna. If they ask you the prevention or prophylaxis of DVT, there are two methods beta for prevention of DVT. One is called as the pharmacological prevention बच्चे, second is known as a mechanical prevention. याद रखना है कि pharmacological prevention will be better, right? Pharmacological prevention will be more effective, it will be better beta, right? Obviously. And pharmacological prevention will be done with which drug? Nothing else but injection of low molecular weight heparin, right? Injection of low molecular weight heparin beta. So you might have seen na, in ICU patients basically who cannot walk, in those patients beta, in the medicines you might have seen injection of low molecular weight heparin. You are not able to understand why it is added. This is the reason beta, because those patients cannot walk. So in those patients beta, mechanical prevention is not useful. In those patients I can go for pharmacological prevention with low molecular weight heparin beta. Okay, so that has to be remembered. Next important if I talk about beta, total 10 days warfarin नहीं भाई, ए बेटा ये पहले 5 दिन warfarin दिया है, and after 5 days you have to continue warfarin either for a span of 3 months or a span or lifelong depending on the presentation. Mechanical prevention, if I talk about beta, mechanical prevention is usually done by two things beta. First, obviously, after the surgery, as I told you, you always ask the patient beta to start an early ambulation. What is early ambulation? We ask our patient beta to start walking as early as possible. Okay, sometimes you might have seen kitta pagal surgeon, he's asking the person to walk on the day one itself. But beta, we don't want our patients to develop DVT, and that's the reason we ask our patients to walk. Second important beta is nothing else but pneumatic compression stockings. Okay, if I talk about beta pneumatic compression stockings, basically you are able to see these are the pneumatic compression stockings. This was an image based question in your examination also. Okay, this ones. So here you are able to see beta, these pneumatic compression stockings are applied around the lower limbs of the patient beta. And now this machine which is there beta, it is going to inflate those stockings. Yes, it is going to push air inside those stockings. That's the reason it is called as pneumatic beta. Okay, and once definite, after every 2 hours, what happens? After every 2 hours beta, the air is pushed inside the stockings, and when air is pushed in the stockings beta, they are going to compress the lower limbs of the patient. And when the lower limbs of the patient will get compressed, or the calf of the patient gets compressed beta, there will be proper blood flow which will be maintained. Okay, it will prevent the stasis of blood beta, वो blood को जमा नहीं होने देता वहां पे. That is important beta. That's the reason pneumatic compression stockings will have a major role to play in prevention of DVT beta. If pneumatic compression stockings are not available, you can use the normal elastic compression stockings for varicose veins that you use beta. If those are also not available, you might have seen beta in a lot of patients after the surgery, surgeons usually wrapping their legs completely with a crepe bandage. So this is the reason beta, because if no availability is there, we wrap our patients legs with crepe bandages beta. Okay, and if that is also not available, then in that condition, at least ask the attendants of the patient beta to press his legs after every 2 hours. Reason, if they are going to keep on pressing his legs after every 2 hours beta, okay, pressing his calves, so what will happen? It will ensure that a proper blood flow is maintained over there, and there is no stasis of blood basically, and there is no risk of thrombus formation. Clear about that? Is important. BP cuff is not possible beta. BP cuff is not going to be self-inflating any which ways. ठीक है, so that is the important thing. BP cuff नहीं, पूरे leg में चाहिए होता है, in the whole calf region. BP cuff is such short basically. ठीक है, so that is important. This is an automatic one. The pneumatic compression stocking is a machine which is an automatic one beta, but otherwise you can do the manual one also. ठीक है, no issues with this anybody? So याद रखना, for prevention these are the two things: pharmacological prevention with low molecular weight heparin, which is better, and mechanical prevention with early ambulation and pneumatic compression stockings. This is the Homan sign beta, as you are able to see. Dorsiflexion of foot causing resistance or pain in the calf region will be the Homan sign. Okay, now let's talk about the next topic, and that is going to be beta, nothing else but the varicose veins or the varicosities. For that, definitely you have to understand beta what is the arrangement of the anatomy in the lower limb veins beta. Okay. Now for example, if I talk about beta, these are the deep veins of my patient beta. These are the deep veins of my patient, and in the deep veins beta, definitely the superficial veins are going to drain. So for example, this is a superficial vein bache. This is a superficial vein beta, and the superficial vein, we know it is going to drain into the deep vein of the patient, right? The superficial vein is actually going to drain into the deep vein of the patient. Now where the superficial vein beta usually drains into the deep vein of the patient, okay, this site is basically called as a junction. This site is basically called as a junction beta. Apart from that bache, apart from that, definitely please remember, you will also have a connection beta between the deep veins and the superficial veins. These small vessels beta, which are going to be the connecting points. Okay, these small vessels beta, which are going to be connecting points bache, between the deep veins and the superficial veins. These small connections are called as the perforators beta. These small connections are known as the perforators. Okay, so what are the two sides of connection between the deep vein and the superficial vein? One major side is the junction beta, second smaller side is the perforators. There are 100 to 150 perforators beta in each lower limb basically. Okay, that is important. There are a few major perforators which are named, we will talk about them in a while. Okay, but this is the important thing that you need to remember. Now important is beta yaad rakhna that deep veins are always larger in size beta, and they carry almost 80% of the blood supply, whereas superficial veins are very smaller in size beta, they are very thinner, and they only carry 20% of the blood supply. Now beta, we know definitely no aspirin is not required. Anticoagulants are given, not antiplatelet drugs. Okay, so that is important beta. If I talk about in this patient, basically यहाँ पे, ठीक है, sorry, what is the beta? We know beta in the vessels, basically on the veins beta we have valves. ठीक है, तो याद रखना in the vessels or in the veins we always have valves beta. ठीक है, तो यहाँ पे even at the junction of the deep and the superficial veins beta we have these valves. Okay, even at the junction we have valves beta. Now what happens normally, understand, whenever you start walking beta, whenever you start walking basically, okay, the leg muscles of your patient are contracting. As the leg muscles of the patient contract beta, the first vessel to get collapsed will be the superficial veins. Okay, as your leg muscles contract, the superficial veins will get collapsed, and as the superficial veins are collapsed, all the blood from the superficial veins beta that goes into the deep vein. याद रखना है, all the blood from the superficial veins goes into the deep vein. Can the blood from deep vein go into the superficial vein beta? Can the blood from deep vein go into the superficial vein? No. Reason, we have these valves beta, and these valves will only allow one way flow beta, that is from the superficial veins to the deep veins. They will not allow the reverse flow to happen. Okay, so this is the normal finding beta. Okay, now even if I say that even if the pressure inside the deep vein is very high, for example a patient is having DVT beta, and due to that the pressure inside the deep vein is very high beta, still will there be a flow beta from deep vein to the superficial vein? No. Okay, in a normal person, even if you have DVT beta, the flow can never get from deep vein to the superficial vein. Reason is, again, the valve is there now. So in which patients definitely the patient can have the reverse flow? In those patients beta where either these valves are completely absent or these valves are defective beta, right? So if the valves are completely absent or these valves are defective, matlab valves nalayak hai, that is valvular incompetence we call it as, right? If the valves are of no use, that is called as valvular incompetence. So either if the valves are absent or the valves are defective. Ab kya hoga, understand, as the pressure in the deep vein increases beta, as the pressure in the deep vein increases due to whatsoever reason, ठीक है, the pressure in the deep veins is high. For example DVT है, इसीलिए the pressure in the deep veins are high. And second problem क्या है, the valves are also absent, right? Due to that, now what will happen, the blood will start flowing from beta from the deep veins of the leg to the superficial veins. The blood will start flowing beta from the deep veins of the leg beta to the superficial veins. Now as a lot of blood starts coming into the superficial veins, we know beta that superficial veins which are there, they're usually very thin, they're usually very small beta, but as a lot of blood is coming from the deep veins now, therefore beta what will happen, these superficial veins will start undergoing dilatation beta. These superficial veins will start undergoing dilatation and they will become tortuous, right? They will become twisted like this. So this dilated tortuous superficial veins is what is called as the varicose veins beta. Okay, so when a lot of blood comes into the superficial veins of the leg and when they become too much dilated and tortuous, these vessels are what are called as varicose veins or varicosities. Clear about that? Has to be remembered. And it is due to what reason? It is because the valves which were there beta, they are either absent or they are defective. That is called as valvular incompetence beta. Okay, and that will be present at the level of junction, or it can also be a problem at the level of perforator vessel. Kaise? Now you can see beta, the arrangement in the perforator is such that the blood can only go from superficial vein into the deep vein. But agar galat arrangement ho jaye beta, so obviously what can happen, the blood from deep veins can also go into the superficial vein beta. So if the perforators are also having some problem beta, that is called as perforator incompetence, that may also lead to development of a varicose veins. Yes, if the problem is at the level of junction, obviously the varicose veins will be much more severe beta, whereas if the problem is at the level of perforators, it may not be that much severe beta. Clear about that? Is important to be remembered. Hopefully clear to all of you now. Yeah, that's now junctions which are there beta, these connections which are present between the deep veins and the superficial veins beta, they are of two types basically. Understand? For example beta, we have a deep vein called as the femoral vein beta, and in that femoral vein beta, a superficial vein is going to drain, and that superficial vein is known as GSV. What is GSV? Great saphenous vein. So what happens? This great saphenous vein starts from the medial malleolus, travels all the way from the medial part of the thigh beta and drains into the femoral vein beta at the level of the thigh. This, when the great saphenous vein drains into the femoral vein beta, will be called as the saphenofemoral junction, and this is located at the level of the inner thigh. Next important beta, behind the knee we have a popliteal vein. So popliteal vein is a deep vein beta, and in that popliteal vein, which superficial vein is going to drain? So it is the short saphenous vein. So the short saphenous vein starts from the lateral malleolus, travels all the way up beta from the lateral part of the leg and drains into the popliteal vein beta at the level of the popliteal fossa or at the level of the knee beta. And therefore, at the level of the knee, we have the second junction beta between the superficial and deep vein, and that is what is classically called as the saphino-popliteal junction beta. So how many junctions we have? We have two junctions beta, saphenofemoral and saphino-popliteal junction. Okay. So as I've told you, the deep and the superficial veins which are there beta, the deep and the superficial venous system in the lower limbs, they are connected with each other bache, at two sides. One is the junctions when the superficial vein directly drains, or second are the perforators, the small connections between them. Now if I talk about the junctions beta, the great saphenous vein, bache, when it basically drains into the femoral vein, what is that junction called as? That is known as the saphenofemoral junction. And I hope all of you are quite aware that saphenofemoral junction is located at which level? The saphenofemoral junction is located at the level of the thigh beta. Whereas the next one, short saphenous vein, which is there beta, when the short saphenous vein, it drains into the popliteal vein beta, then that leads to formation of which junction? Then that leads to formation of the second junction beta called as the sapheno-popliteal junction. And I hope all of you are quite aware that the sapheno-popliteal junction which is there, it is located at the level of the knee beta or the popliteal fossa. Clear? So these are the two junctions that we have. Clear hai? Chalo. Next important if I talk about beta is nothing else but the perforators now. I've told you beta the perforators, there are 100 to 150 perforators in each lower limb, but beta there are certain perforators which are constant and which are major ones. Those are given names beta. Okay, let's talk about them. They are shown in the picture over here. The first one is known as a Hunterian perforator beta. The first one is a Hunterian perforator, and this Hunterian perforator is usually located at the level of the proximal thigh beta. Hunterian perforator is present in the proximal thigh. Next important beta is the Dodds perforator. Now Dodds perforator which is there beta, it is present in the distal thigh, or you can say above the knee beta. The second one which is there beta, it is known as the Dodds perforator. It is usually present at the level of the distal thigh or just above the knee. Okay. The third one which is there beta, it is the Boyd's perforator. The third one which is there beta is known as the Boyd's perforator, and yaad rakhna, the Boyd's perforator is present below the knee. Which Boyd's perforator is present just below the knee. And the third one which is there, the fourth one which are there beta, those are known as Cocket perforators. Yes, the fourth one which are there beta, those are known as the Cocket perforators. And please remember beta, there are three Cocket perforators. They are usually 5 centimeter, 10 centimeter and 15 centimeters above the medial malleolus. Okay, so these are the three Cocket perforators, 5, 10 and 15 centimeters above the medial malleolus. Okay, so Hunterian, Dodds, Boyds and Cockets, these are the important perforators that you have to remember in the lower limbs of the patient. Done with this? Chalo, now let's talk about varicose veins as a condition. Shall I? Now when I talk about varicose veins beta, if I talk about varicose veins beta, varicose veins I've already told you. What are varicose veins? Varicose veins are nothing else but beta, the abnormally dilated and the tortuous superficial veins in the limbs of the patient beta. Okay, the abnormally dilated and the tortuous superficial veins of the lower limbs, those are called as varicose veins. Can you see them? These ones which are there beta, these are basically called as your varicosities or the varicose veins. Clear about? Next important beta, if they ask you what is the most common site, the most common site is obviously the lower limb, we know, but which part of the lower limb exactly? It is the legs beta. Okay, legs matlab below the knee. Okay, so legs important beta, that has to be remembered. This will be the most common part basically for the varicose veins to develop. Okay, now if they ask you beta what is the cause, so please remember, as I've told you beta, the main cause is nothing else but valvular incompetence. What is valvular incompetence? Valves are nalayak. Okay, so that valvular incompetence which is there, the valves are of no use basically, either they are absent or they are defective beta. So either there is some defect in the valve or these valves are absent beta at the level of junction. That is what is called as valvular incompetence, and that is the main problem now over here. That is important beta. Or the problem can be what beta? The second problem can be a perforator incompetence. Which the second problem is what basically? The incompetence is at which level? The second problem beta, the incompetence is at the level of the perforator. the arrangement of the perforator is not correct. Okay, so the second problem could be a perforator incompetence. Okay, either one problem is valvular incompetence, second problem is perforator incompetence. If they ask you beta which is more common, the one that I've highlighted, that is nothing else but valvular incompetence beta. Valvular incompetence is actually a more common cause for varicose veins to develop in a patient. Okay, if they ask you what is the most common site for the valvular incompetence, whether it is the saphenofemoral junction or the saphenopopliteal junction, so do remember the most common site beta for the valvular incompetence has to be the saphenofemoral junction in the thigh beta. Yes, the saphenofemoral junction which is there at the level of thigh, that is actually going to be beta the more common site basically for the valvular incompetence. ठीक है, तो valvular incompetence की अगर पूछेंगे बच्चे the most common site क्या है, तो your answer has to be the saphenofemoral junction would be the most common site of problem. ठीक है, the valves at saphenofemoral junction are usually absent. Now, will all the patients who are having definitely absent valves will develop varicose veins or what? No. I've told you beta that the pressure in the deep veins should be high. Now, if the pressure in the deep veins is high, then only the blood will go from deep veins into the superficial veins. So both the factors should be there. One, the valvular incompetence. Second, some risk factor which is causing increased pressure in the deep veins beta. And what are the risk factors which will actually cause increased pressure in the deep veins of the leg? The first and the foremost factor has to be beta the prolonged standing, right? We know that if a person is doing prolonged standing, bache, so due to that, definitely there is pooling of blood in the lower limbs beta. And if there is pooling of blood in the deep veins of the lower limbs beta, obviously the pressure inside the deep veins is going to be higher beta. Okay, so prolonged standing will cause pooling of blood in the deep veins, and that is going to increase the risk beta. Okay, so prolonged standing will be seen in whom? Prolonged standing can be seen definitely beta in the patient, in usually teachers, in surgeons, in policemen definitely, or in watchmen, in traffic police, all of them. But most important, it is usually seen beta in none other than housewives. So if you ask definitely beta, please remember, if you ask your mothers and aunts definitely, are you having pain in the legs? Most of the times they say yes, and most of the times we discard it by just giving calcium or vitamin D. But if I see properly beta, most of them definitely have varicosities which have been developed. Clear about? So that is important beta. Housewives are the most common patients who present to us basically. Okay, so yaad rakhna. Prolonged standing is going to be an important risk factor beta. Other ones definitely if I talk about is going to be pregnancy, which is okay. Along with that, pelvic tumor beta. Why? Because in pregnancy or in pelvic tumor beta, we know that definitely there is a lot of pressure in the pelvic cavity, right? Due to the gravid uterus or due to the pelvic tumor beta, there will be a lot of pressure over here. And if there is a pressure over here beta, the vessel which is coming or the vein which is coming basically beta from the deep, the vein which is coming beta from the lower limb, obviously that vein will get compressed. And if this vein is going to get compressed beta, that is the reason there is pooling of blood in the lower limb veins beta. And as there will be pooling of blood in the deep veins of the lower limbs, the pressure inside these deep veins is going to increase. Another risk factor is going to be obesity beta, or as I've told you, DVT, because DVT mein there is blockage and therefore pooling of blood in the deep veins. Next is progesterone beta. If I talk about progesterone, why? Because progesterone is a smooth muscle relaxant beta, and that's the reason it causes dilatation of the vessels in the dilatation of the deep veins beta, and that causes pooling of blood. This is the reason why patients develop edema during pregnancy. Okay, because of progesterone basically in the lower limbs. No issues with this, anybody? Next important beta, other factors could be definitely genetics and family history are also responsible. Okay. Next important is if I talk about varicose veins beta, there are various clinical presentations with which the patient can come to us, but you have to remember beta, the most important ones basically, as I've told you, these dilated tortuous veins which are there, those are varicose veins beta, which are seen over here. Apart from that, here as the varicose veins are seen, as the varicose veins have developed, that means the superficial veins are dilated beta. In that superficial vein, there will be a lot of pooling of deoxygenated blood, and if a lot of deoxygenated blood pools up beta over there in the lower limbs, there can be pigmentation basically, and second there can be eczema also which can develop, and ultimately ulceration which can happen beta. Okay, so that can be a complication of varicose veins. If I talk about this beta, we'll talk about the stages also, but please remember this picture if it comes beta, it is you are able to see that the veins have started getting dilated beta, and these veins, if they are dilated up to 1 millimeter, they are called as telangiectasia beta. Okay, and this telangiectasia or the thread veins we call it as, Here they are seen in a fan shaped manner. So when telangiectasia or okay sorry, when the telangiectasia which is there beta or the thread veins are seen in a fan shaped manner, this is classically called as what? This is called as corona phlebectasia beta. Okay, do remember this name. This is what is called as corona phlebectasia, previous year NEET PG question. Or I can also call this condition beta, aka we can also call this condition as malleolar flare bache. We can also call this condition as a malleolar flare beta. No issues with this, anybody? Yeah, OCPs are usually avoided, but in this patient, OCP should be avoided in any patient of having increased risk of thrombosis. Okay. So corona phlebectasia beta, also known as malleolar flare, that will be seen over here. No issues with this, anybody? Next important beta, if I talk about, is the next picture, and this picture which is there beta, here you are able to see telangiectasia in the surrounding, and in the center beta there is hypopigmentation or atrophy basically, right, due to decreased blood supply, and this is classically called as atrophy blanche beta. This stage which is there beta is classically called as atrophy blanche. So these are the image based questions which could come in the examinations. ठीक है, तो याद रखना कोरोना फ्लेबेक्टेशिया has come in a previous year NEET PG, so do remember these at least, कोरोना फ्लेबेक्टेशिया or malleolar flare, and the second one is atrophy blanche beta. ठीक है, चलो. Once you do this, now let's talk about the classification for the varicose veins. I hope all of you are quite aware about the name of the classification used for varicose veins beta, and the classification that we are going to use for varicose veins beta is going to be which one? The classification that is going to be used for varicose veins is called as the CAP classification. Now, if I talk about the CAP classification, what is the CAP classification? Do remember, beta, CAP is actually a classification based on 4 parameters, beta. And what are these 4 different parameters? The first parameter which is there, okay, the first parameter is clinical manifestations. That is based on signs and symptoms of the patient, beta. If you are going to do a classification or staging, that is what is called as the clinical manifestation based classification. Second important, E stands for etiology beta. So based on the cause or the etiology, we can do a classification. Third, A stands for what? A stands for anatomy. That is based on the anatomical distribution or the location where these varicose veins are developing beta, you can do another classification. And last is P beta. P stands for what? Pathophysiology. That is based on pathophysiology, that is the mechanism why the varicose veins have developed. Based on that, if you classify them, that is called as a pathophysiological classification. The most important that you have to remember for your examination is this one beta, the clinical manifestation or the sign symptoms based classification beta, that we need to talk about. But remember, all of them definitely beta has to be remembered. Which one causes higher risk matlab? So please remember beta, CAP classification, if I talk about, you have to remember that C stands for clinical manifestations, E stands for etiology, A stands for anatomy, and P stands for pathophysiology beta. The classifications could be based on these 4 parameters. Name of the classification is important, full form is important, and third, the clinical manifestation based whole classification is important. Now, if I talk about the clinical manifestation based classification beta, let's talk about it in details. The first one is C1 beta. What is C1 basically? C1 matlab the veins are less than 1 mm dilated. When the veins are less than 1 mm dilated beta, that is what is called as telangiectasia. When the veins are less than 1 mm dilated, that is known as a telangiectasia beta, that has to be remembered. Okay, telangiectasia means the vessels are less than 1 mm dilated. Or beta, we can also include if the vessels are 1 to 3 mm dilated. If the vessels are 3 mm dilated beta, then that is called as reticular veins beta. If the vessels will be or the veins will be 1 to 3 mm dilated beta, those are known as reticular veins. Clear about? Next important beta, if I talk about basically C2. Okay, C2 is क्या? C2 is nothing else but varicose veins itself beta. Yes, C2 is varicose veins, and varicose veins means when the veins are more than 3 mm dilated. So when the veins are going to be more than 3 mm dilated beta, that is what is called as varicose veins. And this has been a previous year question of your exam, that varicose veins will come under which classification. So answer has to be C2 beta. Okay, and when they write this R beta, this small r which is there, C2R, matlab they are talking about a recurrent varicose veins. Malleolar flare is due to varicose veins. It is a manifestation of varicose veins basically. when definitely that telangiectasia is seen in a fan-shaped manner. That is what is my coronal ectasia or malleolar flare. Okay, so that is important beta. C2R, R stands for recurrent if I talk about. Okay. If I talk about beta C3 now, what is C3 basically? So C3 is nothing else but beta edema. Why? Because if there is pooling of blood inside the superficial veins of leg, obviously beta the pressure in the superficial veins will be high, and due to that beta extra fluid will get kicked out, leading to development of edema in the patient beta. Okay, the patient will have edema. Next important bache is C4A now. If I talk about C4A, okay, if I'm going to talk about beta C4A basically, that is what it is, pigmentation and eczema beta. C4A is going to be pigmentation and eczema due to pooling of deoxygenated blood, as I've told you. Okay, no issues with this. Next important beta, if I talk about a C4B, तो याद रखना C4B is basically lipodermatosclerosis beta. ठीक है, तो C4B जो होता है, this is important, very important in your exams beta, has been asked twice or thrice. So it is lipodermatosclerosis. ठीक है, तो C4B beta is nothing else but lipodermatosclerosis बच्चे, has to be remembered. Important is C4C beta. What is C4C? The ones that we have discussed, that is corona phlebitis or atrophy blanche beta. Corona phlebitis which is there, or the atrophy blanche if it is seen, it will be considered as C4C beta. And next is C5 beta. What is C5 basically? याद रखना C5 is nothing else but healed venous ulcer. थोड़ा सा उल्टा है. Please remember beta, healed ulcer which is there, it is C5, and C6 means an active venous ulcer. ठीक है, याद रखना C5 मतलब a healed ulcer, but C6 मतलब a active venous ulcer beta. I hope all of you are quite aware that venous ulcers are also known as varicose ulcers, because the most common cause of varicose ulcers beta is nothing else but or venous ulcers is the varicose veins itself. ठीक है, that has to be remembered. First point to be remembered. Second point to be remembered beta is definitely that the venous ulcers which are there, they are superficial or shallow ulcers beta, with which kind of edges I told you, they are going to have sloping edges beta. That has to be remembered. Clear है बात? चलो, so that is important. तो जल्दी से एक बार. Okay, so CAP classification is used for varicose veins. C for clinical manifestation, E for etiology, A for anatomy, and P for pathophysiology. Clinical manifestation based classification is C1 telangiectasia or reticular veins, C2 varicose veins, R stands for recurrent. ठीक है, C3 edema, C4A pigmentation and eczema, C4B lipodermatosclerosis, C4C corona phlebitis or atrophy blanche, C5 healed ulcer, and C6 active venous ulcer. Clear है बात? That is important. Now if I talk about beta, is this picture over here. This picture has come in your examination earlier beta, and what is this? So understand here beta, the basically the patient is having fat loss from the limb beta. Yes, you are able to see there is fat loss basically from the limbs over here beta, because of less blood supply. There is fat loss also. Then there is muscle contracture also beta. So there is fat loss, there is muscle contracture. Okay, and that's the reason beta, when you press this limb basically, when you press at this part which is there beta, it is going to feel woody hard. Yes, the texture basically beta of this part is going to be woody hard. So woody hard texture hota hai. So you are able to see fat loss, you will be able to feel muscle contractures, there will be a woody hard texture, there will be pigmentation and eczema that is visible beta, and this is classically called as beta, this which is there beta, this appearance which is there is classically known as the inverted champagne bottle appearance beta. Clear hai? This appearance of the leg basically beta is known as the inverted champagne bottle appearance. Okay, so inverted champagne bottle appearance in leg, if they ask you it is seen in which condition, you have to remember it is seen in varicose veins. And in which stage of varicose veins is it? So it is nothing else but beta C4B. And what was the stage C4B? C4B is nothing else but lipodermatosclerosis, right? C4B is what? C4B is nothing else but lipodermatosclerosis. So in your previous year exams beta, they have given this picture and they asked you that which stage is it. So we know the picture which is there, it is of lipodermatosclerosis. By the name it is evident. Now sclerosis is what? Fibrosis. So here basically there is fibrosis at the level of the fat and the muscle beta, and even in the skin, and that's the reason you are able to see a woody hard texture at this side beta. Okay, so inverted champagne bottle appearance is seen in patients of lipodermatosclerosis, and the stage is going to be C4B. Clear to all of you now? Chalo. The next picture which is there, beta, here you are able to see pigmentation, but along with pigmentation, what is this, beta? This is nothing else but a ulcer that is usually visible over here. Okay, this is an ulcer, beta, not an active one. This is a healed ulcer, C5 है. Hopefully clear to all of you. Chalo. So these are the things, beta, you have to remember about the classification of varicose veins. Now let's talk about the clinical features and the further diagnosis of the patient. Now when I talk about clinical features or diagnosis, beta, first one, clinical feature will be what, beta? The patient will have a dull aching discomfort, beta, in the calf or the heel region, right? The patient will have always a dull aching discomfort either in the calf or the heel region, beta. Okay, and the patient will have a dilated veins which are visible, and some patients may have extreme pain, beta. Reason, deoxygenated blood is pooling up over there, the skin and the nerves are not receiving enough blood supply, and that's the reason, beta, the nerves will start dying, and that will cause extreme pain in the patients, beta. Okay, so either there is only a dull aching discomfort or there can be a severe pain, beta, in the legs of the patient along with that dilated appearance of the veins. Okay, now on examination, beta, two tests could be done. One test is basically to check the valvular incompetence. Second test is basically to check the perforator incompetence. Understand what I'm trying to tell? Okay, you don't have to perform this test, obviously, just remember the names, but understand it once. My patient will be lying down, beta, supine. Once my patient is lying down supine, what I'm going to do, I'm going to raise the leg of my patient, beta. मैं patient का leg उठाऊंगा, and then I'm going to empty all the superficial veins of my patient, right? You are just going to press it properly, and you are going to do a proper drainage of all the superficial veins. Once the superficial veins of the legs, beta, will become empty, what are you going to do? Once the legs, once the veins become empty, beta, you have to tie tourniquets, beta. Where you tie tourniquet? Understand. One tourniquet I will tie at this level, beta. That means I will tie one tourniquet at the level of thigh to block which junction? To block the saphenofemoral junction. Next tourniquet I'll tie at the level of the knee, beta. At the level of the knee, which junction we have to block? We have to basically block the saphenopopliteal junction. Now, beta, all the superficial veins are empty. Okay, so the varicosities are not seen, beta. Okay, the dilated appearance is not seen, first thing, and even the junctions are blocked, beta. Okay, now what I'll do, I will ask my patient to stand up. As soon as my patient stands up, beta, I'm going to open the first tourniquet. Now, as I've opened the first tourniquet, beta, okay, what is seen? If the saphenofemoral junction is normal, or if the valves at this junction are normal, beta, I may not be able to see any problem as such. But as soon as I remove the tourniquet, beta, and if there is a lot of blood started filling inside the superficial veins, beta, okay, if there is a lot of blood which is filling up inside the superficial veins, and immediately varicosities have started appearing, beta, that means my patient is having a valvular incompetence at which junction? Saphenofemoral junction. Next, if I'm going to open the second tourniquet, beta. Now, once I open the second tourniquet, beta, and if immediately if the blood starts filling up inside the superficial veins, and if I'm able to see that dilated appearance in the superficial veins, beta, okay, that means there is a valvular incompetence at the level of which junction? Saphenopopliteal junction. This test which is there, beta, is basically called as the Brody-Trendelenburg test. And please remember, this is done basically for checking the valvular incompetence at both the junctions. Next condition mein, again my patient is going to lie down. I'm going to again raise the leg of my patient. I'm going to properly empty or drain the superficial veins of my patient. After doing that, beta, again we are going to tie two tourniquet. Now again my patient is going to stand up. But this time when my patient stands up, beta, I'm not going to remove either tourniquet. कोई tourniquet निकालना ही नहीं है. Now, if I'm not removing the tourniquet, beta, that means the patient's junctions are still blocked. If the patient's junctions are blocked, beta, should I be able to see those varicosities now? No. But here what happens, beta, after some time, I'm able to see, beta, slowly, the blood is coming inside these superficial veins, beta, and slowly, that dilated appearance have started occurring. Okay? And this, beta, is suggestive of a perforator incompetence because patient के junctions तो blocked थे. Still, if there is a blood filling inside the superficial veins, beta, that means the perforators of this patient are incompetent, beta, and it is suggestive of a perforator incompetence. Okay, and perforator incompetence means the filling of blood will be much slower, beta. Clear about? This is called as the Fagan's test. So do remember the two tests. Valvular incompetence के लिए I have told you, beta. Either you can call it as the Brody-Trendelenburg test or the tourniquet test. We can either call it as the Brody-Trendelenburg or the tourniquet test beta. Remember the names, that's more important for your exams. Okay, whereas for perforator incompetence beta, it is going to be called as a Fagan's test. Done with this? Chalo. Now, if they ask you what is the investigation of choice, as usual, superficial veins are there. That means peripheral vessels are there. Peripheral vessels hai. The investigation of choice has to be what? Duplex scan. So, beta, here you have to go for a duplex scan. The investigation of choice has to be duplex scan. And when we go for a duplex scan in the patient beta, we are able to see a very classical feature. And what is that? Understand now. Here, beta, when I do a duplex scan, here, this is the common femoral vein of the patient, right? This is the common femoral artery of the patient. Normally, beta, this third one which is there, this is called as a saphenofemoral junction, beta. This appears to be collapsed. Why? Because obviously the pressure at the saphenofemoral junction is going to be very, very less. That's the reason, beta, this saphenofemoral junction will never appear prominent. But here you are able to see, beta, the saphenofemoral junction of the patient is appearing prominent. Why? Because the valves at the saphenofemoral junction are absent or they are defective. That's the reason a lot of blood from the femoral vein beta is usually going into the saphenofemoral junction and then into the great saphenous vein. And that's the reason the saphenofemoral junction is dilated over here. And due to the valvular incompetence at the saphenofemoral junction, very good, we are able to see the classical Mickey Mouse appearance beta. We are able to see the classical Mickey Mouse appearance which is. So, agar duplex scan of the lower limbs beta is going to show us the Mickey Mouse appearance, we have to remember it is suggestive of varicosities or it is suggestive of varicose veins beta in the patient. And Mickey Mouse appearance is suggestive of incompetence at which level? It is suggestive of beta a saphenofemoral junction incompetence. Okay, it is suggestive of a saphenofemoral junction incompetence. याद रखना ये बात. Clear है? Next important now, let's talk about the treatment. When I talk about the treatment beta in the patient, done. Chalo. So beta treatment, if the patient presents to me early, that is early in the sense in the stages of telangiectasia, reticular veins, इस stages में अगर patient मेरे पास आता है बेटा, if the patient presents to us early basically, तो क्या करोगे बस lifestyle modification, right? We know ना there are modifiable risk factors in the patient. So beta, please remember when the patient presents to you early basically, you can ask the patient to go for lifestyle modifications. And what are the lifestyle modifications, बच्चे? The first thing is you have to ask the patient beta to avoid prolonged standing. You can ask the patient that you can please sit and you can definitely do all your work beta. ठीक है? You have to avoid prolonged standing. So please remember that he has to avoid prolonged standing. That is the first important thing. Second important beta, if he says no Dr. Saab, it's not possible and all of that, second advice you will give that whenever you sit or whenever you sleep beta, you have to keep a pillow below your legs basically. Why? As he keeps a pillow below the legs beta, obviously his limbs will be elevated, and if the patient's lower limbs are elevated beta, all the blood from the deep and the superficial veins is able to drain properly. And if there is a proper drainage of blood beta, obviously the pooling of blood will not happen in the lower limb veins beta. Okay, so that is what is avoided. So always ask the patient to elevate the limb. That can be another advice. Apart from that beta, the third advice should be, and the most important advice, that if the patient has to stand, the patient can stand, but the patient has to wear elastic compression stockings during that time. Reason, if a person is going to wear the elastic compression stockings, it is obviously not the normal stockings that you people wear. Okay, elastic compression stockings beta, they are a very, very tight stockings basically, which is going to compress the leg beta. Okay, and it can cause pain also. It is so tight. So definitely the patient has to wear these elastic compression stockings beta, so that what is going to happen, then the leg of the patient will get compressed, and if the leg is compressed beta, the muscles are compressed, the superficial veins of the patient will be collapsed. If we are going to collapse the superficial veins, please tell me, due to the external pressure the superficial veins are collapsed, will the blood be able to enter inside the superficial veins now? No. So please remember beta, the blood is not able to enter inside the superficial veins, and that is what is done. Clear about? So do remember beta that here the patient will, okay, will be asked to wear elastic compression stockings. That is a very important advice to be given. Clear about? So Now if I talk about beta the late stages में क्या होता है, late stages में obviously beta the only option that is left with us is surgeries beta, ठीक है. Late stages में we have to go for surgery. Now which kind of surgeries, let's see them one by one. The first condition beta, if I say if the problem is at the level of the saphenofemoral junction, yes, if it is a saphenofemoral junction incompetence beta, then what we can definitely do, no beta lifetime नहीं करना होता. So please remember beta definitely here if the problem is at the level of the saphenofemoral junction incompetence, ठीक है, saphenofemoral junction बेटा, ठीक है, यहाँ पे अगर प्रॉब्लम है तो what we have to do, we have to ligate the saphenofemoral junction itself. Why? If you ligate the saphenofemoral junction itself beta, obviously the blood from the femoral vein will not go into the great saphenous vein, and that is what is needed, right? So we can do a ligation, but that ligation is not done over here. Reason, if you do it over here beta, and if the stump is left, that stump can actually rupture due to high pressure, ठीक है. So that is the reason beta ligation will always be done exactly on the surface of the deep vein beta, and that is called as the flush ligation. Okay, and once you have done a flush ligation beta, you have to strip off the great saphenous vein. Yes, you are going to strip off, you are going to remove the great saphenous vein. You will be like, sir, any problem? Grafting में भी निकालते हो ना? No problem, ठीक है. So please remember beta, here we know that for example beta, this is the saphenofemoral junction. Here we are going to do a flush ligation, but after that we have to remove the great saphenous vein. We have to strip the great saphenous vein beta only up to the knee. Only इतना ही हिस्सा निकालना है बस. Okay, only this part of the great saphenous vein has to be removed beta. Reason, if you try to remove the great saphenous vein below the knee beta, please remember here the great saphenous vein is very closely attached with a nerve beta known as the saphenous nerve. If you try pulling out over here, obviously there can be a very high risk of injury to the saphenous nerve beta. That has to be remembered. So saphenofemoral junction incompetence mein, what is the surgery that we do? We have to go for a Trendelenburg operation beta. We have to go for a Trendelenburg operation. Clear hai? Thus the surgery that I have just now explained you is known as the Trendelenburg operation beta. And what is done in Trendelenburg operation? I have told you, flush ligation of the saphenofemoral junction along with stripping of the great saphenous vein. But stripping of great saphenous vein should be done only up to the level of the knee beta. It is only done till the knee to avoid injury to which nerve? To avoid injury to the saphenous nerve beta. Clear about that has to be remembered. To avoid injury to the saphenous nerve beta, you have to do the stripping only up to the knee itself, not below the knee. Next important beta, if there is a saphenopopliteal junction incompetence. So if there is saphenopopliteal junction incompetence beta, the same surgery is done beta over here. We just have to do a flush ligation beta of the saphenopopliteal junction, ठीक है. यहाँ पे flush ligation करोगे saphenopopliteal junction का, but do not remove the short saphenous vein beta. We are not going to strip off the short saphenous vein basically. We are going to keep the short saphenous vein as it is. Reason beta क्या है? Understand. Here we are going to ligate the saphenopopliteal junction at the level of knee, but after that we are not going to strip off the short saphenous vein. Reason, short saphenous vein which is there beta over here, it is very closely associated beta with another nerve known as the sural nerve. If you are going to strip off the short saphenous vein, there will be a very high risk of injury to the sural nerve, and that's the reason you are not going to strip it off. So saphenopopliteal junction incompetence अगर है, so here we have to do a flush ligation of the saphenopopliteal junction, but there is no stripping as such beta of the short saphenous vein which is done. GSV, at least we were stripping of GSV till the knee. Okay, but short saphenous vein, no part of short saphenous vein will be stripped off beta. Okay, otherwise it will lead to injury of the sural nerve. That is important to be remembered. Done with this. Chalo. Next important beta, if I talk about is perforator incompetence. If there is a perforator incompetence beta, okay, the incompetence is at the level of the perforator. So what we do, we previously used to perform a surgery beta called as the Dodd and Cockett surgery. We previously used to perform a surgery which is known as the Dodd and Cockett surgery. Now what we used to do in Dodd and Cockett surgery, we actually beta used to make multiple incisions. Dodd is where? Above the knee. So here we used to make one incision beta and we used to ligate that perforator. Then we used to make 3 incisions beta above the medial malleolus, 5, 10 and 15 centimeters above the medial malleolus, and we used to ligate these 3 Cockett perforators beta. Okay, that was called as the Dodd and Cockett surgery. But what was the problem beta? In this surgery we had to make multiple incisions at various sites, right? बहुत सारे अलग अलग incisions करने पड़ते थे for each and every perforator. So we thought, why to make so many incisions? Can we make just a single incision and can we do the surgery with that? Yes. And therefore we have come up with a new surgery for the perforator incompetence beta, and that is known as the SEPS. What is SEPS? Understand. It is subfacial endoscopic perforator surgery. So what we do over here? Above the medial malleolus beta, we have to make an incision. And once we make that incision above medial malleolus, we have to create a tunnel from there where we can pass the endoscope beta. Okay? We have to create a tunnel. Where is this tunnel created? Between the fascia and the muscle beta. Therefore, it is called as subfacial. So we have to create a tunnel beta between the fascia and the muscle, and we have to pass the endoscope along with it. Now, when you are going to pass the endoscope, you will be able to analyze the perforators. Once you have analyzed the incompetent perforators beta, you can ligate all these perforators beta. Okay? Definitely, you can ligate all these perforators with the single incision basically. Okay? So, with the help of lasers basically nowadays, or with the help of clips also beta, we can usually ligate the perforators, and that surgery which is there is known as the SEP surgery, that is subfacial endoscopic perforator surgery. So done with this. Next important beta, let's talk about the new techniques basically for the management of varicose veins. If I talk about the new techniques beta for the management of varicose veins, we have to remember the new modalities mein. One of them is a endovenous glue therapy. You have to block the perforator. We have to just block the junction na. What we can do to block the junction or the perforator? We can just inject beta a glue over there at that side, so that the glue is going to block the junctions. So we can go for endovenous glue therapy, and in endovenous or endovascular glue therapy beta, which is the common glue used, so you have to remember the name of that glue beta, that is called as the cyanoacrylate glue. Okay, so it is basically called as the cyanoacrylate glue beta, which can actually block the junctions of the perforators for us. Next important is called as a foam sclerotherapy. What is done in foam sclerotherapy? Here we actually here we actually make a foam beta of the sclerosing agent, and then we have to inject that foam of the sclerosing agent beta at the level of the junction, so that this sclerosing agent over here is going to cause fibrosis beta, and once there will be fibrosis at the level of junction, obviously the junctions are going to get blocked completely. That is what we want. So foam sclerotherapy. Another question, that which is the most common sclerosing agent used for the purpose of foam sclerotherapy beta? याद रखना, the most common sclerosing agent used is going to be 3% sodium tetradecyl sulfate beta. So it is 3% sodium tetradecyl sulfate, which is actually going to be the most common sclerosing agent used during a foam sclerotherapy. Okay, remember the sclerosing agent, it is important, because it is not only used over here, because sclerotherapy can also be used for the management of esophageal varices, or even for the management beta in a case of hemorrhoids as well. Okay, so that's the reason. Now if they ask you what is going to be the surgery of choice beta, so yaad rakhna, here the surgery of choice is going to be EVLT beta. What is EVLT now? EVLT is an endovenous laser therapy. So nowadays beta, we know if I want to block a junction or I want to block a perforator, I can easily do it with the help of either a laser beta. Okay, we can coagulate that junction, or we can do it with the help of a radio frequency waves beta, right? So that is important. So nowadays beta, the surgeries of choice which are there, the surgeries of choice nowadays beta is going to be either EVLT. And what is EVLT? It is nothing else but an endovenous or an endovascular laser therapy. It is nothing else but endovenous or a endovascular laser therapy beta. Either that can be used, or definitely beta RFA. RFA is what? Radio frequency ablation. RFA is nothing else but a radio frequency ablation. These are considered beta as the surgery of choice nowadays for your varicosities. Okay, so do remember them. So done with this. Now the last part of the vascular surgery beta that we have to remember, and the last part of that vascular surgery is going to be lymphedema beta. Okay, let's talk about lymphedema now. This is about the lymphatics now. Shall I done with this? When I talk about lymphedema, bache, okay, lymphedema is what? Lymphedema is nothing else but beta collection of lymph basically, or lymph is nothing else but an interstitial fluid. So in between the cells, when there is collection of a lot of lymph or a lot of interstitial fluid, that condition is known as a lymphedema. Okay, so accumulation or collection of excessive lymphatic fluid or excessive interstitial fluid is what is known as a lymphedema beta. Okay, lymphedema can happen in the upper limbs of the body also, as well as in the lower limbs also. More commonly it is seen in the lower limbs of the body. Clear hai? Now there can be two types of lymphedema beta. Either it is a primary lymphedema or a secondary lymphedema. Now, primary lymphedema beta is basically due to some defect in the lymphatic channels. Okay, it is basically due to a hypoplasia, that is nothing else but underdevelopment. It is due to hypoplasia, okay, or underdevelopment of the lymphatic channels. As the lymphatic channels are not well developed over here beta, there is basically a leakage and accumulation of lymph beta that is going to cause a primary lymphedema. Next important is the secondary lymphedema, which is much more common beta. And secondary lymphedema, if they ask you beta, okay, the most common cause of secondary lymphedema is going to be what? So do remember the most common cause of a secondary lymphedema is going to be infections beta. Yes, there are certain infections beta which can definitely cause a secondary lymphedema, and I hope all of you are quite aware the most common infection which is there, which is going to be a condition known as lymphatic filariasis, right? Lymphatic filariasis, which is caused by Wuchereria bancrofti beta. Okay, the lymphatic filariasis, which is known as which is caused by the Wuchereria bancrofti, that is basically going to be beta the most common cause of lymphatic filariasis, and that is known to cause beta a secondary lymphedema in the patient. Okay, that is known to cause a secondary lymphedema in the patient. That has to be remembered. Apart from that beta, what are the other causes? The other causes can be axillary lymph node clearance. Yesterday I have told you beta that when you do a axillary lymph node clearance during a modified radical mastectomy beta, definitely the patient may have damage to the lymphatics, which can lead to a upper limb lymphedema in the patient. Rather, I've told you the most common cause of upper limb lymphedema is the axillary lymph node clearance or a MRM itself. Okay, whereas the patient the other surgeries which are there beta, they can also increase the risk of secondary lymphedema or even radiotherapy for that matter. Reason, radiotherapy causes fibrosis beta, and if there is going to be fibrosis of the lymphatic channels beta, that will increase the risk of lymphedema in the patient. ठीक है, याद रखना ये बात. No issues with this. Primary lymphedema का one of the conditions we have studied in the morning beta, and that was what? That is nothing else but cystic hygroma. Cystic hygroma is due to underdevelopment of lymphatic channels na, so it is an example of lymphedema only. ठीक है. If they ask you most common site, I have told you beta the most common site for a lymphedema to develop are going to be the lower limbs of the patient. Upper limb may definitely beta the patient may develop a lymphedema, and if they ask you what is the most common cause of an upper limb lymphedema, so we know that the most common cause of the upper limb lymphedema is nothing else but either I can call it as axillary lymph node clearance, ठीक है, or dissection जो भी बोलना है तुम्हें, or we can call it as MRM beta. ठीक है, whatever is there in the option you can mark it as. ठीक है, either you can call it as the axillary lymph node clearance beta or the modified radical mastectomy. That is actually considered as the most common cause of upper limb lymphedema in a patient. If they ask you what is going to be the complaint of the patient, obviously beta lymphedema hai, so you can see definitely the patient is going to have swelling bit of the limb, right? The patient is actually going to have swelling of the limb bache. Along with that, sometimes the patient may also have pain as well. Okay, and the patient may have skin features, like the patient may have pigmentation of skin, there can be ulceration on skin. These kind of skin features can be there. Now, if they ask you beta what can be done for the diagnosis of the patient, either a very gross method is what beta, limb volume measurement could be done. Yes, okay, we can just do a limb volume measurement, but that's a very gross method and not the best one. So therefore beta better one is what, lymph angiography, where we have to inject a dye inside the vessel and we can see the leakage beta. Okay, so that is a lymph angiography. But even better than that beta, okay, even better than that, the gold standard investigation, if they ask you, an answer has to be a water plethysmography. Okay, याद रखना बेटा, if they ask you whatever is the gold standard investigation, so nowadays if they ask you what is the gold standard investigation, answer has to be a water plethysmography is considered as the gold standard investigation for lymphedema. Now treatment is what beta, treatment की अगर मैं बात करूँ, this is a very small topic beta, that's the reason I'm pacing up. Treatment which is there, the first one is nothing else but beta limb elevation. What is limb elevation? We just have to ask the patient to elevate the limb. She has to take the pillow below the legs beta, so that there is a proper drainage of the limbs beta, and if there is proper drainage of the lymph, the lymphedema, the risk of lymphedema is going to decrease. So limb elevation could be done beta. Second important, you have to give antibiotics. Reason, the risk of secondary bacterial infections is going to increase beta. That's the reason you should give antibiotics. And third, you'll ask the patient to do proper skincare. Reason is, if the patient is having a ulcer development, or if the patient is having a wound beta, she has to take proper care, of the person has to take proper care on the wound beta. Regular cleaning and dressing of the wound has to be done. Okay, so that is important. If they ask you, apart from this, what could be done? If it is a severe condition beta, we have to go for a decongestive therapy. Now you'll be like, sir, decongestive therapy, what we do? In decongestive therapy, we try to drain the lymph which has been collected. Now what are the various ways beta to drain the lymph? The first way is beta, nothing else but manual drainage. What is manual drainage? You are going to do proper massages beta, or physiotherapy basically, with the help of which you can drain the lymph properly beta. Yes, DEC provocation, अगर lymphatic filariasis से है तो DEC provocation can be done. ठीक है, no issues with this beta. तो याद रखना, the main management which is there in decongestive therapy is done by manual drainage बच्चे. तो manual drainage करते हैं तो usually it is done with the help of physiotherapy. You can ask the patient to, like, either with the help of physiotherapy or with the help of a massage beta properly, we can definitely do a proper manual drainage. Okay, so that is important to be remembered. Apart from that beta, okay, elastic compression stockings can be given to the patient, because obviously if you give elastic compression stockings beta, the lymphedema which is there is going to reduce. So elastic compression stockings also have a very important role to play, and even exercises beta. I have told you yesterday itself that lymphedema agar develop hota hai, so you can actually recommend the patient exercises, so that exercises will actually help in draining of the lymph properly beta. Okay, so manual drainage, elastic compression stockings, and definitely exercises beta. These are the methods with which you can actually prevent a lymphedema, or you can treat a lymphedema. Complications now. We know beta, the first complication which is there is going to be skin changes. You may be able to see. Okay. Apart from that beta, the patient may also have infections. The patient may have skin changes, the patient may have secondary bacterial infections, or the patient may have this kind of a deformity. We know better that a patient, when he develops a lymphatic filariasis, okay, and if that wound is not properly taken care of, obviously it can lead to such kind of a deformity. And what is this deformity called as? This deformity is known as elephantiasis. Yes, and we know elephantiasis is actually a complication of lymphatic filariasis beta. Okay. Next important, if the patient had a lymphedema beta and a long-standing lymphedema, that is almost for a span of 8 to 10 years. Okay, a long-standing lymphedema for almost a span of 8 to 10 years beta, and that patient was not given a proper attention. So what is going to happen? That patient may develop a secondary malignancy of the lymphatics beta, and I've told you that secondary malignancy arising from the lymphatic duct will be called as lymphangiosarcoma, and then the patient will present to you beta with these kind of features. What is these kind of features? You are able to see definitely beta over here. There are blackish, bluish nodules definitely seen all over the arm of the patient, and this is what is called as the lymphangiosarcoma, known as Stewart-Travis syndrome. This was a previous year image based question which has come in your exam. ठीक है, तो याद रखना है बेटा, that lymphangiosarcoma which is there beta is known as the Stewart-Travis syndrome, which may develop as a complication of a long-standing lymphedema in a patient. Clear to all of you now? That has to be remembered. So this is what is the Stewart-Travis syndrome beta, or the lymphangiosarcoma. Okay, that was all about your lymphangiosarcoma, lymphatics, and that was all about your vascular surgery. Now let's start with the major part of your surgery beta, and that is nothing else but GIT. The first part in the GIT beta is nothing else but the oral cavity and the salivary glands. A short part beta, not like a lot of questions do not come, but yeah, it is like there are some questions here and there, miscellaneous types, which keep on coming from this topic. So let's talk about them. Okay, so let's talk about them. Done with this, hopefully. That was all about your lymphedema. Now let's talk about GIT. In the first part we have to discuss beta is nothing else but the oral cavity. Okay, if I talk about the oral cavity beta, here the first thing we need to discuss is the oral cavity cancer or oral cancer. Now when I talk about the oral cancer in a patient beta, okay, when we talk about the oral cancer in a patient, please remember, we know that what are the most common sites for oral cancer beta. The most common site for oral cancer worldwide, if they ask you, okay, worldwide agar puche most common site for oral cancer, you are able to see beta, it is the lateral border of tongue. Here you are able to see a ulceroproliferative growth on the lateral border of tongue. Whereas if they ask you beta, which is the most common site for oral cavity cancer बच्चे in India, तो याद रखना the most common site for oral cavity cancer in India is going to be this anata. What is this? That means basically between the gums and the buccal mucosa beta. Okay, you are able to see this gap now. That gap is basically called as the gingivo-buccal sulcus beta. ठीक है, तो प्लीज रिमेंबर बेटा, इन दैट gingivo-buccal sulcus बेसिकली द पेशेंट इज गोइंग टू हैव द ओरल कैविटी कैंसर इन इंडिया. क्यों? आई होप ऑल ऑफ यू आर क्वाइट अवेयर. क्या करते हो? व्हाट यू डेफिनेटली कीप ओवर देयर बेटा, टोबैको. सो दैट्स द रीजन बेटा. इंडिया में अगर पूछेंगे तो इट इज अ gingivo-buccal sulcus. ठीक है, तो मोस्ट कॉमन साइट वर्ल्ड वाइड लैटरल बॉर्डर ऑफ टंग. ठीक है, so most common site worldwide is going to be the lateral border of tongue beta. Whereas the most common site in India, as I've told you, is not nothing else but beta the gingivo-buccal sulcus. And अगर gingivo-buccal sulcus में एक choose करना है, that means whether it is more commonly seen on the gums beta, that is gingiva, or the buccal mucosa, which one will be more common? तो याद रखना है, the more common one among both of them beta is going to be the buccal mucosa. Okay, so the more common one is going to be buccal mucosa beta. That has to be remembered. No issues with this, anybody? Okay, that is important beta. चलो, तो याद रखना है, this has been questions beta. Gingivo-buccal sulcus have been a question. Even the lateral border of tongue could be a question beta. So do remember that. Important is if they ask you beta oral cancer or the oral cavity cancer histopathologically is which type most commonly. So we know beta or that in the GIT beta there are three sites where a squamous cell carcinoma is going to be common. One is the oral cavity, second is the esophagus, third is the anal canal. So at these three sites beta squamous cell carcinoma is common. Rest in all other parts of GIT beta adenocarcinoma will be seen. ठीक है, तो oral cavity, esophagus, anal canal, squamous, बाकी सब जगह adeno. So the type of oral cavity cancer beta we know more commonly has to be a squamous cell carcinoma, which has to be a squamous cell carcinoma. No issues with this. Now important is what are going to be the risk factors for oral cancer beta. Let's talk about beta. What are the risk factors for squamous cell carcinoma? The first one is, we know smoking and alcohol sarkari risk factors beta. So the two sarkari risk factors for cancer beta, that is smoking and alcohol. Next important beta is tobacco use, especially, right? So tobacco use definitely, okay, all that gutka वगैरह everything, ठीक है. So please remember tobacco use is going to be important risk factor. Next, sharp dentures beta, right? Sharp dentures definitely, because they are going to cause injury to the buccal mucosa, and that's the reason beta the patient may have a ulcerative lesion first and then a cancer from there. Next important beta, those people who eat betel leaf. What is betel leaf? Pan. So those people who eat pan a lot, ठीक है, तो betel leaf or areca nuts beta, that is supari, ठीक है, तो pan, supari, all of them beta. Or oral infections, like which oral infection? So there is a viral infection beta which actually causes overgrowths or warts basically, and those warts can further develop into a cancer beta, and that infection which causes warts beta is nothing else but HPV. And what is that HPV beta? I hope all of you are quite aware. It is nothing else but human papilloma virus beta. So that human papilloma virus bache is also associated with oral cavity cancer. Yes, it is also associated with multiple cancers beta apart from oral cavity. Okay, and we know the high risk strains of HPV virus, that is 16 and 18, will be associated beta. Okay. Now if they ask you what are the pre-malignant conditions bache, so do remember the pre-malignant conditions in the patient are going to be pre-malignant matlab kya? These conditions may further develop into a cancer. So let's see the various pre-malignant conditions. The first one is, here you are able to see beta a white patch in the oral cavity. Now once there is a, when there is a white patch in the oral cavity, that will be called as leukoplakia. Leuko means white, plakia means patch. Okay. Next important, here there is a red patch in the oral cavity. So red patch is called as erythroplakia. Okay. The next one beta, here you are able to see that the patient had an ulcerative lesion initially, and then that ulcerative lesion is going to heal beta, and healing occurs with a lot of fibrosis. So here you are able to see a lot of fibrosis beta in the oral cavity of the patient, right? A lot of scars you can see beta. So this is called as a oral submucous fibrosis. Okay, oral submucous fibrosis beta. And lastly this one, this is basically a candidiasis. Please remember the normal oral candidiasis known as oral thrush, it does not increase the risk of cancer. This is the chronic hyperplastic candidiasis beta. So hyperplasia is seen over there, or overgrowth is seen over here. So only chronic hyperplastic candidiasis increases the risk of oral cavity cancer. Clear about? Chalo. So the various pre-malignant lesions you have to remember beta. The various pre-malignant lesions, they are very commonly associated beta with betel leaf chewing और अरेका नट चूविंग, ठीक है, बीटल नट चूविंग, तो इनके साथ डेफिनेटली बेटा ये चीजें बहुत ज्यादा कॉमन है. Now first one is erythroplakia. What is erythroplakia? As I told you, it is nothing else but red patch is what is called as erythroplakia. And if the patient is having erythroplakia beta, the risk of malignancy is very high. How many times the risk of malignancy increases? 6 to 9 times beta, there is a higher risk of malignancy. 6 to 9 times there is higher risk of malignancy, which that has to be remembered. No issues with this. Next important beta, if I talk about, is the leukoplakia. I've told you beta what is leukoplakia. Leukoplakia is nothing else but a white patch. Leukoplakia in simple terms beta is nothing else but a white patch. And if I talk about that white patch of the leukoplakia, this will have how much times of how many times increased risk? It has basically beta 3 to 5 times higher risk of malignancy. Yes, so yaad rakhna, leukoplakia basically has 3 to 5 times higher risk of malignancy. So which is more malignant or which is more dangerous beta? याद रखना, erythroplakia is more malignant or it is more dangerous. Leukoplakia on the other hand beta, if I talk about this leukoplakia which is there, it is definitely going to be much safer beta. Leukoplakia is going to be much safer, no issues with that definitely, but still there is 3 to 5 times higher risk of malignancy, so you have to get it excised beta, you have to remove it. Okay, yaad rakhna, if they ask you which is more common, basically the most common pre-malignant lesion is going to be leukoplakia beta. Yaad rakhna, the most common pre-malignant lesion is going to be leukoplakia, but the more dangerous one is going to be erythroplakia beta, as it is evident over here. Next condition is nothing else but beta oral submucous fibrosis. Now oral submucous fibrosis, I've told you, initially ulcer and then a lot of fibrosis and scars in the oral cavity beta, those are going to develop in the patient. Here beta, it basically develops because the patient has hypersensitivity to betel nut beta. So this patient keeps on chewing betel nut beta, and that is the reason the patient will have a due to that beta, the patient will have a hypersensitivity reaction that initially leads to ulcer formation, and then definitely beta, the patient will have fibrosis. Okay, what can be a treatment over here? I'm just talking about oral submucous fibrosis beta. In this condition beta, one of the options can be a intralesional injection of, you can just write down intralesional injection of which long acting steroid? What's that? Intralesional injection of triamcinolone beta. Okay, so intralesional injection of triamcinolone can be tried beta in a patient of oral submucous fibrosis. ठीक है, तो oral submucous fibrosis जो होता है, in that patient beta only we can give a intralesional injection of triamcinolone that can help in the management. Next important beta is called as chronic hyperplastic candidiasis beta. Very few cases of candidiasis may develop into this condition, and that can be considered as a risk factor beta. If they ask you what are going to be the treatments, the first and the foremost beta, the patient has to avoid all the risk factors. Whatever are the risk factors beta, like alcohol, tobacco, smoking, betel nut, betel leaf, and the areca nut beta, everything has to be avoided in the patient. The patient has to avoid those risk factors, first thing. Second, definitely beta, you can go for antioxidants in the patient. Okay, antioxidants could be given beta. And third important beta, the mainstay of management, as we know, it is nothing else but surgical excision beta. You have to scrape out this region. Okay, so surgical excision of this region should be done beta. That is important to be remembered. If it is very small, then we can definitely only go for a conservative management. But if it is larger in size beta, we have to go for a surgical excision. Okay, chalo. Now if they ask you beta, coming back to cancer, what is the investigation of choice for cancer beta? We know the investigation of choice for cancer, or even for these lesions beta, if you are not able to make a clinical diagnosis of these lesions, you can go for a biopsy. And obviously for a cancer, you have to go for a biopsy itself. You can just ask the patient to open the mouth and take a biopsy easily, right? Not even now endoscope is required. So investigation of choice beta for oral cancer has to be a biopsy directly. And if they ask you what is going to be the surgery beta, once you definitely do biopsy, it confirms that it is a cancer and it would be a squamous cell carcinoma. Once that has been done, or once that has been confirmed, if I talk about the treatment now, what will be the management beta? If I talk about the surgery, do remember that the surgery for oral cavity cancer beta is going to take a lot of time and a lot of efforts beta. it can actually be minimum beta 8 to 9 hours of surgery also. Okay, and in that condition, what we have to do, we have to remove all the cancerous lesions beta from here. Okay, even if the mandible is involved, we have to do a mandibulectomy also if required. All the lymph nodes which have been involved, we have to remove all the lymph nodes beta. Radical neck dissection is done. Along with that beta, you also have to remove all the muscles, all the vessels that have been involved. Okay, and then please remember to cover this area beta. Now we have to take a flap from this chest muscle beta. Yesterday I've shown you that flap, and that is PMMC flap beta, called as the pectoralis major myocutaneous flap. You take that flap and you cover the part over here beta. Okay, so that is important. This operation which is there beta is actually called as the commandos operation. ये जो surgery होती है beta, this is basically called as the commandos operation beta, or we can even call it as the oromandibular dissection. Okay, we can even call it as the oromandibular dissection. So either you can call it as the commandos operation beta, or we can call it as the oromandibular dissection beta. Clear about? Now important is, if they ask you definitely beta, what will be done? So you have to do a wide local excision of the cancer beta with some normal margins, with or without lymph node dissection. Definitely, as I've told you, radical neck dissection has to be done, and mandibulectomy has to be done beta if it is involved. Okay, and then to cover it beta, we have to place a flap. This is what is the commandos operation or the oromandibular dissection. Flap which is there beta, it is more commonly the PMMC flap. I'm just telling you that is nothing else but the pectoralis major myocutaneous flap, or it can definitely be another one beta called as the deltopectoral flap as well. Another one that you can use beta is known as the deltopectoral flap. So either of these flaps definitely can be used beta to cover the area. Okay. Now, if they ask you beta, what is done for the chemotherapy? Reason is, if lymph nodes are positive, I've told you beta, it is a locally advanced cancer, and you should always give a chemotherapy beta to limit the cancer basically, and to avoid the risk of recurrence. So, so chemotherapy which is there beta, it is given when the lymph nodes are positive. That means when it is a locally advanced cancer. And chemotherapy mein beta, two drugs which are commonly used in the whole GIT beta. Okay, the one drug which is there which is known as cisplatin. Okay, the one drug that we are going to commonly use is cisplatin. The second drug I'm writing is known as 5-fluorouracil beta. Okay, you can write the full form over here. After that, we will only write 5-FU. Okay, so please remember beta, cisplatin and 5-fluorouracil are the two anti-cancer drugs beta that are generally used for the chemotherapy beta in the patient of oral cavity cancer. Next important is radiotherapy. As always, as I've told you, radiotherapy, why it is given? So do remember beta, the radiotherapy is usually given to prevent what? To prevent the risk of recurrence beta. To prevent recurrence, you have to give radiotherapy after the surgery beta. Important is beta, if they ask you that which is the most common prognostic factor used in this patient beta, which is the most common prognostic factor which will tell you about the outcome of the patient beta. So you have to remember the most common prognostic factor which is there, which is going to be the lymph node status of the patient. Okay, the most common prognostic factor that you can use beta is definitely going to be the lymph node status of the patient. Okay, or the stage, you can say. Done with this? No issues with this? Now let's talk about the next one beta, and that is actually a tumor itself beta, but that tumor usually arises from the bone now, and that tumor which arises from the bone beta is known as an ameloblastoma. Yes, that tumor basically is what is known as a ameloblastoma beta. So let's talk about that. So this is basically a tumor beta that is arising from the bone, and this tumor is basically called as an ameloblastoma. Yaad rakhna, ameloblastoma is nothing else but a bony hard mass basically, and the most common site of this you are able to see in the picture itself. Which bone is it? Most common site beta for this ameloblastoma has to be the mandible. Mandible is going to be the most common site for that bony hard mass to develop. Okay, if they ask you about diagnosis, you can definitely do a diagnosis beta with the help of this investigation. What is this investigation, bache? This investigation, as I've told you already, is a OPG. And what was OPG? OPG is nothing else but a orthopantogram. We have discussed this in mandibular fracture, right? So this is a OPG beta or orthopantogram, and on that OPG you are able to see this mass basically beta arising from the bone, right? This is what is a ameloblastoma. Clear hai? Treatment, if they ask you beta, treatment kya karoge? Treatment is nothing else but a wide local excision to be done. Yes, treatment agar puchenge bachche, it is nothing else but a wide local excision to be done in the patient. Wide local excision has to be done. Done with this. Next important beta, here you are able to see in the picture. This has been a similar kind of a picture which has come earlier in the NEET PG examination. This one which is seen beta. Right? This one which is seen over here beta, this is nothing else but a picture of a lip cancer beta. Yes, ये जो दिख रहा है picture में, this is nothing else but a lip cancer which is seen. Okay, याद रखना that lip cancer is also very common beta. याद रखो, lip cancer is also very common. Lip cancer, if I talk about it, is also a squamous cell carcinoma itself बच्चे. And here also the investigation of choice has to be biopsy. Treatment याद रख लेना बेटा. In a patient of lip cancer, if they ask you the treatment, it is nothing else but again a wide local excision to be done. In a treatment of lip cancer, you have to do a wide local excision, that is removal of the cancer with some normal margins beta, plus minus, that is with or without lymph node dissection beta. Okay, plus minus with or without lymph node dissection has to be done. Okay, so lip cancer is also a squamous cell carcinoma. Biopsy is done for diagnosis. Management is a wide local excision with or without lymph node dissection. ठीक है, तो ये पिक्चर्स आते रहते हैं बेटा. दीज, एज आई टोल्ड यू ना, लॉट ऑफ मिसलेनियस क्वेश्चन कीप ऑन कमिंग फ्रॉम दीज टॉपिक्स. बेसिकली कभी भी कोई भी उठ के कोई क्वेश्चन आ जाता है, नॉट इन वेरी डेप्थ, दे जस्ट आस्क यू टू मेक अ डायग्नोसिस, बस इतना ही, या ओनली आस्क यू द ट्रीटमेंट. दिस काइंड ऑफ क्वेश्चंस का. ठीक है, चलो नाउ लेट्स टॉक अबाउट द सलाइवरी ग्लैंड्स बेटा. नाउ इंपॉर्टेंट थिंग्स दैट आई नीड टू डिस्कस अबाउट द सलाइवरी ग्लैंड्स बेटा आर गोइंग टू बी डन विद दिस. ओके, let's talk about the first basics and then we will move further. So if I talk about the salivary glands, बच्चे याद रखना, salivary glands which are there are three main salivary glands, or the three major salivary glands beta. The largest being the parotid gland, the second largest being the submandibular gland, and the third one being the sublingual gland beta. ठीक है, then there are multiple minor salivary glands also. Okay, if I talk about beta, the parotid gland over here, though it is the largest salivary gland beta, it is not responsible for the maximum saliva production. Maximum saliva production is done by the second largest gland known as the submandibular gland, which is present in the floor of mouth or in the submandibular space. Okay. Now important is beta, we know that the submandibular gland opens with the help of a Wharton's duct and the parotid gland opens with the help of a Stenson's duct beta. ठीक है, अब ये जो parotid gland होती है, it actually opens, that parotid duct which is there beta, it opens opposite the first and the second molar beta in the upper half of the oral cavity. Whereas the submandibular duct along with the sublingual duct beta, it actually opens up in the floor of mouth beta. Where do they open? You have to remember beta that the ducts of the submandibular and the sublingual duct beta, they usually open on both the sides of the tongue beta, below the tongue basically. This is what? This is the frenulum. So you are able to see on both the sides of the frenulum beta, the sublingual and the submandibular ducts are going to open. Okay. Now if I talk about the nerve supply, parotid gland has three nerves beta in it basically. Okay, the main three nerves which are there. The first one, the main nerve supply of the parotid gland is given by the glossopharyngeal nerve or your ninth cranial nerve beta. Okay, whereas there is another nerve which gives secretomotor fibers to the parotid gland. अब ये क्या होता है? That means this nerve is going to stimulate the parotid gland beta for the production of saliva. So the secretomotor nerve supply of the parotid gland is given by the auriculotemporal nerve beta. It is actually the branch of the fifth cranial nerve or the mandibular nerve. Okay, that is important. Whereas the third nerve which is related to the parotid gland, it has a relation with parotid gland, like I love you but only as a friend beta. अब ये क्या लॉजिक है? That means the facial nerve or your seventh cranial nerve beta goes inside the parotid gland but does not supply the parotid gland. Clear है? That is important to be remembered. Next important beta, your submandibular and the sublingual gland which are there, they are usually innervated or they usually supplied beta by the lingual nerve beta. We know lingual nerve is actually a branch of the mandibular nerve beta, which is in turn a branch of the fifth cranial nerve बच्चे. ठीक है, so that is important to be remembered. Hopefully this is clear to all of you now. Chalo. So that is the basic anatomy that I have told you until now. Now let's talk about beta. The first condition, what you are able to see, we are actually able to see beta that there is stone inside the floor of mouth, and the stone in the floor of mouth basically is actually arising from the salivary gland itself, right? Either it could be either it could be from the submandibular gland or the sublingual gland. So more commonly it is from the submandibular gland beta. What happens? Understand, we know that submandibular gland is responsible for maximum saliva production. But in case beta, if the submandibular gland basically, okay, will have stasis of secretions over here, and if there is stasis of secretions beta, there can be actually formation of a stone, and that stone formation in the submandibular salivary gland is classically called as sialolithiasis. Lith means stone beta, sialo means salivary. Okay, so please remember sialolithiasis is what? Sialolithiasis is nothing else but stone formation inside the salivary glands. If they ask you that which is the most common site for the stone formation beta, we know the maximum function is done by whom? Submandibular gland. Therefore, the most common site beta for sialolithiasis has to be the submandibular gland beta. Okay, no issues with this anybody. Next important beta, if they ask you which are the more common type of stones, you have to remember beta, the more common type of stones are usually the calcium phosphate or the calcium carbonate stones beta. Okay, so calcium phosphate, calcium carbonate, these are the more common type of stones beta that has to be remembered over here. If they ask you beta, what will be the complaint of the patient beta? What will be the complaint of the patient? The patient will definitely have a lot of pain basically, but that pain beta or the swelling which is there, it is going to worsen when, understand why there is a swelling now. Obviously, if that stone is going to cause blockage beta and the submandibular duct, all the secretions of the saliva are going to retain, or all the secretions of the saliva beta will remain inside the submandibular gland. And if there is too much of retention beta, obviously that submandibular salivary gland will dilate beta, and due to dilatation of the submandibular salivary gland there will be formation of a swelling in the floor of mouth. Okay, now important to be remembered is beta, याद रखना that whenever you eat food beta there will be more saliva production. Yes, but is that saliva able to come out? No, that is the reason beta, the swelling is going to increase rather in size whenever you are going to eat food beta. Okay, and the pain is also going to increase. Okay, so please remember beta, the patient usually has a painful postprandial neck swelling beta, that has to be remembered. Okay, the patient will have a painful postprandial neck swelling. So after you eat the food beta, the pain and the swelling is going to worsen basically, and that is going to last for at least 1 to 2 hours beta. That is going to last for at least 1 to 2 hours. Now important is if they ask you what is the investigation of choice, investigation ke liye beta, you can see this investigation can be done. It is basically a type of x-ray beta of the floor of mouth where you are able to see a stone. This was a previous year NEET PG, NEET PG question where they asked what is the diagnosis. So answer was clear, sialolithiasis beta. Okay, and another exam they asked what is the investigation. So yaad rakhna beta, this kind of x-ray of the salivary gland or the floor of mouth is known as a sialogram. So this x-ray that you are able to see beta is known as a sialogram. Okay, that x-ray is known as a sialogram. Clear to all of you? So please remember beta, the investigation either it can be a sialogram beta, but if they ask you what is a better investigation than a sialogram, right? Obviously sialogram can show you the stones beta, but if it is a very small stone, it may not be seen. So the better investigation is always what? A NCCT beta, right? The better investigation is always a NCCT. But not for parotid stones, because parotid stones are radiolucent beta. I hope all of you are quite aware. Radiolucent means they appear black on X-ray or a CT scan, so it will not be visible. Okay, so parotid stones ke liye ultrasound could be done beta, but usually parotid stones are very rare, so you don't have to worry. Sialogram or NCCT has to be done. If the stone is smaller in size beta, that it is less than 4 mm in size, then I have to go for an endoscopic removal beta, right? If it is less than even 4 mm in size, you may have to go for an endoscopic removal of the stone. But if it is more than 4 mm in size beta, okay, if it is more than 4 mm in size, I can definitely do a open surgical removal biche. We can definitely go for an open surgical removal. Or if you are not able to retract the or if you are not able to retrieve the stone or remove the stone directly beta, then you can first break the stone beta, and after breaking the stone you can remove the fragments biche. And when I'm going to break the stone, that is what is called as a lithotripsy beta. Okay, when I'm going to break the stone, that procedure is known as lithotripsy. Okay, so that is what is done. If they ask you in the floor of mouth surgery beta, we have discussed this already also in the ranula, that which is the most common nerve injured. I've already told you beta, the most common nerve injured in any floor of mouth surgery beta, whichever floor of mouth surgery you do, the most common nerve injured has to be the lingual nerve beta. Okay, and when lingual nerve will get damaged bache, the patient will have loss of sensations in the floor of mouth as well as loss of general sensations from the anterior 2/3 of the tongue. Clear about that is important. So that was about it beta. Now let's talk about the salivary gland tumors. So salivary gland tumors which is there, again a small topic itself. Done with this. So salivary gland tumor, if I talk about beta, is going to be benign and malignant beta. If I talk about the benign and malignant salivary gland tumors now, let's talk about it. The first one which is there beta. If I talk about the benign salivary gland tumor, so please remember beta, the most common benign salivary gland tumor, if they ask you which is the most common benign salivary gland tumor beta, तो क्या याद रखना है, the most common benign salivary gland tumor is going to be a pleomorphic adenoma बच्चे. ठीक है, तो अगर पूछते हैं कि which is the most common benign salivary gland tumor, तो answer has to be a pleomorphic adenoma. We know adenoma means a benign tumor arising from the gland or the columnar epithelium. Pleomorphic basically means multiple, the cells which are there beta, they will be of multiple sizes and multiple shapes basically, right? Different morphology. ठीक है, तो most common benign salivary gland tumor will be pleomorphic adenoma. Next important, if they ask you beta that which is the most common benign salivary gland tumor in children, if they ask you the most common benign salivary gland tumor in children will be a one that arises from the blood vessels beta, and that should be called as a hemangioma. The most common benign salivary gland tumor in a child is going to be a hemangioma. Next important beta, if they ask you that which is going to be the most common malignant salivary gland tumor, तो क्या याद रखना है, the most common malignant salivary gland tumor बच्चे is definitely going to be a mucoepidermoid carcinoma. याद रखना है क्या, it is going to be an mucoepidermoid carcinoma. Right, so mucoepidermoid carcinoma beta is going to be the most common malignancy beta in the salivary gland. And if the patient is having the malignancy known as mucoepidermoid carcinoma in the salivary gland, what is going to be the treatment beta? So यहाँ पे we are actually talking about the treatment of the malignancy beta, not about the benign tumor. So if I talk about the treatment of the malignancy beta, what we have to do, understand, we have to definitely go for a wide local excision beta. That means you may have to remove the salivary gland itself beta, right? We have to do a wide local excision बच्चे. Rather than that, you can write radical parotidectomy. Radical parotidectomy. Why I'm saying parotidectomy beta? Because see, stones were definitely more common in the submandibular gland, but all the parotid tumors, whether it is a benign parotid, but all the salivary gland tumors beta, whether it is a benign salivary gland tumor or a malignant salivary gland tumor, all of them are more common in the parotid gland itself. Okay, so here you have to go for a radical parotidectomy beta. And when I say radical parotidectomy, that means we have to go for a lymph node dissection. Radical parotidectomy means removal of the parotid gland along with the adjacent structures whichever are involved and the lymph nodes beta. Okay, so that is what is done. Now if I talk about beta, the first benign salivary gland tumor that you are able to see, and that benign salivary gland tumor is nothing else but a pleomorphic adenoma बच्चे. Okay, if I talk about the next one, that is known as a pleomorphic adenoma. If I talk about a pleomorphic adenoma, we have discussed that it is basically the most common benign salivary gland tumor. It is the most common benign salivary gland tumor. Okay, it is going to be benign. That's the reason it is going to be a slow growing tumor. And we have already discussed beta that all your salivary gland tumors, they are going to be more commonly seen in which gland? They are more commonly going to be seen in the parotid gland. So does the pleomorphic adenoma beta. It is more common in the parotid gland followed by the submandibular gland. It is more common in the parotid gland followed by the submandibular gland beta. If they ask you what are the risk factors, two important risk factors beta for a pleomorphic adenoma. One is going to be smoking as usual. Second is going to be a previous radiation exposure beta. So smoking and radiation exposure are the two important risk factors for a pleomorphic adenoma to develop. Investigation of choice अगर पूछेंगे बच्चे तो investigation of choice has to be a FNAC. What is FNAC? Fine needle aspiration cytology has to be the investigation of choice for a pleomorphic adenoma. ठीक है, extent देखना है definitely बेटा, तो extent देखना है, तो if you have to see a soft tissue extent बेटा, तो soft tissue में कितना फैला है, then we can go for a MRI बेटा. But if you have to see the bony extension basically, then we have to go for a CT, right? So please remember, soft tissue extension के लिए we do a MRI, bony extension के लिए we have to go for a CT scan. Treatment, if they ask you beta, if they say what is the treatment in the patient, तो याद रखना है treatment में बेटा, we know there are two lobes of the parotid gland beta. There is a superficial lobe which is a major lobe beta. 80% of the parotid is made up of the superficial lobe, and then there is a small lobe beta called as the deep lobe. तो याद रखना है that most of the tumors which are there, they will be only in the superficial lobe of the parotid gland. That's the reason beta, you only have to remove the superficial lobe of the parotid gland, and that is what is going to be called as the superficial parotidectomy bache. Okay, that is what is known as the superficial parotidectomy. Okay, so that has to be remembered. Yes, right, that is important. Now let's talk about the next one beta, the second most common benign tumor of the salivary gland. The second most common benign tumor of the salivary gland beta, if I talk about, is known as the Warden's tumor. Okay, it is known as the Warden's tumor beta. Warden's tumor which is there, it is also known as, I will also write it as, it is also known as adenoma lymphomatosa beta. Adenoma means a benign tumor, lymphomatosa because there are a lot of lymphocytes beta which will be seen inside this tumor. Basically a lot of lymphocytic infiltration is seen. That is the reason we can call it as adenoma lymphomatosa. It is only and only seen in the parotid gland beta. Yes, okay, pleomorphic adenoma was more common in parotid gland, I said, but ये तो बस parotid gland में ही दिखेगा. It is only seen in the parotid gland itself. Okay, I've told you that this Warden's tumor, also known as adenoma lymphomatosa, is the second most common benign tumor beta in the salivary gland. It is the second most common benign tumor of the salivary gland beta. It is only seen in the parotid gland. The risk factors are the same beta, that is smoking and radiation will be the two important risk factors which will be there. Investigation of choice beta, if they ask you, investigation of choice has to be FNSC itself, and on that FNSC, as I've told you, a lot of lymphocytes is going to be seen. A lot of lymphocytes are going to be seen beta. Lymphocytic infiltrate will be seen. Okay, treatment, if they ask you, the same beta, that is nothing else but superficial parotidectomy has to be done. Okay, so you have to go for a superficial parotidectomy. Now more important for us beta is basically to remember what are the complications of the surgery beta. When I say this superficial parotidectomy na, what is actually the complication of the superficial parotidectomy beta, that is actually more important for us to remember. ठीक है, ये जो superficial parotidectomy है, इसका जो complication है ना, shall I? Okay, so let's talk about it beta. Now the complications of the surgery which है, hopefully all of you have written. So complications of surgery, if I talk about beta, is going to be what? So it is nothing else but beta, one is going to be hemorrhage. Any surgical procedure, I've told you beta, bleeding or hemorrhage can be a common complication, and second could be infections. But apart from that beta, injury to the nerves is a very important thing to be remembered over here. Now injury to which nerves is going to be seen? Okay, let's see that one by one. First of all, if I talk about beta, here the injury to the nerves mein beta, the first one is the patient will have drooping of angle of mouth after the surgery. If they say beta, if the patient has drooping of angle of mouth, something like this, okay, the patient has a drooping of angle of mouth after the surgery beta, that is basically due to which nerve injury? So you have to remember beta, the nerve injury is going to be the marginal mandibular nerve. Yes, the marginal mandibular nerve beta is going to be injured if there is drooping of mouth seen. अगर drooping of mouth दिखता है बेटा after the surgery, you have to remember it is due to the marginal mandibular nerve injury. And yaad rakhna that marginal mandibular nerve injury is actually the most common nerve injury happening after a superficial parotidectomy. Okay? The marginal mandibular nerve injury beta is the most common nerve injury to happen after a superficial parotidectomy. Next important bache is anesthesia or angle of jaw. Very common question beta in your examination. It can come also from ENT more commonly. Anesthesia. Anesthesia is what? Loss of sensations beta over the angle of jaw. So if my patient is having loss of sensations or anesthesia over the angle of jaw, how they will say? The patient has undergone a superficial parotidectomy few days back, and now the patient complains that during shaving he is having complete anesthesia or loss of sensations over the angle of jaw or the angle of mandible. This is classically due to which nerve injury during the surgery? To yaad rakhna, anesthesia over the angle of jaw beta is basically due to the greater auricular nerve injury. This area is supplied by the greater auricular nerve. Okay, that is classically going to be due to greater auricular nerve injury. This has also been a previous year question of your exam. Okay, so greater auricular nerve injury definitely beta is important to be remembered. Next important is bache. This would be a question that will be common between surgery and ENT beta. Let's talk about that over here. And what is this? See, Understand first and then we will write the name. तो याद रख लो. For example, बेटा, my patient is having a my patient is having a parotid gland tumor, and therefore we have planned a superficial parotidectomy in the patient. We know that the secretomotor fibers to the parotid gland beta, that is the fibers which are going to stimulate the parotid gland for salivation beta, those are basically from which nerve? The auriculotemporal nerve beta, which is a branch of the mandibular nerve. बराबर है. Auriculotemporal nerve gives secretomotor fibers to the parotid gland. Now what we have done a superficial parotidectomy. But as we have done a superficial parotidectomy beta, can you see during a superficial parotidectomy, by mistake we have injured the auriculotemporal nerve fibers? Yes. And now as these auriculotemporal nerve fibers were damaged, obviously they will start regeneration beta. And as they will start regenerating beta, what happens by mistake? Rather than only supplying the parotid gland over here beta, they go further and they actually supply the skin bit over here. They are actually going to supply the blood vessels on the skin and the sweat glands on the skin as well. ठीक है. अब क्या होगा? We know that whenever you take food beta, this auriculotemporal nerve is stimulated. Whenever you eat food beta, the auriculotemporal nerve of the patient is stimulated. Then it further stimulates the parotid gland beta, and that leads to secretion of saliva. ये normal फंडा था. अब what is going to happen after the problem? See beta, now whenever you will eat food beta, obviously the auriculotemporal nerve will be stimulated. The problem is what? Now the auriculotemporal nerve fibers beta, a lot of them are also supplying the blood vessels and the sweat glands over the skin. So whenever you will eat food, this nerve stimulates, and that's the reason beta, the patient starts having vasodilatation over here beta, and there will be a lot of redness or flushing beta over this area. Apart from this, the sweat glands are stimulated, therefore the patient starts having a lot of sweating over this area beta. So जब भी खाना खाओगे, there will be a lot of redness and sweating beta over the cheek or the temporoparietal region beta. This is classically called as the Fraser syndrome. You might have heard about this. This is classically known as the Fraser syndrome beta. याद रखना ये बात. So when they say sweating and flushing beta, when they say definitely sweating and flushing over the parotid area beta or the parotid region after eating mainly spicy food beta, it is basically due to injury and regeneration of which nerve? It is due to injury and aberrant, that is aberrant is abnormal. Okay, it is due to injury and aberrant regeneration of which nerve? Auriculotemporal nerve. They have asked you about the nerve beta, that has to be remembered. It is due to injury and aberrant regeneration of the auriculotemporal nerve fibers. That is important to be remembered. First thing. Second point to be remembered beta is this condition which is there beta is classically called as which syndrome? So yaad rakhna, this condition is classically known as beta the Fraser syndrome. You might have heard this name. This condition is classically known as the Fraser syndrome. And here Fraser syndrome itself is known as a gustatory sweating beta. This Fraser syndrome is classically called as gustatory sweating also. Clear to all of you? The Fraser syndrome is nothing else but injury to the auriculotemporal nerve, which leads to abnormal regeneration and supplies the sweat glands and the skin. Due to that, whenever you will eat food beta, patient will have sweating and flushing over this area beta. Picture a classical, there is sweating and flushing over this area. Okay, that is classically called as the Fraser syndrome. Clear hai? No issues with this. These are the things to be remembered beta. Nerve injuries are always common or important beta as a topic basically whenever they are actually given as a complication of a surgery. हमेशा याद रखना, जहाँ जहाँ nerve injuries हम लिखेंगे, all of those topics are important. Okay. Want a break? Then definitely we can take a small break and then we can start with the last session after the break. Okay. We will be starting with esophagus. That is a very important topic. Esophagus and stomach are the most important topics of your GIT beta. Okay.